Good morning, everybody. I'm going to call the meeting to order. Okay, good morning, everybody. First order of business this morning is roll call. Thank you, Trent.
Teresa Taylor.
Here.
Lynn Paquin for Malia Cohen.
Here.
Frank Rufino for Fiona Ma.
Present.
Lisa Middleton.
Present.
David Miller.
Here.
Arena Ortega.
Here.
Jose Luis Pacheco.
Present.
Kevin Palki.
Present.
Ramon Rubacava.
Here.
Yvonne Walker.
Here.
Melissa Willett.
Here.
Dr. Gail Willis.
She logged on? Okay. Let me know if she is, because I will have to read her the attestation. Welcome, everybody. Thank you very much. Right now, we're going to recess into closed session for the Chief Executive Officer's briefing on performance, employment, and personnel issues. And we will immediately reconvene in open session after this closed session and start our meeting. So if we could clear the room, thank you very much.
Malia Cohen.
You can just say here.
Present.
Frank Rufino for Fiona Ma.
Present.
Lisa Middleton.
Present.
David Miller.
Here.
Arena Ortega. Jose Luis Pacheco.
Present.
Kevin Palke.
Here.
Yvonne Walker. Melissa Willett. Dr. Gail Willis.
Not excused right now? Okay.
Sorry. Ramon Rubacava. Sorry about that.
All right. Our next order of business, I have asked Mr. Pacheco to lead us in the Pledge of Allegiance. Mr. Pacheco?
I pledge allegiance to the
To the
flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Mr. Pacheco. Slow down, slow down. That was too fast. Thank you, Mr. Pacheco. I appreciate it. So I want to welcome everybody to our annual Board of Administration Education Day. And I especially want to welcome our newest members, Malia Cohen, our new state controller. Thank you. Congratulations. Kevin Palke, representing our school employee members. And Yvonne Walker, representing our retirees and a close associate. We look forward to working with all of you and helping you settle in. I'm going to swear you all in just a few minutes, so we'll call you up over here. But before we launch into today's agenda, I'd like to pause and pay homage to two important national observances, Martin Luther King Jr. Day and the National Day of Racial Healing. These are two events that speak to the ideals we embrace at CalPERS. Yesterday, our nation honored the legacy of Dr. King and his commitment to equal rights and justice for all. His work left an enduring mark on the country and for generations has inspired hope, courage, and a call to action for the work left to be done. But bear in mind, we do still have work to do. 60 years has passed since Dr. King's famous I Have a Dream speech, in which he imagined a day when his children will not be judged by the color of their skin, but by the content of their character. His vision of a nation united by our common humanity is one we still embrace today. So that brings me to the National Day of Racial Healing. It's observed today on January 17th. The purpose is to encourage people to talk about racial relations and how we can all work together to heal our nation's wounds. CalPERS is and always has been about people. As we go about our business to serve our members, who represent one of the most diverse states in the country, we embrace the ideals of racial, financial, and health equity in the work we do through all three of our lines of business: pensions, investments, and health. As a large institutional investor on the world stage, we have an opportunity to use the strength of our size, partnerships, and capital to drive change. And I appreciate the open-minded spirit of this board and the manner in which we conduct business to continue our engagement on these issues. So moving on to our business for today, the annual Board of Education Day allows us to spend some time on important issues we'll be discussing throughout the year. The education is an essential part of our process to enhance the board's knowledge and facilitate sound decision-making in the best interests of our members and employers. At the end of each session, we will take time for public comment. And with that, I'll hand it off to our CEO, Marcy Frost, for her remarks and to preview today's agenda.
Good morning, President Taylor and members of the board. We'd also like to welcome our newest board members, Controller Cohen, Yvonne Walker, representing the retirees, and then Kevin Palke, representing school employees. Earlier this month, I shared a New Year's message with our members and our stakeholders where we acknowledged the challenging economic horizon and highlighting several of the priorities that we have for this coming year. Healthcare and investment sustainability were chief among them and will be the focus for our open session agenda items today. After some preliminary administrative business this morning, we'll begin the day with a healthcare discussion. We have an esteemed panel of presenters who will speak on accountable care policy and their perspectives about Medicare ACO REACH model. We'll have Dr. Elizabeth Fowler, who is the Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation with the Centers for Medicare and Medicaid Services. After lunch, we'll then turn our attention to sustainable investing. Sustainability factors that consider the risks and the opportunities that would be associated with environmental, social, and governance issues have really been part of our investment strategy and approach since 2015. I had an opportunity to go on CNBC Squawk Box last week and really talk about the consistent approach that CalPERS has had for several years now. CalPERS has been a leader in this space, helping drive action through advocacy, through engagement, through partnerships. We can't do this on our own. These partners are extremely important to our work, as well as governance models that integrate sustainability factors across our total portfolio. We do view sustainability through the risk lens to protect the fund against long-term trends that we see coming from climate disruption. We might see trends coming from human capital management practices within the companies where we're invested, and then numerous corporate governance issues, an area where we weigh in quite heavily, whether that's through proxy season or that's through a direct voice with that company. Investment opportunity is another lens by which we can look at sustainability principles. It can help us identify investments that have the potential to deliver those risk-adjusted returns that we need to hit that 6.8 assumed rate of return. We're pleased to have Mark Carney, who is a leader on sustainable finance, join our own CIO, Nicole Musico, in the discussion. They will talk about sustainability trends across the marketplace, and we'll get his perspective on this very important topic. Mr. Carney was instrumental in developing the Task Force on Climate-Related Financial Disclosures, a framework that we use here at CalPERS. We just issued our second report, and you received that update just last year. That will be followed by the board's annual fiduciary training, led by Matt Jacobs and the board's Fiduciary Council, which will assist all of our board members, but in particular our newest board members, to adjust to your new responsibilities on the board. That will complete the open session content for the day, and then we'll convene in closed session thereafter. And then, of course, tomorrow we'll be right back here in the room for our 4th annual stakeholder forum, which we're all looking forward to. And so back to you, President Taylor.
All right. Thank you, Ms. Frost. So it is time now to swear in our newly elected board members. So I'll ask the three of you to join me by the mic over here. Not totally, but yeah, kind of like that. That'll work. So, I state your name.
I, Malia Cohen,
Do solemnly swear
do solemnly swear
that I will support and defend the Constitution of the United States
that I will support and defend the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies, foreign and domestic.
against all enemies, foreign and domestic.
Hold on, guys. I only have one page here. Nope, this is it. Finally, that I will bear true faith and allegiance
True faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of California.
and the Constitution of California.
I take this obligation freely,
I take this obligation freely,
without any mental reservation or secretive evasion,
without any mental reservation or secret evasion,
and will faithfully
and will faithfully
discharge the duties upon which I'm about to enter.
discharge the duties upon which I'm about to enter.
All right, thank you. Congratulations, everyone.
Thank you.
Thank you very much.
Thank you.
Yay, come on. All right, thank you, everyone. So at this point, now we're going to have the election of the president and the vice president. So I'm going to hand the virtual gavel off to Mr. Miller to run the election for the president. I guess we should trade places. Go ahead.
Thank you. I would like to move a motion to elect Teresa Taylor as board president.
Okay, we are entertaining motions for the position of president. We have a nomination from Melissa Willett of Teresa Taylor. Are there any further nominations? Are there any further nominations?
I think we have a couple of, I think we have to get a second, David.
Yes.
Do we have to get a second? Jose?
Yes, I'll second it.
Jose Luis seconds. Okay, so we have a motion and a second. Are there any further nominations? Any further nominations? And finally, a third time, are there any further nominations? Okay, seeing none, we have the one motion on the floor, so we take a vote on that. So the vote now we'll take is for the nomination of Teresa Taylor to be our board president.
Is Gail on? So we can do it by acclamation. Okay. go
Okay? Okay, so calls for the question. So all in favor, say aye. 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 Any opposed? Hearing none. Any abstentions? Okay, the motion passes. Congratulations, President Taylor. And I will hand you back your virtual
Here's the
gavel.
virtual gavel back. All right. So now we're taking nominations for vice president. Mr. Pacheco.
Yes, I would like to nominate Mr. David Miller for vice president of the CalPERS Board of Administration.
All right. Great. Mr. Rubalcava, go ahead.
I will second the nomination.
All right. So we have a motion on the floor and a second. Motion from Mr. Pacheco, second by Mr. Rubalcava to elect David Miller as vice president of the board. Do I have any other nominations? Any other nominations? Any other nominations? Hearing none, we're moving on to the vote then. All those in favor of electing David Miller as president of the board, please say aye. Vice President of the board, please say aye.
It's a subtle.
All those opposed? And any abstentions?
I'll abstain.
All right, Mr. Miller abstains. Thank you very much. That does it. Mr. Miller, you have been elected Vice President of the board. Congratulations.
Yep. Thank you.
Can we have about a couple of minutes to move everybody around now?
Yeah,
Sorry.
Appreciate everybody's support. Thank you.
So we're just taking a quick 2-3 minute break. All right. I want to thank everybody again for your support for myself as president, and hope that we can all work together this year collaboratively and move program as we need to move program. So thank you very much. Moving on is our next item, order of business, is proposed decisions. You've got that, of administrative law judge.
Yep.
Okay, and I'm going to hand that off to Mr. Miller.
Okay, I move to adopt the proposed decision. Not quite.
You are not on? Hold on. I don't, oh, there it is. It's way at the bottom. That's weird. It's not working.
There we go. Okay. I move to adopt the proposed decisions at agenda items 1 through 14 as the board's own decisions with the minor modifications argued by staff to agenda items 2, 6, 7, 11, and 14. And I'm looking for a second.
We don't need a
we don't
second.
need-
On motion, are there any objections, any discussion? Hearing none. All those in favor? All those opposed? Any abstentions? Hearing none, motion passes. Is there another one? Is that it?
Is it?
That was it. All right. So then we move on to board travel approvals, which I have to add to that. And that is what's on your diligent board book. I'm adding, and everybody should have this in their packet, Melissa Willett for Washington, D.C. for CalPERS, and Frank Ruffino for D.C. in March for CII Spring Conference. And I need a motion on the...
So moved.
Okay, so it's been moved by Mr. Miller, seconded by Mr. Pacheco, so to approve the board travel. And if there's any discussion, I want to just check. Okay, seeing no discussion, all those in favor?
Aye.
All those opposed? Hearing none, any abstentions? All right, motion passes. I really should do this. There we go. Right, at this point, we are on salary range adjustment for the chief health and chief actuary, chief health director, chief actuary, chief financial officer, and general counsel. And these increases would be effective July 1 of, this says 2022. Do we mean 2023? 2022 for the current year. Oh, they're retroactive. Ms. Frost, did you want to? Okay. Oh, there you are. I'm sorry.
Good morning, Ms. Taylor. Congratulations on your election. Mr. Vice President, Mr. Miller, congratulations as well.
All right, Ms. Tucker, thank you. Go ahead.
Thank you. Good morning, members of the board. Michelle Tucker, CalPERS team member. During the board's compensation workshop in November 2022, the board provided direction to the Human Resources team to return with an action item addressing the potential for compensation range adjustments for the chief actuary, chief health director, chief financial officer, and general counsel classifications. The base pay ranges for these 4 classifications have not been adjusted for several years. Today's item presents an option to apply a 4% increase to the maximum of these 4 classifications. This option is consistent with the maximum base pay increase awarded in the board's compensation program during the year-end process for fiscal year 21-22. So thank you, members of the board. That concludes my remarks, but I'm happy to answer any questions. And Ms. Taylor, it would be retroactive to July 1st, 2022 to answer your question.
Okay. I just thought there might have been a typo.
Yeah.
Mr. Pacheco, thank you.
Yes, thank you very much, and congratulations, President Taylor, again. And again, thank you, Ms. Tucker, for this, for your presentation. Just want to know, when was the last time these were adjusted?
It varies based on the classification, but some of them were adjusted in 2019. The chief actuary has not been adjusted since 2008. So it does vary a little bit depending on the particular classification.
And is this 4%? Is it pretty much with the norm around or with our other peers, like say CalPERS and so forth? Or?
So, CalPERS has a different compensation model, but for these particular 4 individuals or for the 4 positions, they've been at maximum pay for a while. So if approved, they would receive pay increases commensurate with their ratings for the end-of-year appraisals that Ms. Ross concluded. So most of the other comparator groups do provide regular compensation reviews. So in that sense, yes, it would be consistent with other peer organizations.
Excellent. Thank you very much.
Mr. Rubalcava.
Yes, thank you. And again, congratulations,
Thank you.
Madam President. Thank you for the report, Ms. Tucker. And as you stated, and as your report stated, these 4 individuals are at maximum. And these are 4 of our, key executive staff. And I think the adjustment is very appropriate and necessary.
All right, thank you very much. So I also will voice how necessary I think this is. We have some excellent talent in each of these positions, and I want to make sure that they're appropriately compensated. So I too am very much for this, and maybe visiting something else down the road so that we don't run into this maximum cap that we keep running into.
And we do have the full compensation item for statutory positions coming to you in February, so that'll be
Great.
an opportunity to look at that more closely.
Perfect, I appreciate it. Mr. Miller?
If the chair would entertain a motion, I would make that motion to adjust the salary ranges for the chief health director, chief financial officer, and general counsel positions as recommended or outlined by staff.
Motion's been made by Mr. Miller.
I'll second.
Seconded by Mr. Pacheco. Looks like we already had our discussion. Hearing nothing else. All those in favor?
Aye.
All those opposed? Any abstentions? Motion carries. That was very quick. Thank you, Ms. Tucker.
Thank you.
So we are now a little bit early. Do we want to wait? Or is everyone here? Because we're like 15 minutes early. We're okay to move forward. Okay, so I do want to move forward then to our Medicare accountable care policy and addressing our perspectives about the ACO REACH model. So give us a moment while everybody comes up to speak. Is Don, are you introducing folks?
So, Madam President, we have one speaker who is en route from the train station.
So we're kind of,
He's not the first speaker.
Okay.
We could start and have him join, or we could wait. It's your prerogative.
oh no, we can, if he's not the first speaker, let's move ahead then. I don't think so. Don, does he need to hear the other presentations by any chance? Is it necessary?
If you see the slides, I think yeah, he's here in the next. Yeah, he should be here by the time he speaks.
So you're okay?
Give him 5 minutes and see what happens.
I'm okay. Okay, you guys, let's just take a 5-minute break and let's make sure everybody can get here. If you've got to take time for yourselves, we'll be back at 10:15. Thank you. I have been advised our other panelists will be here shortly. So I'm going to go ahead and start with our first panelist, who, if I'm doing this, oh, there you go.
Hi, good morning, board members. Lamena Tefera from the clinical policy team. Happy to introduce panelists today discussing the ACO REACH program. Our first panelist is Elizabeth Fowler from the Innovation Center at the Centers for Medicare and Medicaid Services. Dr. Fowler has had a long career in public service, working as counsel in the days of writing the Medicare Modernization Act and developing the Part D program that Medicare beneficiaries are very grateful for. Also helped write the Affordable Care Act and helped implement it as a senior advisor to President Obama. currently serves as the director of the Innovation Center, where she oversees a $10 billion budget looking for methods to improve process of care for our Medicare beneficiaries across the country. We are very pleased to have her speak today.
Can you scoot a little closer to the mic? I'm being told
Sure.
people in the back can't hear you. I'm sorry.
No problem. We're very pleased to welcome Dr. Fowler today to speak about accountable care organizations and strategic thinking at CMS regarding management of Medicare beneficiaries in the future years. Dr. Fowler, welcome.
Oops. Is that on? Yep. Thank you. Before starting, I just want to thank the CalPERS board for inviting us to join today's board meeting. CMS is committed to better care and better health outcomes for Medicare and Medicaid beneficiaries. I'm joined here today by my colleague, Pauline Lappin, who leads the Seamless Care Models group that has implemented this model as well as other models that we have. We really appreciate your interest in learning more about the work that we're doing, and specifically more about ACO REACH that started on January 1st. Let's see, now I push it over here, right?
Yep.
Okay. So I was going to start today's discussion with a brief introduction to the Innovation Center. For those of you who aren't familiar, talk a little bit about our strategy and how accountable care fits into that strategy, and then provide an overview of our ACO initiatives at CMS and a deeper dive into ACO REACH. And after that, I look forward to hearing from the two experts on the panel and to the discussion with the board. So for those of you who aren't familiar with the CMS Innovation Center, it was established in 2010 as part of the Affordable Care Act, and our goal is to test new approaches to care delivery and payment in Medicare and Medicaid to improve the quality of care, hopefully bend the cost curve of health spending, and so we either consider it success if we improve quality while we keep costs neutral, or we reduce costs but don't harm quality, or best case scenario, we both improve quality and reduce cost. We are essentially the research and demonstration arm for CMS, the agency that runs Medicare and Medicaid. And as Don Berwick, a former CMS administrator and foremost expert on delivery system reform, described the Innovation Center, we are to the U.S. health system what the NIH is to biomedical research. So on a tactical level, this means that we can, for example, change the way that Medicare pays for services and then evaluate whether that change met our goals outlined on the slide. So our models have focused on improving care for people with certain conditions or diseases like end-stage renal disease and cancer. Sometimes we have models that focus on specific types of healthcare providers like primary care practitioners or providers working together like in an ACO. We have region or state-specific models like the Maryland Total Cost of Care model, and then we also test models within Medicare Advantage and the Part D prescription drug program. These are time-limited tests, really designed to improve care. Most of our models last for 5 years. Sometimes we consider extending them, but most of them are, well, they're all time-limited in duration. So in 2021, we released a white paper outlining the strategy for the next decade. Our vision is a health system that achieves equitable outcomes through high-quality, affordable, person-centered care. And in the white paper, we described 5 strategic objectives that guide our work under the new strategy. The first is driving accountable care that promotes the delivery of whole-person integrated care. For beneficiaries in traditional Medicare who aren't part of Medicare Advantage plans, we want them to have that integrated, coordinated care and patient navigation that leads to better outcomes and improved quality. And so we set a goal for every Medicare beneficiary and the vast majority of Medicaid beneficiaries to be in an accountable care relationship where a provider, for example, in an advanced primary care practice or in an ACO, is responsible for their care and their quality. Second, we're focused on advancing health equity. I think we all see that the pandemic illuminated the vast disparities that exist in our system, and we've committed to embedding health equity into all aspects of our model, from design to evaluation. That means enrolling more safety net organizations and rural providers that care for underserved populations. It includes collecting data, focusing on social drivers of health, and making sure that the benefits of improved care and better quality extend to all beneficiaries. Third, we're focused on supporting innovation that enables all of what we want to see, this person-centered integrated care. And to achieve this vision, we know that providers need tools, data, resources, and flexibilities to deliver care that's consistent with people's goals and preferences. Fourth, we're focused on affordability by addressing healthcare prices and reducing duplicative or unnecessary care. Our statute directs us to focus on program spending, but we remain, and of course, committed to that goal. But we also want to address affordability for people and patients and beneficiaries. For example, our Part D senior savings model tested the idea of $35 capped insulin per month for beneficiaries. And that provision ended up in the Inflation Reduction Act and is now available to all beneficiaries. So that's our best outcome, is when we can test models that then become permanent part of the program. And then finally, we need to really focus on partnering to achieve system transformation. Medicare can't make changes alone. We really need to partner with other payers, with patients, providers, and purchasers in the system. And quite frankly, that's part of why we're here, because we see CalPERS as a really important partner in a lot of what we're trying to do. And so we're very excited about the opportunity to tell you more about what we're working on. And then also, we timed the launch of some data and information today to coincide with this meeting that we just posted on, so I'll share some of that as well. CMS's vision for accountable care. So advanced primary care and ACO models are really an important part of achieving our vision. And so along with this vision is a set of principles that apply to all of our models that we test in traditional Medicare, including accountable care and advanced primary care models. And this is, first, beneficiaries retain all rights in traditional Medicare. That includes the freedom to choose any provider. Second, as I mentioned, we're committed to promoting and advancing health equity. And then along with that is really aiming to expand the reach of our models in underserved communities. We firmly believe that our vision for a better healthcare system through primary care and accountable care will improve patient care and experience. In Medicare, if you are a beneficiary and you don't want to sign up for a Medicare Advantage plan, we want to make sure there's a place to go for these set of services and coordinated care that exist in traditional Medicare, and hopefully, in some cases, can also lower cost sharing and address social determinants of health. So as part of our strategy and inherent in our strategic objectives is really a commitment to incorporating patient voices and engaging with beneficiaries so we can better understand their preferences, what they want to get out of their care, and enable a closer relationship between primary care providers and patients. So a little bit about what is an ACO. So getting each step a little deeper into the conversation, and that brings us to what is an ACO? What is an accountable care organization? Navigating the health system can be complex and difficult for anyone. I know that's the case with my own parents, but particularly for beneficiaries with multiple chronic conditions that receive care from many different providers in different settings and in different specialties. Over the last 20 years, fragmentation in healthcare for Medicare beneficiaries has increased exponentially. Between 2000 and 2019, the percentage of beneficiaries seeing 5 or more physicians annually increased from 17 to 30%. Even more startling, we've seen an 83% increase in the number of specialists that a primary care provider needs to coordinate with on behalf of their patients. This means a Medicare beneficiary could have multiple providers, receive duplicative and unnecessary tests and services with potential out-of-pocket implications for each service, and no single provider who's coordinating that care or accountable for the quality of care provided. Today's fee-for-service payment systems in traditional Medicare don't provide the mechanisms or the means to facilitate care coordination. In fact, sometimes they work against care coordination, and that's where ACOs can play a role. In an ACO, physicians and other healthcare providers join together to take responsibility for quality and the care of their patients and the total cost of that care. These responsibilities encourage providers to coordinate services across clinical and care settings, and the ACOs that are successful in meeting quality standards and savings share a percentage of those savings with the Medicare program. The rationale for ACOs in short, is to improve the healthcare experience for beneficiaries, for the delivery system for providers, and for the Medicare program by reforming the fee-for-service, volume-based incentives that have underpinned care delivery for more than half a century. ACOs in the Medicare Shared Savings Program, which is CMS's permanent ACO program, which operates in traditional Medicare, consistently generates saving for Medicare, estimated at approximately $6 billion over the last 5 years. It's a fraction of total Medicare spending, but it's an important start. And we know that they're successful in, they perform better in patient experience and performance measures compared to physician groups participating in what we call the merit-based incentive program, or the fee-for-service program called MIPS. Just to give a little bit of an example, because we start to talk about technical issues, but really our North Star is really improving care for beneficiaries. So I wanted to share an example from an ACO in our model, what care can look like for Medicare beneficiaries in an ACO. And so the beneficiary featured on this slide is a 90-year-old homebound patient with multiple chronic conditions who required assistance for activities of daily living. He was experiencing increased depression and anxiety with insomnia, poor appetite, and shortness of breath. His care strategy under the ACO included in-person home visits, telemedicine visits, quick phone visits by 2 providers and a community health worker. Together, they addressed his reluctance to take depression medication and therapy, including helping him find a language concordant therapist, as well as hearing aid batteries and help with SSI benefits. The outcome for this patient was the avoidance of emergency department visits through a more intensive home monitoring and support, which was achieved by building trust with the beneficiary to address his underlying conditions. All Medicare beneficiaries should receive this type of patient-centered coordinated care that's focused on their needs and on getting them well and staying well. We know that this is what the type of care that's more likely to happen through an advanced primary care or an ACO. At the Innovation Center, we've been working across the agency with different parts of CMS to make sure that we have a shared vision for ACOs, and that creates a synergy between the Medicare Shared Savings Program, which, as I mentioned, is the permanent part of Medicare, and in traditional Medicare, and the Innovation Center models. This translates to an aligned ACO vision that includes using the Shared Savings Program as a chassis for innovation and for our model tests. And we've been testing these models for over a decade. The Pioneer ACO model was the first Innovation Center model certified by the CMS Chief Actuary as demonstrating savings to Medicare while also improving quality. And as a result of these outcomes, that model was incorporated into a higher risk track of the Medicare Shared Savings Program. Our second model test, the ACO investment model, demonstrated that upfront payments can support the formation of ACOs in rural and underserved areas. And that model became a permanent part of the Medicare Shared Savings Program announced last year and will start next year. And then finally, the next generation ACO model has also informed the Shared Savings Program. Beneficiaries in the next gen model reported high satisfaction with their access to care, communication with their doctor, and ability to engage in decision-making with their healthcare provider. Next gen ACOs invested in data analytic capabilities to better support providers and more proactively addressing health needs. So as I mentioned, we made an announcement earlier today. CMS announced the 2023 participation information for the Shared Savings Program and the ACO REACH program. And it was a little bit of a heavy lift to try to get this out before this meeting, as you can imagine, getting through the agency, but we wanted to make sure we could share the information with you. So over 13.2 million beneficiaries in traditional Medicare will be served by over 700,000 healthcare providers and organizations. We announced that 2.1 million beneficiaries are part of ACO REACH. This is an increase of about 300,000 patients from what it was last year, where it was 1.8 million who were part of the model in 2022. We received 271 applications for ACO REACH this year. Out of those, we provisionally accepted 128. That's less than 50%. It's a much lower proportion than any other model that the Innovation Center has tested. And of the 128, some withdrew, others didn't meet the additional requirements. And so of those 271, we entered into agreements with 48 new organizations for 2023. And 84 of the 99% participants in 2022 remain part of the model. What we're really proud of is out of the participating providers, we've seen an increase in the number of safety net providers. So 824 providers in the program are part of a safety net organization. This includes federally qualified health clinics, rural health centers, and critical access hospitals. It's more than double the number in 2022. In terms of California, for 2023, 27 of the 132 ACOs in the model are providing services to beneficiaries in California. And of note, 7 organizations that participated in California last year are not participating in 2023. And I think that brings us to the heart of today's discussion, which is on ACO REACH. ACO REACH is the 3rd generation of an ACO model tested by the Innovation Center. We made changes to what was previously called the Global and Professional Direct Contracting Model, or GPDC, to advance priorities of the Biden-Harris administration, including our commitment to health equity and in response to stakeholder feedback and participant experience. And again, this version of the model started on January 1st of this year. Organizations that were part of GPDC who had a strong compliance record were able to transition into the new ACO REACH model, but only if they were able to meet new requirements in the model, which I'll describe on the next slide. Like the Medicare Shared Savings Program, beneficiaries are aligned to an ACO based on their relationship with their healthcare provider, their primary care provider, who signed up to join an ACO. In the ACO REACH program, we also allowed beneficiaries to join by attesting either electronically on Medicare.gov or through a paper-based process with the REACH ACO that a provider who is part of their ACO is their source of primary care. And consistent with the accountable care principles I referenced earlier, beneficiaries in ACOs remain in traditional Medicare and retain all of their rights, coverage, and benefits, including the freedom to see any Medicare provider. The ACO REACH model, like its predecessor ACOs, prohibits limited networks, prohibits prior authorization, or any other means of restricting what care a Medicare provider can deliver. Beneficiaries are not required to participate in any of the care coordination or other activities offered by the REACH ACO or any of the models. They can opt out by having CMS. They can opt out of having CMS share their data, their claims data, with a REACH ACO or any ACO that, for that matter, for care coordination quality improvement initiatives by contacting 1-800-MEDICARE. A little bit more detail on the changes we made to GPDC when it transitioned to the new ACO REACH model, and 3 areas to highlight. First, we put a much greater focus on healthcare equity and attracting providers who care for underserved beneficiaries. And I'll describe the health equity policy shortly, but we're pleased that we've more than doubled the number of safety net organizations participating, as I mentioned. Second, we increased the requirement for healthcare providers and patient advocates to play a more direct role in governance and care delivery model. We required that at least 75% control of each REACH ACO's governing body must be held by participating providers or their designated representatives, compared to 25% in the GPDC model. And we also required that at least one beneficiary representative and one consumer advocate, that's 2 different people, must sit on the governing board and have voting rights. And then third, we adopted an enhanced screening of applicants into ACO REACH, and we've publicly committed to conducting more robust monitoring of participants and greater transparency into the model's progress for the remaining 3 years of the program. For example, we've been sharing quarterly financial and quality performance data for GPDC, and we'll continue doing that for ACO REACH. We also this year posted more information about ownership of participating ACOs, and that you can see on the website today. We expect that beneficiaries whose primary care provider is part of a REACH ACO will experience improvements in care, and the quality of care will improve because of the ACO REACH model. For example, they may receive increased access to telehealth, they may receive home visits after leaving the hospital, In some cases, they receive cost-sharing support to help with copays or other enhanced services or incentives. And several ACOs are also providing nutritional support for food insecurity, transportation, and in some cases, helping to coordinate dental care. It's these flexibilities and tools that we can build in and provide some of the same benefits to traditional Medicare beneficiaries that we see happening on the Medicare Advantage side. Moreover, the new health equity provisions introduced in 2023 will provide greater access for underserved communities. I'll talk a little bit more about those in a moment. So we know there have been questions about the financial arrangements and incentives that are part of ACO REACH, and this slide provides an overview of the model options that are part of the program. ACO REACH offers two options, professional and global, and both options have the same ACO structure where ACOs contract with participant providers and preferred providers for participation in the model. The professional option offers 50% shared savings or losses with CMS. The global option offers 100% risk for shared savings or losses with a discount to ensure that Medicare recognizes some of these savings. The global risk track is the highest level of risk sharing that we have tested and provides incentives for providers to be successful, not just in reducing costs, but improving quality, as the model includes financing incentives based on quality performance. Capitation or prepayment for ACOs for primary care services and select other services allows providers to make long-term investments in care and enables providers to focus on their patients' health needs that are not directly reimbursed by the program. For example, as I mentioned, transportation, nutrition, remote patient monitoring, hiring social workers, and data analytics. This financial arrangement is sometimes confused with capitation as it's applied to MA and in HMOs. This is not the same thing. We posted earlier today the percent of total spending that is provided on a prepaid basis. In 2021, 2.5% of total spending was on a prepaid basis for services provided to beneficiaries who are part of the program in 2021. In 2022, for the first 3 quarters, an estimated 2.7% of total spending was prepaid. The rest of the payments for services flowed through Medicare fee-for-service payment systems, just like it does for the rest of the program. And I think this point is really worth emphasizing. Providers in a REACH ACO, just as in GPDC, are required to submit all fee-for-service claims to their usual Medicare Administrative Contractor, or MAC, for all services, including those subject to prepayment. This means we have full visibility into utilization for primary care, specialty care, inpatient, and post-acute care. This allows CMS to monitor for unusual patterns of care, including potential stinting. And so I want to make this distinction. This is really in contrast to Medicare Advantage, where CMS pays MA plans a capitated rate that covers 100% of the total cost of care, and MA plans assume responsibility for contracting with a provider network and adjudicating and paying all claims that those providers bill to the plan. And that's why we're talking about the difference between the two of them, which is really important. We keep seeing this quote that organizations in REACH are keeping 40% of payments. That is not the case. An MLR, or medical loss ratio, does not apply to ACO REACH because it is not paid based on capitation. It is paid based on the same fee-for-service system that we use to pay others, just with these other incentives. We have estimated that approximately 98% of spending goes towards medical care and health services. So what's the value proposition of ACO REACH for Medicare providers? The financing mechanism in ACO REACH gives these organizations and their healthcare providers a greater ability to align incentives so that providers are directly rewarded for managing patient care and patient health and improving care. It allows them to build partnerships in order to provide coordinated and team-based care that's commonly achieved through investments in technology platforms and data analytics. And then there's lower administrative burden by providing administrative functions for providers. Prospective population-based payments offers a more predictable cash flow and are of interest to providers, and this finding was driven home during the COVID-19 public health emergency. In my personal experience, having visited a number of these organizations, This approach to payment allows these providers, these primary care providers, to get off the hamster wheel of trying to see 25 patients every day and then filling out paperwork to make sure that they get paid. It allows them to really focus on the patients who need care the most and care for the people that, in a way that patients want to be cared for. I've heard providers tell me, this is why I went into medicine, to practice this sort of care. So I want to share the story of one REACH ACO to illustrate these opportunities further. Two healthcare providers in Washington, D.C. formed what's an organization called Blue Rock after reading about the model. They were attracted to the model because of the ability it provided to deliver needed care to patients in Southeast D.C. in a primary care professional shortage area with a high percentage of dually eligible beneficiaries and extremely high rates of diabetes. The prospective payment mechanisms of the model enabled them to deliver home-based care to their patients, to isolated seniors in the height of the pandemic, and better engage caregivers. With high beneficiary engagement, including telehealth, Blue Rock demonstrated improvements in glucose control for diabetic patients within 90 days. They saw a reduction in those with poor control from 27% to 9%, and they increased the proportion of patients with good control from 54% to 73%. Just a little bit about risk adjustment, because we hear a lot about risk adjustment lately. I think you probably all know about risk adjustment as CalPERS, but I'll just go into a little bit of basics. Risk adjustment is used to estimate the cost to treat a patient in a given year based on the patient's specific health needs. Risk adjustment is a way to make sure that doctors and other providers are paid fairly for the people they treat. Providers get paid more for patients who have more health problems than for healthy patients who may not need as many services. In an ideal world, it levels the playing field by recognizing that not all patients are the same, so providers are able to treat patients with different care needs and not just healthier, less costly patients. Of course, the reason risk adjustment has been an area of focus lately is because some organizations are better at identifying and coding patients' health needs, which leads to higher payments. The better an organization or an MA plan is at coding, the higher their payments. One of CMS's goals in ACO REACH was to set a fair and accurate payment system, and risk adjustment is a fundamental part of that goal. If left unchecked, coding intensity can lead to two different challenges. First, it can lead to overpayments resulting from different coding, differential coding patterns. And then second, excessive investment in coding intensity activities. So plans spend more time and energy trying to do coding than they do at directing and coordinating care for patients. In the ACO REACH program, we have tried to address this issue by establishing risk adjustment guardrails designed to protect both the Medicare Trust Fund and beneficiaries. These guardrails mean that risk adjustment is budget neutral at the model level and intentionally constrained at the ACO individual organization level. And we accomplish this through a mechanism called the coding intensity factor, or CIF, and also through a risk score cap. At the population level, risk scores are normalized every year to control for changes over time in the average risk score of the entire Medicare fee-for-service population. This ensures that ACO REACH plans are not overpaid by a model calibrated based on past Medicare fee-for-service beneficiaries. It's also helpful to note that the way that we in which risk scores are normalized and the coding intensity factor are applied in ACO REACH is distinct from the manner it's applied in Medicare Advantage. Medicare Advantage does not have a plan-level risk score cap in the way that ACO REACH does. Furthermore, we are monitoring risk score growth in ACO REACH to identify any unusual patterns or trends that might suggest inappropriate coding behaviors. In other words, we're testing these strategies, and if they work, perhaps they can be adopted in other parts of the Medicare program. So I mentioned earlier that ACO REACH incorporates a focus on health equity, and I want to take a few minutes and talk about the 5 specific policies that are part of this model and our efforts at advancing health equity and reducing health disparities. The first is a requirement that all participating ACOs develop and implement a health equity plan that started this year in 2023 to identify underserved patients within their beneficiary population and then implement initiatives to measurably reduce health disparities. we worked with the CMS Office of Minority Health to develop templates and guidance for this requirement, which we expect to include in other models. For example, our Enhancing Oncology model, which starts in July this year, also will have a requirement for a new health equity plan. So REACH ACOs must update this plan annually and report back to CMS on their progress in implementing their health equity plan and achieving health equity goals. And second, we know that participants in CMS prior ACO initiatives serve a beneficiary population that's less underserved than the general Medicare population. To address this dynamic, we included a beneficiary level payment adjustment, the first we have ever tested, that will increase the payment benchmark for ACOs in the REACH program that are serving a higher proportion of underserved beneficiaries. The upward payment adjustment is offset by a smaller downward adjustment to the benchmark for ACOs that serve a lower portion of underserved beneficiaries. Just a little bit more detail on how this works. It's really a first-of-the-kind adjustment. We've never tried this before, and the goal is really to make up for historical underinvestment in underserved areas. And so we are stratifying aligned beneficiaries within ACO REACH using a composite measure of underservice. The composite measure is based on a combination of area-level and beneficiary-level measures to account for both beneficiary-specific factors and local measures of deprivation that may influence access and provider resourcing. So we're using the University of Wisconsin's Area Deprivation Index to measure local socioeconomic factors as a well-respected measure that is highly granular with data at the census block group level. And then for the beneficiary level measure, we're using dual Medicaid status, either full or partial dual status. And we've assigned points to each of these variables in constructing this composite measure, as shown on the slide. So once we've calculated a score for each beneficiary, we stratify them, and the top decile organizations receive a $30 per member per month payment adjustment, and the bottom decile receives a minus $6 per member per month downward adjustment. You might ask, are these the right measures to measure underservedness? Is this the right differential in payment? I can't answer those questions, but again, that's why we're testing it, to see if it works, and if so, perhaps consider it in other parts of the program. The three additional health equity policies in ACO REACH include self-reported demographic data collection to make sure that we're supporting the delivery of comprehensive person-centered care. We're requiring organizations to collect and report certain beneficiary-reported demographic data and social drivers of health data. ACO REACH beneficiaries will also have access to expanded nurse practitioners and physician assistant services. That means nurse practitioners and physician assistants can furnish certain services without physician supervision, which we think is more efficient and will lead to increased access to services. And lastly, as we selected participants, we attached points to application questions where organizations demonstrated experience with direct patient care and/or providing high-quality care to underserved communities. So our intent was really to bring ACOs into the model that shared the same goals and visions as CMS to improve care for our beneficiaries. As I said earlier, beneficiaries in ACO REACH remain in traditional Medicare and retain all of their rights, coverage, and benefits, including the freedom to see any Medicare provider. And REACH beneficiaries may receive additional benefits to improve the quality and experience of their care. Benefits and incentives that are not provided under traditional Medicare that these plans are providing include telehealth services, waiver of the homebound requirement, so beneficiaries can get home health, additional benefits and visits following discharge from the hospital, concurrent care for beneficiaries that elect hospice, so they can continue to receive curative care, cost-sharing support, and, as I mentioned, services to address social determinants of health. Beneficiaries receive annual notifications that their physicians are in an ACO, and we welcome your feedback on improving these communications with beneficiaries. And finally, we make sure that beneficiaries have all rights, retain all rights in traditional Medicare for raising concerns with their care and reporting any complaints. This slide provides greater detail on how we're conducting monitoring and compliance in the program. The productions are in addition to the enhanced screening of applicants for the program. The application process required additional information on ownership, leadership, and governance. We've received some criticism about the role of private equity backed organizations in the plan. My personal opinion, you can't say that private equity is inherently bad or good, but the way that we viewed it, we want to make sure that the organizations in our program are in it for the right reasons. So we looked at their background and their experience. Do they have experience in healthcare? Does their leadership have experience in healthcare? And then we have these monitoring, a comprehensive set of vetting, monitoring, auditing, and analytic activities aimed at protecting beneficiaries, healthcare providers, and the models, our ability to evaluate the model. So that was a long way of explaining the program and a lot of detail, and I really appreciate your patience in learning more about the program. I want to end formal remarks with another story about another beneficiary that's served by an ACO model participant, because the beneficiaries, again, are our North Star. A 69-year-old African-American beneficiary in an Innovation Center ACO had multiple chronic conditions, diabetes and heart failure, and multiple visits to the emergency department. Like the previous beneficiary example, his care included monthly in-home visits with a nurse practitioner and a social worker. He was given a scale to monitor weight and encouragement to manage chronic conditions. He received post-discharge home visits, a model benefit enhancement, and cost-sharing support to help him adhere to to care and to manage chronic conditions. It resulted in better engagement with his primary care provider, improved management of chronic conditions, and more appropriate use of the emergency department. The beneficiary has testified to us, "Thank you, this program has saved my life." Thank you for the opportunity to speak with you and be here today, and for those of you interested in our work and how we can partner together to improve quality and experience for beneficiaries, please visit our website and sign up for more information. Thank you.
Thank you, Dr. Fowler. I'm sure the board's going to have a bunch of questions, and I don't want to go on to the next one because there was so much information in your presentation. I'm not seeing anybody yet, but I'm going to start off with, there's a lot of information here, so what I kind of want to narrow it down to is this is a pilot program. There's not a lot of people in it right now. What's the intent of the program finalized?
So the program runs until 2026. We have no plans to open up another application period. So the numbers that I showed you earlier are the numbers of organizations. There will not be any more than 132 organizations in the model,
okay,
and most likely no more than 2.1 million beneficiaries in the model. If we see that some of these aspects of the program work, we might look into incorporating them into, for example, the MSSP, the Shared Savings Program. There's a lot of interest among primary care providers in looking at primary care prepayment or capitation. We're very interested to see how the health equity benchmark adjustment plays out, if it really does reduce disparities. So if those aspects work, we can incorporate them back into the main part of the program.
Okay, so it's not actually something that's going to take over for Medicare. It's a pilot program that you are using to test certain things to see if they'll work so that you can incorporate it into our traditional Medicare. Is that correct?
Yes, correct.
Okay. So I'm a little curious, my next question, I'm sorry, about fragmentation in care, right? So we see that all over in terms of healthcare in general, right? So, and I like the idea. I've seen your, I think it was 3 different models with 3 different people that you were talking about. I think this whole person care is a great idea. How do we ensure that's actually happening? So we only have the limited amount of people in this program. If this were to be successful, how do you see that implemented within Medicare?
Well, so the ACO, the Medicare Shared Savings Program is the permanent ACO program that has, 11 million beneficiaries? And so we're testing aspects that could be incorporated into that main part of the program. For our models, I think we probably spend more time digging under the numbers and making sure that no one's getting stinted on care, that we're seeing the better outcomes that we're looking for, that we're seeing the lower costs. I think there's probably more eyes on this as a model or a demonstration. But if these things work, then we look at incorporating them. But our goal, again, is to see all beneficiaries have some sort of patient-centered care like we see happening in either advanced primary care or in an ACO. I don't know if my colleague wants to add anything.
Sure, I would add that the shared savings program, thank you. The shared
It's still
savings-
not on. I think it might be over on the other side of you. Oh, there it is. It's on.
Great. The shared savings program also has monitoring strategies, and they also have people in the field working in the CMS regional offices. We refer to them as our ACO regional office coordinators. And so they are the eyes and the ears on the ground of what's actually happening with beneficiaries in the different regions of the country that are being served by ACOs. And so there's a lot of engagement just nationally with ACOs in terms of learning and also monitoring what they are doing for beneficiaries.
Okay, so it is actually, it takes a little bit of extra people in general.
Yeah. So that, because this is in traditional Medicare, it is subject to all the same rules, and we have our Center for Program Integrity reviewing all the claims and any issues that come up, just like they would for any other Medicare program or, benefit. But we also layer on additional monitoring. So there is monitoring that goes on in the shared savings program as a Medicare program, but within our model tests, we also have monitoring.
Okay, that's pretty awesome. And this is for people that only have Medicare Part A and B. Is that it? The
Traditional Medicare and
Yes,
Medicare Part
correct.
A and B.
Okay, so if you have an extra insurance, then would the cost savings and stuff eventually go over anyway? Because I think Medicare always becomes your primary after a certain age, right? And then that extra insurance just covers the extra costs. So we don't want to pass those costs on to another
No.
insurer either, so.
I understand what you're asking. If people with supplemental benefits, for example, from a former employer, are they going to get stuck with those extra costs? And that's not true. We think this reduce overall costs,
Okay.
total cost of care, so everybody eventually gets to save. It's less about cost shifting and sort of bringing the whole
All the costs down. Okay,
Yeah.
and then the reason I'm asking is because we all, as retirees, will get, or our current retirees, have insurance, right?
Yep.
Extra insurance on top of our Medicare. So I just don't want that shifted to that insurance, and then you're paying more out of
Right.
pocket elsewhere.
Right. That would be a bad outcome.
That would be a bad outcome, yes. And I think my last thing was just to highlight, you had talked about the private equity in your healthcare robust monitoring and compliance. I guess the applications of these people that want to participate, these are private equity firms that already own healthcare. Is that what you're saying?
We looked very closely to make sure that any applicant, who's on their board, who are their investors, who are their owners, who are they enrolling in terms of providers. We want to make sure they're in it to be in healthcare because they're interested in healthcare and not because they're real estate investors who see an opportunity or something to jump in. So we really looked very carefully at years of experience, specifically at whether or not they had experience caring for underserved populations. Were they an organization that had focused on caring for underserved beneficiaries? I don't know if there's anything to add, but it was we rejected more than 50% of the applicants. We've never done that in an innovation center model before. Part of it was because of a lot of the criticism and the questions that we were getting, and we wanted to make sure we could say we think that these organizations are in it for the right reasons.
In it for the healthcare reasons, not in it to make a profit out of the healthcare.
Exactly.
Anything else you wanted to add?
I would just say it was really a two-stage application review. So there was the review against the application criteria that asked about their care delivery strategies, their financial mechanisms, anything related to just, their background experience in healthcare. But then, as Liz was sharing, we did like a program integrity screening where they had to fill out a very complicated table about ownership, leadership, and governance board members so that we could actually look back into some of the information that I think others have found, through different resources. Actually, it's the same resources CMS uses through the Center for Program Integrity to look in the background of some of these organizations and some of their key people that they were bringing into the
So that you can make sure they actually were there in healthcare and not just.
Right.
And the governance structure was appropriate.
Yep. Now, we didn't tell them why they did, if they didn't make it into the program, we didn't tell them why.
Right,
We
right.
had some questions. One organization said, I didn't make it into the program, and, we didn't tell them that, but they had a board member who was excluded from providing care under Medicare. So we don't want.
That's bad.
Yeah. So we looked pretty carefully.
Okay. All right, thank you. I do have other board members, and then we will have no, we won't. I'm sorry. Then we'll move on to the next presenters. Mr. Rubalcaba.
Thank you, Madam President. Ms. Fowler, that was a very good presentation. I think we have to thank our stakeholders for asking these questions that made this panel happen, so I appreciate that. But it also it's clear to me that it's a pretty complex situation. And the more I hear your presentation and read literature, I understand that there seems to be a lot of overlap where there's criticism. Well, let me just go back. One thing you made clear in your presentation and your PowerPoints is that this ACO REACH is clearly within the traditional Medicare service, which means fee for service. And yet the goal is to have better outcomes to coordinated care, and that, which is a good thing. And yet, I noticed in the monitoring, one thing you're checking for is that prevent shifting into Medicare Advantage plans, which is a different model. And I know a lot of the literature that's critical of the ACO REACH is because there's, like what they say is risk scoring gaming, which I think is more, which is actually, I guess, a problem on the Advantage plans. But perhaps we could have some more discussion about that at some other point about the how the supplement plans work versus the Advantage plans. That would be helpful, I think. But back to the REACH, you mentioned that there were some imposing the new program REACH based on some past practices and stakeholder comments and what have you, implement some risk adjustment guardrails. And you laid out a couple of them, but I guess in one of them was this. A lot of it is basically how about this whole thing about coding, the risk scores. And there's, I guess, two views of looking at it. One is the more codes you find, the more you can get revenue. But on the other hand, we hope the goal is to identify the condition, the acuity of the patient, of the beneficiary, and address that. Is there anything in your monitoring you wanted outcomes? How do you monitor that the scoring, the risk score is used in a way that ensures better outcomes, that the care is taken care of, if there's comorbidities or something, as opposed to just driving up the revenue side?
Well, as I mentioned, we have both a cap on the individual organizations, and then we have a cap on the whole program to ensure that the coding intensity is not going to grow. To be honest with you, one of the things that we're hearing from a lot of the plans, and particularly those that are trying to go into underserved areas that have been historically underfunded, is that they are finding a lot of beneficiaries with unmet need, and now they're capped in terms of how much we can pay them because of the cap. So in some ways, we might have gone too far in capping and potentially inhibited their ability to provide some of those overall care. It's sort of a balancing act. I think we want to make sure that we're not seeing that people are in this program for the coding and the growth for just for the payment's sake, but we also want to make sure that if they're going into these areas and these neighborhoods and taking care of these beneficiaries, that they're appropriately compensated. We hope that maybe we're learning something that could be applied to other parts of the program. For example, the Medicare Shared Savings Program, which is the ACO program that Medicare runs, or to maybe even to Medicare Advantage. I don't know if you want to add anything.
I think you answered that, really well. We do have organizations that are better coders than others, and so you have to always look back at, history of coding, and that's one of the issues people are concerned about is, are we appropriately identifying and accrediting organizations with the right risk score based on their patient population. One thing we can do is we can look at the utilization of services, so we can monitor the risk scores and how they're growing and compare it to what we're seeing in our claims, because we see everything at CMS. So we have very comprehensive analytic tools that we can use to actually see, do these risk scores actually coincide with the diagnoses and the services that these beneficiaries are getting? How do they compare with each other? This is an analytic strategy that we're going to be incorporating into ACO REACH. We can also look from year to year to see if we're seeing anybody who really is an outlier, that their risk scores are just super high compared to everybody else, and we can employ, or even super low. We want to see what's going on there too. But we'd want to be able to employ techniques to actually look at those organizations a little bit more, and we've actually identified a few organizations that we're going to be doing that with.
We can also see if beneficiaries move from traditional Medicare to Medicare Advantage, so we're following that as well. Basically, considering that this is the research and demonstration arm, we're looking under the hood at a lot of these data a lot more than maybe other parts of Medicare, and we consider that part of the model and the testing process.
Yeah, I want to follow up on that comment you made, because that was one of how I started, how you're looking at one of the monitoring things is whether or not they're being shifted into or out of an Advantage plan. So tell me, why is that? Is that because you want to keep a population you can study, or is that because you think you want to guard against the providers or is that because there might be an financial incentive somebody to move a particular beneficiary to a more managed group, I guess?
So there's no question that the payments are much more generous under Medicare Advantage than they are under this program. There's no question. And so what we want to make sure is that they're not purposely being moved. For example, you see a provider, and that provider is also participating in a Medicare Advantage plan, and they sort of convince beneficiaries, we might be better off, over here, or that they're, they receive marketing material. We just want to make sure that beneficiaries are where they want to be, and that they're not being encouraged to go somewhere else where maybe it's advantageous to the organization but not to the beneficiary. So that's why we're looking at that movement.
I keep reading that this year or recently the population enrollment in the traditional Medicare has actually slipped, and it's now more people are now in the Advantage plans.
That's right.
So is that a concern for this pilot, or is this something that you want to ensure that this, because there seem to be contradicting things. One thing, you want coordination to get better health outcomes, but yet it's a fee-for-service program that that people seem to appreciate and want to protect. So I'm just trying to understand, is this an approach to give people free choice, which I guess people that enter in traditional want to have that free choice, but yet you want to ensure that it's not wasted dollars, right? Is that you want to have basically a healthy population as best as we can once you identify who they are. Is that?
We're not making judgments on either Medicare Advantage or traditional Medicare, but we want beneficiaries to make choices based on what's available to them. Medicare Advantage is a growing part of the program. It's already 50% and expected to grow. And we want to make sure that beneficiaries, that if you want to stay in traditional Medicare, you don't want to be subject to prior authorization or a narrow network, that there's a viable place for you. And that's why we're making sure that these opportunities for extra benefits, for lower cost sharing, are available to beneficiaries in traditional Medicare, and you don't have to leave traditional Medicare in order to get those benefits. That's the whole point of what we're testing. So I think we're not making judgments. We are, this is the Innovation Center. We're talking about maybe doing more research in the Medicare Advantage area. For example, maybe, if just because they're getting capitation doesn't mean they're paying based on value to their providers. So we're thinking about looking up under the hood to see what sort of arrangements that are there. Could they be doing a better job at care coordination under Medicare Advantage as well? That's sort of on our future agenda and on our radar for future research.
Okay, on this redesigned ACO REACH model that just kicked off, you mentioned there's going to be lower administration costs. Can you explain how that's going to happen?
So you probably are the payment person. I'm going to turn to you.
The providers who are in ACO REACH still submit their claims to CMS. I think what we're hoping for is that they are able to get some support from the ACO, because the ACO will help them understand the data that they have on their beneficiaries, on their patients, and know where their high-risk patients are who might need more care management services. Right now, a busy practice, it's really hard for them to be proactive with their patients. They're in reaction mode under traditional Medicare. And so being part of an ACO helps to lower some of those administrative costs to a practice, because the ACO can take on some of that support for them that the practice doesn't have to do themselves. And we've heard this when we've met and gone on site visits and met with the physicians, how valuable that has been for them, because it really helps them to better know their patients and also know how to triage their resources as a practice. And even in some cases, the ACO is hiring nurse practitioners and training them, and then the practice can actually use those nurse practitioners to help support the care delivery for their patients.
I'll give you one solid example of a physician we met with in New Jersey in the fall last year. He was saying he didn't know when his patients went into the hospital. Nobody's telling him when his patients go into the hospital. It's not like the hospital notifies him necessarily. But now he's part of an ACO. They have a lot of that. They know when patients go into the hospital, these nurse practitioners that are monitoring for the sort of, I guess, the high costs and high users who need that extra care, and they can let them know, hey, your patient's in the hospital. You might want to go help with discharge planning, with home care after a hospital visit. It also allows them to focus on those patients rather than the sort of coding and billing that comes along with trying to run a physician practice.
Thank you. One of the big components of the new relaunch or redesign, I think is the term to use, is this what you presented at the end, the health equity plan. And it's got very admirable goals. Very admirable goals, the health equity plan. So how soon before you can start reporting out some of your findings, how well it's succeeding in its goals? I know it's just starting.
It's just starting. So I would say, we'll be getting the plans now. They're due, I think, in March to us to take a look at. And then probably, I would say, in a year, we'll get more information about how they're going and meeting goals from the monitoring information that we get. But we won't have anything to report in 2023. We'll be able to share some of the strategies and some of the initiatives that they're planning for their populations, but we won't have outcomes yet.
Thank you. I'm looking forward.
To actually run the interventions.
No, I said I'm looking forward to hearing more how things develop as we go forward. Thank you.
Thank you, Mr. Root. We'll call Mr. Pacheco. You're up next.
Yes. Thank you. Thank you very much. Thank you, Madam President Taylor, and thank you, Dr. Filler, for your presentation. So my first question is basically back to the beginning of how this Innovation Center started with the statute and so forth. And I just want to ask you kind of a basic question about, you mentioned there are other statutory prerequisites that need to be considered in addition to the 3 criteria that you've already mentioned with the quality improvements and neutrality. What are those other statutory requirements? I'm just trying to understand that, or are those already been laid out?
I'll try to do the best I can, and I actually worked on the legislation when I was with the U.S. Senate on drafting the ACA, and the reason that we put the Innovation Center as part of the ACA was because we looked out for ideas like, what ideas are there and that we could incorporate into Medicare, and we didn't really see a lot. And so this was really that testing ground. The Innovation Center has pretty broad authority in Medicare. We can waive almost any requirement or regulation that stands in the way of coordinating care in Medicare. We have less authority in Medicaid, so there's very limited authority in Medicaid. We work with our the other part of Medicaid, Medicare, CMS that runs the Medicaid program when we do anything in Medicaid. We can look at providing benefits that may not be necessarily covered. We can look at for example, waive the 3-day prior stay for SNF care, for skilled nursing care. We can waive the homebound requirement for home visits. We can pay for services, for example, the physician assistants and the nurse practitioners that wouldn't otherwise be paid if we think there's a good reason and that there's a valid reason to test some of that. I don't know if any other examples, but in terms of the restrictions, our success is really determined by whether we're reducing costs and/or improving quality. Those are the sort of two areas. We think that advancing health equity and addressing health disparities is a fundamental part of improving quality. So we've sort of interpreted that as part of our mission as well.
Thank you very much for that question. So as a follow-up with that, how would you elaborate on the health equity component? I know you've just started, but I want to understand a little bit more and kind of build on what Mr. Rubalcaba had said. I just want to kind of get your feel for that, if you can give me.
Well, so we came in as the new administration in 2021, and one of my first questions is, there's a lot of focus on health equity. It's an important part of the Biden-Harris agenda. And so, okay, our models that we've done 54 models. What have we done in health disparities? And it turned out we either weren't collecting data, so we didn't even have data on race and ethnicity, or we didn't really have a focus on whether or not providers were serving underserved populations or whether they were safety nets. So we didn't even have the data to be able to say, yes, we're reducing disparities or not. So I think the data collection is one part of it. So starting with that. And then second, all the way to the evaluation. We didn't know whether we were making a difference for different populations. So we've committed to collecting data in all of our models, incorporating elements like the health equity plan, this new payment adjustment in the benchmark to test whether we can really go after these populations that have been historically underfunded for decades, for generations, and see if that can make a difference. And then in the evaluation, when we come out and we evaluate the models, did we actually make a difference in reducing disparities in some of the quality metrics? Are we seeing the same improvements across populations, or is there a variation? So I think we hired Dr. Dora Hughes is our Chief Medical Officer. She's a national expert in health equity. She's leading our efforts and making sure that we're connected with the Office of Minority Health, that whatever we're doing is connected with what the rest of the agency is doing. We don't want to do it in a vacuum. We want to make sure that we're doing things in the same way as the rest of the agency. We also are focusing on social determinants of health, which I think is a really important component. And the Innovation Center ran a model called the Accountable Health Communities model that looked at, it gave providers the ability to connect patients to community-based resources for food, transportation, housing, and helped make those referrals for social determinants of health. We're building in those aspects too. So now we're requiring providers to screen for social determinants. Are people food insecure? Mm-hmm. Do they need transportation? Do they need housing? We had examples even in the GPDC now REACH model where they needed dental care, but they couldn't find a dental provider. The ACO actually found them a dentist who would help deliver care to address whatever their dental needs were. So I think we feel like this is really the approach that can help coordinate that, sort of wrap around a person and their needs and make sure that their needs are being met.
Thank you very much. I have two more questions. Thank you for that. That's very good understanding of the health equity. The next question I have is on kind of the ACO model itself, and kind of back to the basics of it. You mentioned in your comments that ACO are basically groups of doctors, hospitals, and other healthcare providers who come together voluntarily and to provide, a coordinated, high-quality care for the Medicare patients. And you also mentioned that it's not an insurance plan. So can you again elaborate on what kind of organization is it? Because I'm still a little. I want to understand the whole concept of how that works, because is there a contractual bound process, or I'm just trying to understand that.
Sure. So it's not, they don't take insurance risk. They're groups of hospitals and physicians. They sign a contract essentially with us, with CMS, that they're going to care for patients in there that are aligned to them. So these patients that have been seeing them and we know who they are by virtue of their claims data. And we set targets for quality improvement and potential savings. If they are able to improve quality and reduce costs, they get to share in some of those savings. That's different than a capitated managed care arrangement where you give somebody just a per member per month, like we're going to give you $150 or whatever the number is for that patient for that month, and whatever care they need is within that. Under this model, they still submit claims. They can go see any other provider that they want to. It's just that there's somebody helping them navigate. If that makes sense. I'm probably not doing a very good job of this, and you could do better.
In ACOs, basically what we're saying is the providers come together voluntarily to be paid differently by the Medicare program. And they volunteer to work together, and the ACOs go out and they recruit the providers who they want to work with. So they identify those providers who work together with them. We signed an agreement with the ACO, but there are the requirements that are part of the agreement are also, the providers are subject to those requirements too. So they have to also receive that participation agreement that we have with the ACO, because the providers are subject to those same requirements that the ACO is.
I see that. And you mentioned just right now a comment about patient nav. Is it similar to patient navigation? Or I'm just trying to understand the
Depends on how you define patient navigation. As somebody who worked, and I worked in Medicare demonstrations before we had an innovation center, and we did some patient navigation demonstrations back then. But the ACOs will do some navigation. They will hire these care coordinators. Sometimes the care coordinator is a nurse.
Yes.
Sometimes it's a physician assistant. Sometimes it's a social worker or some other kind of allied physician, non-physician provider to help the patient navigate the healthcare system. So these examples that Liz just shared about these different beneficiaries who were really complex, they really benefited by having a social worker helping them navigate so that they would not have to keep going to the emergency room for everything, that they would actually create a better relationship with their primary care provider and know when to seek care from the primary care provider.
I see.
And also learn how to manage their own health by getting a scale, for example, so that they would actually be doing some remote patient monitoring with that nurse and social worker for CHF, for example.
You would hope that your provider would spend time with you and help you manage your diabetes as a regular course of treatment, but that doesn't always happen. And so this is making sure you sort of have those wraparound services, and that somebody is actually taking time with you to explain your care, what you could do to improve your care, to manage your conditions. I think that's the idea.
And that's where I'm gathering. That's where the nurse practitioner, physician assistant services benefit enhancement is. That's the part of it that's going to help in that process.
It will help because in the Medicare payment rules today, physicians have to do certain things. This will allow nurse practitioners and physician assistants who, by state practice acts, are allowed to provide those services, but under Medicare payment rules, they're not allowed to. So what we do is now we give them that flexibility to be able to actually provide some of those things, like certification for diabetic shoes, which had to be done by a physician.
Under
now
Medicare,
a nurse practitioner can do it, or a physician assistant can do it.
And right now, currently, with the physicians that you're working with now and the entire ecosystem, is it being well received? I'm just kind of, or have you just, what are your impressions?
So the benefit enhancements that we've been, in the model, the prior 2 years, they've been using the most, and even from before this model, the 3-day skilled nursing facility waiver that allows a beneficiary to go from the hospital to a skilled nursing facility without having to be hospitalized for 3 days has been very well received. It's commonly used in the shared savings program. We also know that the beneficiaries really like more home-based care, and in the next generation ACO model and in our current model, we allowed for care management home visits for beneficiaries who were at high risk of being hospitalized to prevent hospitalization. And we also allowed for additional post-discharge home visits, more than the Medicare program allows in terms of the number of post-discharge home visits. And the theory of action is that if you can take care of the beneficiary at home, you can help prevent them going into the hospital, which is much more costly to the Medicare program.
I see.
And better for the patient in the long run.
Thank you very much. I have one more question. So you had mentioned at the very end about private equity, and you had mentioned that you had, I think, 50% of the people that came in, of the organization that came in, you rejected them. What was your due diligence process in evaluating these? I mean, was there a way to, were you looking at the general partners? I mean, you mentioned some of the board members and so forth, but I wanted to understand your process of how you went about that.
So I'm going to turn it over to Pauline because her team was the one that did the screening. But just let me say that we had, so the global and professional direct contracting, those contracts were essentially signed before I arrived. So the program was already operating, and we got a lot of criticism, like too many Medicare Advantage plans, too much private equity. We're worried about the organizations. Those participants were already part of the program. We did another request for application, so we opened up an application period, and this is where we got the 271 applicants to start this year. So I want to make a distinction between some of the organizations that were already part of the program and some of the ones that went through this screening, because there's a difference. The screening process that we went through that Pauline's team conducted was quite extensive, and maybe you can answer that question, but I wanted to make that distinction.
Yeah, so as I mentioned before, there were two parts to it. There was the application review where they described a narrative all about their experience, their care delivery strategies, and then there was this whole program integrity review where they had to, and if you look at the request for applications that's available online, you can actually see we asked them for very specific information about ownership, leadership, and governance board members. And so we were able to actually work with the Center for Program Integrity and other resources that we have to screen those organizations or people, listed, and make a determination about whether we thought they were a risk in terms of partnering with us. And that resulted in us, denying more than 50% of the applications that we received. I also want to note that we continue to monitor the current participants who are in the model. We terminated, I shouldn't say how many we terminated. We terminated some withdrew between each year of the model, and we do this based on our own, reconnaissance or analytics monitoring of organizations and their compliance with the model.
So when you're evaluating these individuals, these private equity, you're looking at the general partners. You're trying to understand if they are what they say they are. They're focused on the health programs and so forth, and that's the ones you want to go for. You don't want to go for the ones that are focused on, like you said earlier, real estate or something like that. I want to be clear on that.
Yeah, we had some complaints that some of these organizations were backed by investors who knew nothing about healthcare. They're in real estate, for example. So we looked very carefully at who are the owners, who are the investors, who's on their board, and then the sort of the providers as well, and screened all of them. We looked for program integrity. Did they have past violations of Medicare fraud or abuse? Did they have previous experience in healthcare or not? Were they actually healthcare investors, or are they, others who may have had an interest in the program? So we really tried to look under the hood and very carefully evaluate who was coming into the program.
Okay. Thank you very much. Thank you.
Thank you. Controller Cohen?
Thank you. Let's see. Good afternoon. Good morning. I really appreciate your thoughtful and thorough presentation to the entire team. Just a couple questions, two to be exact. I don't know if I missed it in all of that detail that you gave, but I want to go back to the ACO. Do patients have the ability to opt out of an ACO?
They can stop providing their data. So you get a letter. So every year in our organization, as a beneficiary that sees a provider who's part of an ACO REACH plan, you get a letter and it says your physician is part of an ACO. You retain all the rights of traditional Medicare. You can see any provider. If you are not interested in providing, you can call 1-800-Medicare. If you call 1-800-Medicare and you say, I don't want my data to be shared, so they have no record of which physicians you see, which hospitals you go to, the services you're receiving. They don't receive the data for the patients that have called 1-800-Medicare and asked to.
And the reason that data is important is so that the providers can actually coordinate the services.
Okay.
And so that's why they get the data. And this is also done in the shared savings program. But these beneficiaries are seeing their existing physicians, right? They are aligned through existing relationships that they already have with their physicians. So that is the point here, is that the physician has decided to be paid a different way and has volunteered to be part of an ACO.
So the short answer is yes, the patients have the ability to opt out, and they can call an 800 number.
Yes.
Or a letter.
Yeah, for data sharing.
For data sharing. Okay. Second question really goes back to kind of the notes that I have reviewed about concern about private equity firms, and you touched on it in your presentation. Will the requirement for majority provider ownership of direct contracting entities prevent sales to private equity firms?
So
they can do, there are changes in control that happen. I mean, this happens in healthcare every day. But they have to tell us about it, and we have to decide whether we want to continue to work with them.
So the answer is no.
The answer is that they have to notify us, and then we determine whether we want to continue the organization, continue the relationship with them in the model. We might say, we don't want to work with you anymore. We have
But
the
then
right-
you also might say, we do want to continue
Right.
to work with you.
It just depends on what the risk looks like.
Okay, so based on the risk and a risk analysis, you determine that decision.
But
So-
they are required by contract to let us know if there's a change in ownership.
Okay, so then I'm going to interpret that the answer is no to the original, a short, succinct answer, yes or no. I know you gave nuances, but I just want to know.
I mean, I'm not sure it's a yes or no. It
depends.
It depends.
It depends. Okay, thank you. Thank you. That's it.
Ms. Walker.
Thank you, and good morning. Appreciate the presentation, and my fellow board members, because a lot of my questions got answered before I could even ask them. One area that I wanted, how do you get patient feedback? Like, so they're in the program, how are you getting their feedback, and how often do you get it?
So there's a few things that we're doing. One is there's a patient experience survey that we do every year. And it's done all over our programs. It's called the Consumer Assessment of Health Plan System Satisfaction, CAPS. So it's a survey around patient experience of care. And we get some information from that survey, and we use that survey for quality measurement. We also have beneficiary representatives and consumer advocates that sit on governance boards of ACOs, and they are able to provide feedback directly and have voting rights on the ACO and their decision-making. We also talk with beneficiary organizations. So we've been having regular meetings, probably, quarterly, with different national beneficiary advocacy organizations. And they have been asking questions and providing feedback to us. In fact, we have a meeting with them later this week. And then the fourth thing I would say is when we go and do site visits, we ask to talk to beneficiaries. So we have to see beneficiaries when we go to a site visit. And sometimes they bring the representative from the board and patients, or sometimes they just bring patients, but we ask to actually talk to some of the patients who are being served. And then our evaluation contractor, this is the fifth point, is doing a survey of beneficiaries who are being served by the ACOs. So we have a few different ways that we're collecting information about the beneficiary experience.
I think maybe just adding one more, in the same way that we're looking at embedding equity into everything we're doing, we're also trying to figure out how to embed a patient voice in everything we're doing. We held a couple of listening sessions and webinars trying to figure out what the best way was to incorporate patient voices in our programs. We've made a public commitment that we're going to include patient-reported outcome measures as part of the quality metrics in all of our models going forward. So we're at the early stages of doing that, but that's another sort of angle where we're really trying to make sure we are tapping into that patient perspective.
Thank you. Thank you. And then on the health equity, so, and I understand that this is a new process, a new program, and it's going to be a while before the data can match up with what you think the outcomes are going to be. How long do you think that is, give or take?
So I'm hoping that we can, provide information as we see it. So, I mean, we have to look at their plans, We have to look at the interventions that they're doing and actually see what's coming in from the interventions. Every year, we have to be, they're going to be required to monitor this with us. They have to report the data to us. So hopefully, we'll be able to share that information based on their health equity plan at some point next year, because they're going to be starting their interventions this year. And maybe, we'll be able to do that in some way, for the, each year after. But it's a time-limited model, so it's going to end at some point.
Right.
And we know that sometimes interventions can take some time for them to get started, but hopefully we'll be able to see some traction and some good outcomes from these interventions.
And then I guess maybe I didn't ask the question right. So as I think about health equity, so maybe I should define that, right? As I think about health equity, it is like looking at where are there places where, people don't have the same access to care. And so how are you going to determine, right, that this is increasing access to care, say for people in rural communities or outside the urban centers where, a lot of insurances don't provide coverage or the full scope of coverage. And so how do you determine that it has gotten better? Access to care has gotten better because of this? Or do you, or is that one of the metrics?
I think the easiest and earliest indication is we put out data on who's coming into the program this year, and we more than doubled the number of safety net providers. That includes FQHCs, rural health clinics, and community access hospitals. Critical access hospitals, sorry. So it was 400 last year, and now we know that it's more than 800 this year. So I think that's at least one measure we have an indication. Whether or not the health equity, the bump in payment of $30 per member per month makes a difference, I think that's another aspect, just like the health equity plans, where we're going to have to see whether that makes a difference. There's a lot of historical underfunding. Is that going to make up for that, disparity in that short of a time? Probably not, but at least we'll get some indication. How did they use the extra dollars? Did it actually, did we see that disparate health outcome measure get better for some populations versus another? We can look at whether or not they were receiving the adjustment versus plans that weren't, and see if that actually did make a difference.
Right, because we can actually see all their claims. So for the beneficiaries who will be getting the bump up, we'll be able to see, okay, what did those ACOs and their providers do? Do we see this translating into them getting more primary care services, for example?
And we can compare it to previous. So right. Are they now seeing the doctor more than they did before they entered the model? Are they seeing specialists at a higher rate than they did before?
Yeah. And what kinds of services? I mean, because we don't want people crashing into the hospital at the last minute. We want them to actually get, more proactive care. So I think that's some of what we'll be able to see that through the claims.
Thank you.
Thank you, Ms. Walker. Mr. Rufino.
Thank you, Madam President, and thank you, Dr. Fuller, for your presentation and for being here this morning on this very complex issue. Rich entities need to protect and maximize profits for their investors. So in order to maximize profits, these entities must spend less on patient care. Also, private equity and not-for-profit insurers often prioritize profits over care. So I'm not sure how to tell which entities are bad actors, but how can CMS protect retirees from bad actors since these entities are very different from each other?
Well, I guess having worked in health policy for almost 30 years now, I would say it's really hard to draw lines in black and white and say these are the good guys and those are the bad guys. What we want to make sure is that patients are getting the care that they need, that somebody's not stinting on their care. Where there's an opportunity to keep somebody out of the hospital or keep them from going to the emergency department, we consider that a win. And so that's why we're monitoring quality and outcomes for these models. Are they going to the emergency room less? Are they controlling their diabetes? Are they controlling other chronic conditions that prevents them from needing to go to the hospital, those are good outcomes that we see as positive for patients. And those are the sorts of quality measures that we're looking at for these models. And just to go back to a personal visit, met with an organization and a beneficiary that was part of a model in Nevada, and they were saying this patient, who was 90 years old, and I was there, met with her, said, I was in the hospital 9 times last year. I went to the emergency department 9 times. My daughter is here as my caregiver. She had to take time off of work every time I went to the hospital. And she said to me, I haven't been in the emergency room since April 2021, since joining this model, because now somebody comes to my house, they measure my blood pressure, they taught me how to measure my diabetes, they coordinate with my daughter. They arrange doctor visits so she doesn't have to take time off work to do it. It's that sort of patient-centered care. So it's not stinting on care. It's not savings because they're not getting care. It's savings because they don't see the emergency room as often, or they don't stay in the hospital as often. And I think we think that is a good thing. Of course, if somebody needs to go to the hospital, they should be there. But we think there are ways of doing a better job by patients. And my parents live in Nevada, and I was just thinking that I wanted my parents to be part of that organization, because I think that they were, the beneficiary I met with was getting the sort of care that I would want for my own parents.
Thank you for that clarification. Thank you, Madam President.
Thank you, Mr. Rufino. Ms. Middleton?
All right, thank you. Thank you for what was a really good presentation. I'm going to preface a couple of questions, because most of my questions have been asked already, by saying that from 1994 to 2004, I was in charge of workers' compensation claims and health care delivery for California's largest workers' compensation provider. And I'm well aware of the differences in the health care delivery systems. But that decade left me with a lifetime belief in the understanding of just how many opportunities exist in the fee-for-service system for fraud, for abuse, and for healthcare delivery that is completely non-productive when it comes to actually improving outcomes. With that, for participants in this program, the actual patients, is it their physician who's choosing to participate in the program and they just get pulled into the system because their physician is in, or does an individual have an opportunity to say, I want to be a part of this program?
So most beneficiaries are aligned because their physicians have raised their hands to be part of this.
All right.
And that's how the beneficiaries come in. And in Medicare today, in the Medicare.gov website, there's also, for any Medicare beneficiary that wants to do this, an opportunity for them to notify CMS of who their usual provider is. That is another way that beneficiaries come in. They attest that a certain provider is providing them services. And so the primary way, though, is through that relationship they have with their existing physician who has joined the initiative. The other way is that they go into Medicare.gov, they select, Dr. Lappin as their usual source of care, and Dr. Lappin happens to be part of an ACO. And then in ACO Reach, the ACO Reach also has an opportunity for a beneficiary, because not every beneficiary goes into Medicare.gov, to do it via paper and to attest that that physician is their usual source of care.
So I want to follow up on the question that Controller Cohen asked. If I understood the answer, if an individual is participating and they are being treated by a doctor who's participating in this program, and they don't want to participate, their data can be essentially hidden. That's right. But in order for them to not participate in an ACO program at all, would they need to change physicians?
So if their physician is part of the ACO, then they are aligned to the ACO. They don't have to do any of the services that the ACO provides. They can just, if the doctor says, I want this nurse practitioner to go to your house because you can't come see me, or you were in the hospital and I want to give you more post-discharge, the beneficiary can say no. But they would, if they don't want to be part of the ACO and their physician has decided they want to be part of the ACO and they want to be paid this way, then the beneficiary would then need to find another physician. But, you know, these are beneficiaries who've had long-standing relationships with physicians. And if they're not going to have their coverage changed, and they can still have the access to see any provider they want, then, you know, hopefully what they're experiencing is a better form of care delivery than not being, their physician not being part of the ACO.
Right. Are there healthcare conditions for which ACO programs are more appropriate, or are there healthcare conditions for which you would not want an individual to be in an ACO program?
That's a really interesting question. We have a kidney care focused ACO model testing for beneficiaries with end-stage renal disease and stages 4 and 5 chronic kidney disease. And there is an ACO-like strategy for that segmented population of the Medicare beneficiaries. But in general, we think that there are benefits for beneficiaries with a variety of conditions, because we know that beneficiaries tend to have more than one, more than two, more than 3 chronic conditions, and having the coordinated strategy that the ACOs can offer is beneficial for them.
So last question. We have many, many decades of experience with capitated healthcare delivery systems, and those that have been most successful have very strong internal controls and culture around quality of care and ensuring that patients come first. So how are you approaching making sure that new participants into these programs are going to adapt the kinds of controls and culture that's necessary to make capitation work?
So this is prepayment, even though we've, I think, used the word capitation when we've described the payment mechanisms. It's not true capitation, as Liz mentioned. But in terms of the metrics that we're using, we do have quality metrics that we're using. We also have ongoing monitoring, and we also, conduct site visits and monitor the claims data for these organizations.
But as part of their application, they had to explain what their care delivery strategy was. Tell us about that culture. Tell us about what sort of tools and resources you're using to make care better. So they had to explain this to us as part of the application process.
Thank you.
Okay, thank you, Ms. Middleton. Seeing no more questions from the board, Tef, I'll throw the ball to you.
Thank you, President Taylor. Thanks also to our co-panelists for patience as we delved deep into accountable care organizations and also the questions from the board members. Happy to introduce Dr. Jim Kahn to the board. Dr. Kahn is an emeritus professor from University of California, San Francisco, where he worked in the health policy department. He's researched and published extensively on cost effectiveness, has received funding from the NIH, Gates Foundation, World Health Organizations, among others. He's published broadly over 200 peer review articles and has had a long-standing interest in the healthcare ecosystem in the United States and how to improve our healthcare system for not just Medicare, but all Americans. He's a former president of the California chapter of the Physicians for National Health Program, and also blogs at healthjusticemonitor.com. I'm pleased to welcome Dr. Kahn, and we'll have his slides already up. Thank you, Dr. Kahn. Go ahead. Oh, let me get you the ticker.
Thank you very much, Tef, and thank you to President Taylor and the board for inviting me to speak with you today. My overriding concern is that ACO REACH is a wolf in sheep's clothing. My analysis is based on a close scrutiny of the structure and rules disseminated about ACO REACH. And the core issue is that indeed this is a capitated approach. There is an overall capitation involving for-profit entities, and that has important consequences. I'm going to advance simultaneously on my computer and the screen. Let's see if I can do this right. Aha, I did. I bring to this analysis 30 years of experience doing research in health policy, health economics, and health services research at the University of California, San Francisco. I also do analyses and advocacy for single payer or improved Medicare for all. Here's a preview of the points I'll discuss. First, the first block shows what we know about Medicare Advantage. And as we go through this, remember that Medicare Advantage started with the same promise and the same hopes for improving care. That was the intent, very similar to what we heard about ACO REACH, and that's not how it worked out. Medicare Advantage has private health plans that are marketed to beneficiaries and is paid by formally acknowledged capitation. The plans can limit care access with formal constraints. This includes provider networks, prior approvals, and denials. And Medicare Advantage overcharges CMS by gaming the risk adjustment system and through adverse selection. So that's our experience with Medicare Advantage. What we know about ACO REACH is actually remarkably similar. There are direct contracting entities, DCEs, which were rebranded as ACOs. These are essentially intermediaries that are paid by capitation, even if the providers are not paid by capitation. And I'll come back to this in a few slides. These ACO DCEs take on cost risk for all patients of participating physicians, as you've heard, and they then seek savings and profit by incentivizing reductions in care. They use informal constraints, lower referrals for specialists, for tests, for procedures. And the way that physicians are paid within the ACO model reflects this. The physicians can protect or grow their income only by lowering overall care. I'll come back to this shortly. The biggest problem with Medicare Advantage is access to care. With a heavy reliance on provider networks, often the beneficiaries lack aspect to specialists and to the highest quality hospitals. Also, the Office of the Inspector General found 15 million incorrect care denials over 3 years. As a result of these kinds of factors, about half of Medicare Advantage enrollees who are in fair or poor health have trouble getting health care due to cost or problems paying medical bills. And as a result of that, Medicare enrollees who are at the end of life and have very significant care needs are likely to shift from Medicare Advantage to traditional Medicare. The second problem with Medicare Advantage is overcharging CMS, and this, of course, also affects taxpayers, beneficiaries, and retirement funds that participate. Aggressive and even fraudulent diagnostic upcoding is used to raise capitation rates. CMS has tried to adjust for this known overcoding, but has been limited due to a variety of technical issues as well as political issues. As a result, Medicare Advantage is more expensive than traditional Medicare. One estimate is that the cost to CMS of this overcoding in 2020 was $12 billion, and another estimate by a respected former senior federal health official is that over the 10 years starting this year, the overcharges will amount to $500 billion. This results in increases in Part B premiums, which would include the portion that CalPERS pays to reimburse those. Just like in Medicare Advantage, the finances in ACO REACH are based on capitation and thus motivate diagnostic upcoding. It's not called capitation, it's called a benchmark. There's a benchmark annual cost for each individual, which in effect is a capitation amount. And that's based on the past spending of that individual. Like in Medicare Advantage, this can be adjusted for diagnostic severity. More diagnoses means a higher benchmark. There are weak limits, 3% annual, on the ACO growth of diagnostic severity once the program starts. And again, I'm getting my information from the official releases from CMS on how the program works. There is a static reference year, much is made of that, but that's only for the very end of the program, the last 2 years. There's also a coding intensity factor, which if it would work well, would control the overall coding growth. But based on the failure of CMS to enforce similar kinds of limits in Medicare Advantage, I don't think we can have confidence that that will be well enforced. The payment structure for ACO REACH is designed to maximize profits. Payments to DCEs, or REACH ACOs, is at the start of each month, whereas payments to providers can be much later. This yields a float that can generate several percentage points of investment returns, money that would otherwise accrue to CMS. These DCEs then pay CMS between 0 and 3.5% discount depending on the specific year and the type of DCE. This is pretty much offset by the float, which brings us to the core element. In the global DCEs, or global ACO REACH, the DCE keeps all savings, that is, all reductions in medical costs, up to 25%. It's called shared savings, but it's not shared. All of the savings after that discount and after the float go to the DCE. And if there are additional savings beyond that, if costs go below 75% of the benchmark, they keep much of those savings as well. This is far higher and not comparable to previous generations of ACOs. Thus, for DCEs to profit, they must incentivize less use of care. And this is where the doctor is co-opted into reducing care and costs. Something you didn't hear today, but which is very clear in the financial FAQs for ACO REACH, is that physicians who are continued to be paid by fee-for-service will be paid at lower rates than currently. They must sign an agreement to accept lower rates. They can then share in the savings for any overall costs under the benchmarks. The details of how that works are not released. They're proprietary to the DCEs. But they need to share in the savings in order to maintain their income, let alone increase their income. Thus, they need to facilitate lower medical costs overall. As a primary care provider, they're in a position to do that. As someone who has written and thought about behavioral economics, loss aversion, that is the risk of losing part of their current income, is an extremely powerful motivator, and there's evidence that it is active among physicians. Increasing income is also a motivator, but losing income is a stronger motivator. ACO REACH will use informal care constraints. They can't use the formal ones that Medicare Advantage can't. Fewer or slower referrals for specialists, tests, and procedures. And to me, importantly, this erodes trust between the physician and the patient. Physician financial interests reside in reducing, not facilitating care. Again, the way that the physician keeps their income at the pre-existing level is by helping the ACO reduce care. Sure, sometimes that may happen by a good care coordination program, but many other times it will just be a question of saying, you don't need to see that specialist, or not now, or we can hold off on that test. This undercuts why seniors value and chose traditional Medicare, because they knew everything would be covered and their doctor they trusted would be an advocate for them. The Medicare Advantage wolf is let loose. Why? Why privatize the public part of Medicare? Medicare has been doing, the public part, the traditional Medicare has been doing very well. It's less costly than Medicare Advantage. CMS has stated a goal of all beneficiaries in an accountable relationship by 2030. So while this is a moderate-sized pilot, the goal is to bring everyone into a relationship by this in the coming years. But there's little evidence that ACOs work. I and a colleague reviewed the first several rounds of ACOs at CMS and found no evidence that they work. Similarly, there's really no evidence that DCEs or ACO reach works. In my view, we should drop ACO reach, let traditional Medicare stay traditional. That is the safest option. And that is definitely my preferred option. That said, a much smaller pilot with extremely strict requirements for scale-up, such as superb access to care for the sickest enrollees, the ones who are expensive, could be considered as an alternative to the present plan. And finally, finances and care access issues aside, I believe the ACO REACH experiment is ethically challenged. Beneficiaries often don't know they're being enrolled, despite the rules. We have heard certainly from Sutter Health System's enrollees that they're not getting the letters. But more importantly, the letter that the letter that's being sent out that's notifying of enrollment in ACO claims benefits for clinical care and that doctors requested this. Both of these are substantial misrepresentations of what ACO REACH is about. Furthermore, if people don't want to be assigned to ACO REACH because they're worried about what this might mean for their relationship with their doctor, finding a non-REACH provider is disruptive, and it's very difficult, and apparently no assistance available from CMS, according to people who have tried. This represents coercion. As noted before, I think the doctor-patient relationship is compromised. And I would also add that 10 ACO REACH DCEs have a history of fraud within Medicare and Medicaid. Ultimately, I consider ACO REACH medical experimentation without human research oversight, something that would not pass muster in the Institutional Review Board at UCSF or at any university. It's a huge mistake and fundamentally raises serious ethical concerns. So I urge you to oppose ACO REACH. Thanks for listening.
Thank you very much, Dr. Cron. I appreciate it. And I'm going to change it up here. I know that we let the board ask questions, but we're running out of time. And Larry, don't hate me, but we're going to hear from our next speaker. The board's going to hold their questions. We're going to go to lunch, and then we're going to come back. So if everybody doesn't mind. So, Tef, if you want to introduce the next speaker.
Sure. Thank you, President Taylor. Thank you, Dr. Khan, for your presentation. I'm happy to introduce Dr. Alice Chen to the board. Dr. Chen is an associate professor and vice dean at USC School of Public Policy. She's done extensive research on financial incentives for providers and also the impacts on healthcare markets. Her work has been quoted in lots of public-facing media, including Business Week, CBS News, Forbes, The Atlantic, The Washington Post. She teaches health economics and health finance at USC, and her training was based out of the University of Chicago, where she completed an MBA and a PhD. Dr. Chen, we're happy to have you here and to learn more about ACOs from your perspective.
Thank you so much, Tef, and thank you, CalPERS Board and President Taylor, for having me. I think this is backwards. We're going to just scroll to the beginning here. Oh, here we go. So I wanted to talk to you a bit about what is an ACO and what is not an ACO. Some of this will touch on the conversation we've already had earlier, so I might be able to save you some time and make up for that difference. As you heard from my fellow panelists, an ACO is a group of providers who are responsible for the population of patients, a given population of patients. And it looks kind of like this box. You should have this picture in your mind when you think of an ACO. It's essentially a hospital, a specialist, a PCP, nursing home, and other providers coming together and being incentivized to provide care for a given set of patients. If they do well in terms of spending, in other words, if they spend less on care for this group of patients relative to a benchmark, then they can get share in these bonuses, but they have to meet certain quality thresholds in order to share in those bonuses. If they don't meet the quality thresholds, they don't get the bonuses. Okay, and I think this is a layer of protection in terms of the patient, from the patient perspective, to ensure that their quality of care isn't being compromised at the expense of an ACO trying to reduce spending. There's a lot of comparison really between an ACO and managed care plans, and they are very different, so I thought I would just highlight a few of those differences. In a managed care plan, the costs are being controlled through things like utilization review, rate control, prior authorization, networks. In an ACO, that is not what's happening. Costs are being controlled through this idea of care collaboration across different providers, and this care coordination is occurring because a whole bunch of different providers, as you saw on the previous slide with that box of hospitals, SNFs, PCPs, they're all being held accountable jointly for how much they spend on care for the patient population, and that's where the care coordination is coming in. Another thing that's different is in the managed care plans, patients are enrolling into the plans, they're choosing to be in the plan. In the ACO, as we've heard, they're being attributed, members are being attributed to a plan, and patients wouldn't know otherwise unless they received this letter, whether they're in an ACO or not. And I'm going to talk a bit more about how this attribution works to kind of look under the hood. Okay. And just give me one slide. And the other sort of big difference here is members in a managed care plan are limited to providers in that network if they want to benefit from the cost sharing in that plan. In an ACO, members retain choice of their providers. You can see an ACO provider, you can see a non-ACO provider, you can see whomever you want, however you want. Okay, so that is another one of those big differences between a managed care plan and an ACO. Some of the myths I want to address are listed on this slide. Essentially, some common misperceptions or misconceptions about ACOs are, I will lose my doctor if my doctor is part of an ACO, or I can't choose the specialist that I prefer or the hospital that I like once my specialist or the hospital's in an ACO, or if I'm enrolled in an ACO, or attributed to an ACO, I should say. Some people want to choose their doctor, not the government, and so they say, oh, I don't like ACOs because of that. Some people say my doctors don't recommend the best treatment because it's too expensive, and they've got this incentive to save money, so these ACO doctors aren't going to do a good job. And lastly, my doctor gets paid extra so that they don't do tests on me, right? And these are things I think people are concerned about, and I'm going to try to explain to you why they aren't true. So I want to focus on the first 3 points first. I will lose my doctor, you don't have choice in care, by talking about how is a patient attributed to an ACO. So I've got 2 patients here, patient A and patient B. They both see a whole bunch of different providers. Patient A sees some ACO providers, some non-ACO PCP, some non-ACO specialists. Patient B also sees a host of different providers. Some are ACO providers, some are not. And in this example, patient A is not attributed to the ACO, but patient B is. And the reason is because patient A does not receive the majority of their evaluation and management, sort of their normal evaluation care from an ACO provider. But if you look at patient B, much of their spending on these evaluation management services is coming from an ACO provider. In other words, they're already seeing much of their care is being provided by an ACO provider. That patient then gets aligned or attributed to an ACO. Okay, so from the patient's perspective, from patient A and patient B's perspective, they frankly can see whomever they want. They can continue to see any one of these different providers. Whether they want to see an ACO provider or non-ACO provider is perfectly fine. Patient B, who's aligned to the ACO, can continue to see non-ACO specialists, right? And so the alignment here is really from the provider's perspective, assigning to them the patients that they are already providing the majority of care for and making them accountable for that person's total use of healthcare services. Okay. The next thing I want to address is just really getting to this sort of the last two myths here. My doctor won't do the recommended tests on me, or they're going to try to skimp on care, by highlighting to you what are the quality metrics that must be met in order for ACOs to actually even receive any bonuses, right? So to actually receive, participate in the shared savings. And there's 4 big quality groupings here. The first one is patient caregiver experience, the second care coordination, patient safety, the third preventive health, and the last at-risk populations. And in the patient caregiver experience comes from the survey that you heard about. They're asking, do you get timely care to appointments? How do you rate your doctor? What is your access to specialists? If you don't get any of those, and those are, patients rate them low, then providers get low quality sort of metrics, and they might not meet the thresholds to participate in savings. Care coordinations are measured through things like admissions rate. Preventative health is measured through things like cancer screenings, whether or not you're getting your flu vaccines. And looking at the at-risk populations, the metrics are things like diabetes and hypertension management. Sorry, go backwards. So you might wonder then, okay, so fine, they meet the quality thresholds and they're saving money, then where does the savings actually come from? You heard about some of the investments like having nurse practitioners or at-home care. What the literature has shown is that the savings are coming from things like reducing excessively long SNF stays or reducing duplicative imaging. You go to one provider, they do an image, and then you go to another, do the same image that the other provider did. Shifting care away from outpatient facilities that charge really high prices towards facilities that are more efficient in their care. Discharging to facilities rather than home for more oversight, also having lower admissions rates. And these are sort of an amalgamation of the literature that's been put out so far, published in some of these peer-reviewed journals. So I just wanted to provide that perspective on ACOs, and I look forward to having a discussion after lunch.
Thank you very much. I do appreciate you rushing through that, and you didn't need to. I think there's going to be plenty of questions after lunch from the board, and then our members are also going to come up and comment. I understand our CMS folks have to catch a plane, so I just wanted to make sure before they left that the board had all their questions answered, so that there's nothing else.
My flight leaves a little earlier. My colleague said she'd be able to stay a little longer, so.
If that's helpful for you all, yeah, I'm happy to stay a little longer.
Oh, that would be appreciated in case other questions come up. So I do appreciate that. Thank you. All right, so I'm going to go ahead. It's 12:15. We're going to break for lunch till 1 o'clock. We will be back after lunch. I'll start with board questions, and then we'll move on to comments. Thank you very much. Meeting is what is that called?
Recess.
Recess. Thank you. My brain did not want to work.
Sorry, Teresa. I had so many questions.
Back in session for our open session. And I want to throw it over to our board to ask questions. We're not all here yet, so calling all board members. But I also wanted to let the board know that our gentlewoman from CMS is still here. However, she still has a hard stop in 14 minutes. So if no one has questions, or if you do have questions for her, we will take those first. Those of us from the board. Anybody have questions for her? Anybody?
Well, I have a question for all the panelists.
You want to do an all panelist question? Okay. Go ahead, David. Wait a minute. Takes me a little longer now. I got to work around. Go ahead.
I just want to, first off, thank all the panelists. I really appreciate your time and expertise and sharing with us and spurring some dialogue. So the question I have is kind of much more of a broader, kind of a bigger picture question. You know, the whole, this all comes out of a time when things were very unsettled in the big picture. And one of the things that I've been hearing, even from early on, was that, and I'd just like each of you to kind of share your thoughts and opine on this, is whether this is an obstacle to or some sort of impediment, or whether it's actually something that would, in the long term, strategically thinking, make it easier to move toward a single payer or universal health care type approach. I think there seems to be I hear a lot of folks who view it as kind of a little bit of a wolf in sheep's clothing in terms of being something that ultimately makes it harder to move that direction, and makes it more difficult to move there, makes the whole situation more complex and stickier, makes it easier to try to rationalize staying with systems we've got and trying to improve them versus any kind of, fundamental shift to a new approach. And that it's been somewhat, the political ups and downs have made that more or less of a concern. But so I'd just like to hear your thoughts on how that strikes you.
So go ahead. You can go first.
Thanks for the question.
Oh, no. I'm sorry. She has to leave at 1:15.
Sorry, I didn't know who you was.
I mean, I can't comment, obviously, on behalf of CMS around single-payer system. What I can comment on is that, we know that no payment system is perfect, and transitioning from fee-for-service to population-based payments will introduce other challenges and concerns. There are trade-offs with every payment system. And so I think what we're trying to do is to try to understand sort of what is the current state. We know from evidence like the Dartmouth Atlas that, there's a lot of variation in costs all over the country. We know that fee-for-service, in general, incentivizes, a certain type of, volume of services. And so we're mindful of those concerns. And what we've seen in our fee-for-service payment system is, increased volume of services, more duplicative services, waste, low-value care. And that's why we are really interested in testing approaches that really seek to provide incentives for providers to work together to better coordinate amongst themselves to care for patients. So that's, I think, what we're seeking in terms of the work that we're doing in the Innovation Center.
Mr. Khan? Dr. Khan, sorry.
I think it's fundamentally irrelevant. I think the key insight of single payer from dozens of countries around the world is that if everyone has exactly the same insurance, then everyone will have access to care. And that handles a lot of the issues that ACO REACH is trying to handle in terms of equity. Not all of them, but most. And I think the experiments we've undertaken in recent decades, including Medicare Advantage, certainly should convince the discerning viewer that we're not going to fix our system by privatizing aspects of it like Medicare Advantage. It didn't accomplish what it was aiming to accomplish, and that should, in my view, lead us to conclude that we should finally, as Winston Churchill said, do the right thing. Should finally follow the model of other countries. I don't think that ACO REACH is going to make a pivotal difference there. As I've said, I predict ACO REACH will not reach its goals, and whether we recognize that fully or not down the line, we'll see. But I think that the arguments for single payer are not contingent on that.
All right, thank you, Dr. Khan. Dr. Chen, sorry.
All good. So yeah, I think that the ACO model won't have a big effect on our movement to single payer or not. The big question is, if we are moving to a single payer system, what is that single payer system? And if it's traditional fee-for-service Medicare, we know that fee-for-service is an incredibly inefficient way to run a healthcare system because of some of the things like duplicative services and waste and low-value services and other well-known sort of issues. There is a world that exists, maybe, where there's a single payer system where it's all ACOs as well. And on the private side, we do see ACOs being implemented as well. So it's not like from the private perspective, they don't know what an ACO is. So in that sense, I don't think it makes much of a difference in moving to or away from single payer.
Can I just add very quickly? We do not know that fee-for-service is a problematic approach. Many of the countries that have single-payer and control healthcare costs and provide access use fee-for-service. Most of them do. It's simply not true. We shouldn't state that as an accepted fact.
And not to make this a fun debate, but I would also add that a lot of it's true, there are international countries, other countries who do fee-for-service, but they layer on other things like global payments. So your fee-for-service expenditures can't exceed a certain amount. So there are caps on payments, which we in the U.S. don't have.
But we should.
Thank you all. That was very helpful.
That was very good. Thank you very much. Okay. Hold on one second. Mr. Rubalcaba, it takes me a little longer. There you go.
Thank you. I just want to, since I forgot your name. I'm sorry. See, you're leaving. I wanted to, one of the comments in the, let's see, where's my notes together? One of the I just get to the question. In the redesign, it was presented as just a change in terminology and the contracting entity. Is that just a name change, or was there significant changes in the financing system?
So there were changes, and I think Liz gave a high-level overview of some of those changes. I will say that the name change from direct contracting entity to ACO was sparked very much by the participants in the model who were upset from the beginning of the model that they weren't called ACOs, because some of them were ACOs before in other models and programs, and so they did not like that they weren't called ACOs.
But the ACOs have that system has existed for some time, right?
Yes. Yes.
With the health homes and all that thing, wasn't it come together?
No, with the shared savings program, there were ACOs, and then the CMS Innovation Center tested other ACOs, like the Next Generation ACO, the Pioneer ACO model, the ACO investment model. So we had model tests before ACO REACH, where they were referred to as ACOs, and then the global and professional direct contracting model came out and changed the name to direct contracting entities. And the participants who were in the model had asked us why were we changed to something else. And
go ahead.
And it was really a branding decision, I would say, at the time. But there were some other differences, I think, that had to do with the governance board. So when the model first came out, the governance board had to have 25% provider participation. In ACO REACH, we increased it to 75% or more, which is consistent with the shared savings program, CMS's permanent ACO program. So we actually changed what the governance structure was. We also included an additional representative for beneficiary and consumers. So before there was one representative, now there are two, a beneficiary representative and a consumer advocate on the governance board. So that was one set of changes. The other set of changes in the redesign had to do with the 5 policies around health equity, including that payment adjustment to shift resources to beneficiaries who are underserved. And then there were some others around, for example, the benefit enhancement that allowed nurse practitioners and physician assistants to be able to do certain services under Medicare that previously only a physician could do. The way that we looked at applications, the health equity plan requirement, and the data collection around that health equity plan requirement, that whole bucket of health equity policies were part of the redesign into ACO REACH. And then the third bucket has to do with the compliance and monitoring and the vetting of the applications. So in the original model, there was a set of vetting. It was not the same kind of vetting of applicants that we did for ACO REACH. In ACO REACH, we had the application review, and then we asked for detailed information on ownership, leadership, and governance, as well as the providers. We always vet the providers because CMS has the Center for Program Integrity. We work with law enforcement. We can always look at providers in the Medicare program, but and so we did that in GPDC. But when we got to ACO REACH, we looked more specifically at the ownership and applicant structure around their leadership and governance as well as ownership and the providers.
But the revenue stream, did it change or does it stay the same?
It's Medicare fee-for-service is the payment mechanism. We've set the benchmark just like we would in an ACO model, where you look at expenditures and come up with what the spending target should be for a set of beneficiaries that are assigned or attributed to an ACO. And then the ACO gets flexibilities around how they provide services to those beneficiaries. These are benefit enhancements that we talked about, like more care in the home, the nurse practitioners, telehealth, and then beneficiary engagement incentives around things like in-kind items like transportation or remote monitoring or support for Part B cost sharing. And then in terms of the payment mechanisms, they are the same in both the previous model and ACO REACH, where the beneficiary, or where the ACO receives some prepayment from CMS in a per beneficiary per month payment for those beneficiaries that are aligned to them. And they use that money in their arrangements with their downstream providers that are part of the ACO. So that the providers that are part of the ACO, they enter into agreements with the ACO where they take some payment reduction from Medicare. So we pay some of the payment directly to the provider, some of it goes to the ACO, and then the ACO uses that payment for their downstream financial arrangements as well as infrastructure to help support the providers, whether that's hiring the nurse practitioners and other care managers or providing them data and other kinds of tools.
Thank you. One of the changes you mentioned is that there's a new governance structure. Have you seen that? I know it's new, but have you seen that what kind of difference did that make? And I understand that in the global model, before you transitioned, there was also a governance, but you had, or maybe I misread it, but there was not equal distribution of the votes on that governance structure, or could be, I guess.
Right. So before we transitioned to ACO REACH, and ACO REACH is just starting now, the provider participation was requirement was less. It was 25%. Now we're saying it's 75% or more, which is consistent with other ACO initiatives. So the providers have more voice in the governance of the ACO. And then in terms of the beneficiaries, there's also an additional representative on the board now.
Okay.
I'm gonna let him go.
Thank you.
Just because other people have other colleagues
If it
have more
gets
questions, but
answered,
I'm
you
gonna
can
follow
ask.
up with
Okay.
governance in some place else.
And you may want to leave our folks with a contact information in case the board comes up with more questions, but you're free to go, and I'm sorry.
Sorry,
Thank you, everybody.
Ms. Middleton, go ahead.
I was going to ask Pauline a question, so
She has to get to the airport.
I think she needs to get to the airport.
Yeah. Thank you, Paulina. We do appreciate you staying over for us. If that was the only question for you? Okay.
For now.
Okay, hold on. Mr. Pacheco, wait a minute. Mr. Pacheco, go ahead.
Yes, thank you. Thank you, Madam President Taylor. This question is directed to Professor Chen. So, Professor Chen, you mentioned in the beginning about what is an ACO. You mentioned that there are a group of providers who are responsible for a population of patients, and you also mentioned that in order for them to receive a bonus for reducing spending for their patients, I wanted to understand about the criteria that you use. You said you have to meet certain quality thresholds set by the insurer. And I'm wondering if you can elaborate, are those thresholds subjective in nature, or are they objective in nature, or are they a combination? If you can elaborate a little bit more on that.
Yeah, so thanks for that question. These objectives, at least in the Medicare Shared Savings Program, are set by CMS, and they're objective in the sense that there are certain targets that must be met, but they're also subjective in that patients are giving their feedback, right? So in that sense, patient perception also matters. But whatever the patient's viewpoint is in terms of their care experience, timely access to care, access to specialists, whether or not their provider listened to them, those responses are then treated and benchmarked against something objective. A threshold that's objective.
And these feedback coming back from the patient, is there a way to take into considering bias, like human bias, like I really like this doctor a lot, I'm going to give him 5.55s, but is there other systems in place so that we have a real good, understanding?
Sure. Yeah, so the patient feedback is only one component of the quality, and it will have bias because it's whatever the patient perceived. Right. The other metrics, things like have you managed your diabetes patient population in terms of are they showing up in the emergency room, or have you given cancer screenings that are preventative care that we know people of a certain age, are susceptible for cancer, we should screen them. Have you given them flu vaccinations, things like that? Have you screened for fall risks? Those are objective measures that CMS is collecting.
Okay, thank you very much.
Sure.
Thank you very much. So as I look at this, Dr. Chen, the spending reductions and where they come from, a lot of this looks like it's an HMO, right? These are what, if you're in an HMO, this is the things they're also watching, except the difference is the coordinated care that HMOs don't provide. So how do you get here and coordinated care?
Yeah, so it's a little bit more complicated than just the coordinated care component of it. The way HMOs get there is very different. What they say is you can only see providers in this very specific network of people,
correct.
Right? You can, I'm going to monitor whether or not you are able to do X, Y, and Z, right?
Correct.
Prior authorization. With the ACOs, what they're saying is I'm going to let the providers figure out what is the best way to deliver patient care. And the way they do that, say providers, if you are able to save money and you invest money in other ways, instead of the emergency room, instead of an expensive outpatient facility, find a more efficient facility, you can innovate on those fronts. And the providers are not prescribed, you have to do X, Y, and Z. They're simply given the incentive to save money. And so the way they get there is different between managed care.
But there's still requirements, right? You're still saying quality of care, such as you talked about cancer screenings, there's still requirements to meet for quality.
That's right. Yeah, that's right. And the incentives for coordination come really from the cost side, the financial side, right? So once you've met those quality thresholds, right? So once you can certify that you haven't skimped on care, and you can also produce savings, based on however you decide to invest in the care production process, then you get these bonuses.
Okay. And Ms. Ortega, hold on, mic on, there we go.
Thank you. I had a question that I think maybe is more for staff, which is, I very much appreciated the conversation about this kind of broader health policy questions, but curious about the impact to our members directly and sort of what the scope of concerns and issues that might be facing the board on this.
Sure. Thank you for the question. So we have around 350,000 Medicare beneficiaries in CalPERS. Of those, roughly half are in Medicare Advantage programs, so would not be impacted by ACO REACH or any other ACO program. Of those 150,000, a third or so, less than 50,000, are out of state. So in California, that leaves around 100,000 members. As the CMI team announced in the morning session, they released the list of DCEs this morning, today. So based on where those direct contracting entities are located in California, what we will look at is the overlap with where our CalPERS Medicare beneficiaries are, and then we'll be able to get a better sense of how many members could be participating in ACO REACH. Since all that information is fresh, I don't have an exact answer for you, but that's generally the potential exposure, which is relatively small considering our 1.6 million overall covered lives.
Okay, thank you.
Thank you. Seeing no further questions from the board. Oh, never mind, I lied.
I'm sorry, I do have some follow-up questions.
Okay, you said you might, so go ahead.
Dr. Khan, I was very interested in your presentation, and thank you. How I read, the whole focus is you definitely are an advocate for a fee-for-service and believe Medicare Advantage is not the way to go, and that's why ACO REACH is not the way to go. So, and you made, I'm not sure where I read it or what's in here, you made a statement that Medicare Advantage is more expensive. So can you elaborate what evidence is there to that point? Because I always heard the opposite, so to speak.
Thank you. First of all, to clarify, I don't favor fee-for-service over capitation, or I favor, I think fee-for-service and not-for-profit capitation can both work. The problem with Medicare Advantage is it is a for-profit model for capitation, and this results in a variety of efforts by Medicare Advantage plans to increase their revenue, including upcoding of diagnoses, both legitimate but aggressive and also fraudulent. Risk selection, meaning attracting healthier people into the program and pushing out sicker people maybe through difficulties in access to care. When you take a look at all of that and all of the evidence about what their profit margins are and really excellent econometric analyses, what you find is a couple of things. First of all, Medicare Advantage plans do decrease medical costs, probably by about 9% is the best analysis I've seen. But that's less than the increase due to administration and profit. So overall, Medicare Advantage increases costs compared to traditional Medicare, and that is because of all the reasons I mentioned, such as risk adjustment, diagnostic upcoding, and so on. The estimates of how much they do that, I reported on briefly in my presentation. MedPAC, which is the advisory board for CMS on Medicare, estimates about $12 billion in overspending in one recent year, and the estimate going forward, because these risk adjustment, the risk adjustment gaming is increasing over time, the estimate is much larger for the next 10 years, an average of $50 billion a year, according to a very credible analysis. So that's why Medicare Advantage costs more. It has profits, and they have various techniques to increase the payments and to shed the most expensive patients. And so I think that even the presentation by CMS acknowledged that Medicare Advantage is more expensive than traditional Medicare.
Okay, didn't quite hear that, but that's okay. But I am very intrigued by this perspective, so I have two follow-up questions. One, I keep hearing the term the privatization of Medicare. Explain explain that term for me, please. What did it
Sure.
come from? What does it describe?
Medicare, some decades ago, Medicare was a fully public program. Providers would provide services. They would bill Medicare directly or through a billing agent, and they would get paid from the public purse for those services with no intermediaries. Medicare Advantage introduced the idea of health insurance intermediaries. Basically managed private for-profit managed care companies that would accept the risk of paying for care for many Medicare beneficiaries. So that was the first step in privatizing Medicare. What we're talking about with ACO REACH is the next big step, which is you take traditional Medicare, which now is CMS pays providers, and instead CMS will pay these contracting entities a certain amount each month at a benchmark level, which is essentially a capitation amount, and then those entities, which are private and for profit, will then be responsible for paying providers through this combination of a lower fee-for-service plus sharing in the savings. So now you've taken a public program that is directly paying from the government to providers, and instead you're interjecting the ACO, the REACH ACOs or DCEs, who are taking the risk and are taking the profits, assuming that the overall costs can be lowered.
So part of that analysis is assuming that when you take on risks, you'll also make more money. But I always thought, at least in CalPERS, we do have risk adjustment, but it's the way I understood it is to even the playing field, so there is an adverse selection. So how would you respond to that? I mean,
we're getting a little bit into the technical weeds. If you apply the CMS risk adjustment method called HCC, if you apply it to randomly dispersed patients, if there's a group that happens to get some sicker people, more people with diabetes, for example, the HCC system works really well. And it does even things out. However, if the different groups, like the Medicare Advantage plans, have a way to attract healthier patients, for example, by enrolling directly from companies, people who have been working until age 65 and then retire, those people are a bit healthier than the rest of the 65-year-old population, the healthy worker effect. So they attract healthier people with the same mix of diagnoses, but they're healthier. They can also make it hard for people with very severe and care-intensive conditions, make it hard for them to get care because of this network restrictions. And people who are really, really sick, particularly near the end of life, tend to then shift to traditional Medicare. That means the Medicare Advantage plan gets rid of the most expensive people. So these are all theoretical considerations, but they're all well documented by data. There's ample data to show that this is really what happens. And these combination of factors, which is why Medicare Advantage gets overpaid, why it's more expensive than traditional Medicare.
I have two follow-up questions here. That statement made me find my little notes here. In one of your PowerPoint, you do say that enrollment in the Advantage plans are likely to shift to traditional Medicare at end of life. Explain that. I mean, is that because they've realized that they can't get the care they need, so they need to go someplace? I mean, what does that mean? Why do you say that?
There's certainly anecdotal evidence. There was a paper that came out just a month or so ago, which demonstrated quantitatively that people with advanced cancers, serious cancers, who needed surgery, were those who were in Medicare Advantage were less likely to be able to go to the best cancer surgery centers, and as a result, their mortality rates were higher. More generally, people at the end of life or when they have serious illnesses, they need more care and they need more specialists. And because the networks are restricted in Medicare Advantage, the best hospitals often not in the network. And so someone says, wait a minute, I can't go to UCSF, it's not in my network. Well, I'm going to get out of this plan and get into traditional Medicare. Then I can go to UCSF. That's the kind of decision-making that people are faced with when they're desperate to get the best care and they can't get it through their HMO.
Let me reverse the question a bit. A lot of my colleagues were talking about access to care in rural areas and areas where perhaps are underserved, either because of, I don't know, they live in an area where there's older plants. Hospitals are not don't have the latest. They're not, they're not in the richest part of town. What changes will you advocate? Either, I mean, how's the best way that Medicare should be able to reach out to those people, to serve people who are currently underserved or are not in the areas where they have the best hospitals?
I think the
primary care.
I think the problems with underserved areas goes beyond Medicare. One particularly important piece of that is Medicaid. Medicaid in many states, including California, underpays for care but substantially compared with Medicare and compared with private insurers. It was just an article the last few days about how Martin Luther King Hospital in LA has this huge deficit in the emergency department because Medicaid payments for emergency services are inadequate. This is much more likely to happen in poor areas and particularly in areas with people of color. That's the problem we need to address. That, in my view, is not a Medicare problem. That's a Medicaid problem. It's an uninsurance problem.
No, I agree. It seems, I haven't read that article, but it seems to me that historically, when the emergency room should not be used as a primary care physician, but that's
absolutely
a problem.
Absolutely, and people on Medicaid, because Medicaid also doesn't pay well for primary care, they're more likely to need to resort to the emergency department to get that care.
Yes.
Ms. Middleton.
Thank you.
Thank you. It's a very interesting discussion, and I really appreciate all of the points of view we're hearing. As I've studied healthcare policy over the last many decades, the only thing that everybody seems to agree on is that we have a system that is incredibly inefficient. We have a group of individuals who want to go in one direction to greater privatization, and make sure I use the right hand, and those to the left who tend to want to go to a single payer system. But as I understand it, neither side is winning the argument today in terms of being able to bring the kind of policy that they want. And therefore, we're having incremental reforms of the healthcare system. What I'd like to understand is this ACO REACH, what context should we view it in terms of incremental reforms that are trying to be brought to the system? And either one of you can start first.
I'll start. So the ACO models are, in fact, an incremental reform. They are not revolutionary, I would say. But what it's trying to do is addressing an issue in terms of spending relative to value. What are we getting for the money that we're spending? And it's their attempt to offer a solution or a model that might work in trying to move us closer to that objective.
There we go. From my point of view, the elements of ACO REACH, like greater coordination of care, are really valuable. Perhaps not as valuable as we'd like to think, but definitely in the right direction. There are models to provide coordinated care like Unlock, which is a wonderful model for seniors. It's been around for a long time. There are things we can do. The way that we pay for health care, that's really what single payer is about, changing how we pay for healthcare, fee for service or capitation with global budgets, as we talked about before, and everyone has the same coverage. That's really the great dream of the people who advocate for single payer. The ACO REACH model has some good elements, but because it fundamentally shifts control and to private entities who then can make a very substantial profit, as I said, potentially 25% of the benchmark is available for taking as profit or even more, that is pushing us in the wrong direction. Honestly, we've pushed so far in the direction of privatization in recent years and decades. Your characterization that no one can get the upper hand was very kind. I think, honestly, privatization forces have had the upper hand, but we have a health system with very high costs, rates of medical debt that are astounding. 40% of adults have medical debt, and that affects their families as well. I think those of us who believe that we should have an efficient, fair way to pay for healthcare, like dozens of other wealthy countries, continue to push, but we have not yet achieved the upper hand. Stay tuned.
All right, thank you.
Thank you, Ms. Middleton. You're done? Okay, I just wanted to make sure, because I know Ms. Walker.
Thank you. Doctor, just one question. And I'm going to simplify what I thought I heard you say, just to make it make sense in my head, that it's the problem, not the problem, one of the problems that you have with ACO REACH is not necessarily with the program itself, because you said there's good things in, well, maybe it is, but that there's good things in it that we can get out. But it's adding the layer for an entity, a for-profit entity, to take money out of the system.
Precisely.
Okay. That's what I thought, but I just wanted to make sure that I'm tracking where you are.
Right. The initiatives to improve equity and to improve coordination of care, they're wonderful, without that overlay.
How do you think in this perfect world for you, and how would it look if there were like a nonprofit that was operating as the ACO REACH? In perfect world, how would that look for you?
It's a tricky question. Obviously, having it be a not-for-profit takes away the traditional view of profit-taking as something to benefit shareholders. The problem is there's ample evidence in healthcare that the not-for-profit world, such as hospitals, has taken on the culture of the for-profit world.
Yes, they have.
And so they still look for operating surpluses, AKA profits, and they still pay their CEOs and senior executives huge amounts of money, and they still market services which are very limited medical value but are highly lucrative. So I'm not sure that you could have a not-for-profit ACO REACH model that would truly act not-for-profit. So I'm very much disinclined to see any intermediary instead continue to pay fee for service, but put a little extra money in for coordination of care. Pay doctors to coordinate care. Pay them directly to coordinate care. That's what we have many examples of care management programs for special populations, including the elderly, that work fine. We have models we could do that. It's the overlay of the profit-seeking intermediaries and not-for-profits that might look like the for-profits that creates what I think is the wrong incentives. And that would be my bias, but we're also looking at decades of experience with Medicare Advantage, and that's what happens.
Thank you.
Okay, Mr. Pacheco.
Thank you. This question is to Professor Chin. So this has been a very, very enlightening discussion. But I want to get back to the AC. You had mentioned in your slide that where does ACO spending reduction comes from? And you mentioned that there are certain academic research papers that have shown that ACOs have reduced some wasteful spending. Now, you provided a good list of them, but do you feel that that's enough? Or do we still do more research in this to see the cost savings over time? Because it has an element of efficiency that could scale sometime. I want your understanding of this.
That's what this is. That's an excellent question. Part of the challenge of doing studies over time is that organizations who are participating in ACO have the option to continue participating, or they have the option to drop out. And so when you start to look at ACO effectiveness over time, you end up with a more and more biased sample, because the people who remain in the program look different than the people who've dropped out of the program. So there is definitely, I think, a need for more research and understanding what are the longer-term impacts of an ACO. Right now, the evidence that I provided is based on what has happened 1-2 years, maybe 3 years post sort of ACO introduction. It's not actually a very long period of time when you're trying to talk about sort of systemic or system-wide changes in the way organization runs, right? So I think we definitely need more work in that area.
And so with respect to this, just a follow-up question. So the research is it's still maturing. It's in its infancy, right, in this area. Am I understanding? Is that my understanding? And we don't really have any metadata analysis to increase the power. I'm just trying to understand how many entities and how many ends do we have to get actual understanding.
Sure. There are a lot of ends, and there's actually a lot of papers. It's a growing literature area, and I would say there's hundreds of papers now on ACOs and what they've done, both in the Medicare space and in the private space. And it's usually these papers use Medicare claims data, so the same data that CMS talks about, collecting all of those claims data is what the papers are analyzing.
Okay, very good then. Thank you.
Sure.
So I just want to, I myself was having a little trouble in my head figuring out what you were saying versus what she was saying. So you have a slide on page 2. I looked over here. I'm sorry. Dr. Chen has a slide. I don't think I guess it is page 2. ACO consists of a group of doctors, hospitals, and other healthcare providers who come together voluntarily. So you've got hospitals, PCPs, other providers, nursing home specialists, right? They're all working together for a set of patients that they've agreed to. Is there an entity above that that gets the money and disperses it to them? Because that's what he's saying there is.
Thank you. So the entity is the ACO. So these hospitals, take for example, I come from USC, so Keck, right? Keck Medical System. There is an ACO. Keck participates in an ACO, but Keck is an independent hospital, right? They do their thing. They have an ACO contract, so it's a contracting mechanism, and the incentive gets paid to the ACO, which covers all of these different bodies, right?
So let's say it's the hospital in this case then. So that's what you're saying. So it's not like a company, it's a hospital or a company that owns the hospital, and then they distribute the money. Is that what you're saying?
It's not even, you should think of it as a contracting entity as opposed to a firm or an organization, right? So it's neither the hospital. The ACO is an entity that contracts with many different providers. If those providers save money based on this benchmark that's set,
do they know they're working together? There's where I'm getting confused.
They know
now.
They're working together.
Okay.
Yes. They come together, they agree to this contract, right? The providers agree to this contract, whether it's the hospital or a facility or a doctor. They agree to this contract and say, I agree to be part of this ACO. CMS will pay the ACO entity, right? So neither firm nor organization, but entity, they'll share the bonuses if there is savings that the group of providers have achieved. And in terms of how the bonuses are shared or like how they trickle down the pipeline, completely unknown.
Okay.
Can I just...
Hold on.
Okay.
I got to get this clear in my head.
No, it's about this.
So let's say it's the hospital, it gets distributed to the rest, okay? What I'm concerned about, so it's still a contracting agency. I guess what I'm concerned about is our hospitals under any providers that we deal with right now, right? Are profit driven, whether they're not for profit or not, correct? So doctors groups, hospital groups, they're profit driven. So we already have trouble controlling those costs, regardless of this little ACO organization, right? So say that I contract with, I don't know, United Healthcare, right? For my insurance. And I pick a medical group, because I have to, because it's an HMO. But we still have, there's fights going on all the time between hospitals and insurers and doctors groups over when us as a contracting agency says you got to bring your costs down, then it's a fight between the provider and the insurer, right? So how do we keep that from happening? That's my question, and I'll get to you after. Sorry.
But I do want to comment.
Oh, go ahead.
Largely in agreement with, I agree with your characterization, but just to clarify, the contracting entity, or the ACO, which is essentially synonyms, separate from the hospital and all the doctors. So they approach KEC, or they approach doctors, and they say, we want to set up this ACO. We want you to participate. Some of the doctors may be in medical groups, some of them may be individual practitioners, and some of them will agree to participate in that ACO. The contracting entity gets the monthly payment based on a benchmark, and then from that, they pay the provider, whether it's a hospital or the private doctor's offices or whatever, and then they pay them less than the traditional Medicare amount, and then if at the end of the month or at the end of the year they've spent less than the benchmark, then they share the savings in a way that's not specified, that's not public. Is that an accurate summary?
Yeah, so we are mostly in agreement. I think the MSSP model, the one outside of the experimentation with the ACO REACH model, pays providers in a fee-for-service rate that is the exact same rate as set by Medicare, right? So Medicare traditional fee-for-service is what those providers get paid. I think it's important to understand what that benchmark is. The benchmark, at least in the MSSP program, and the one that's permanent, was based on historical spending of the beneficiary. So they look at the little patient A, patient B picture I had, right? Some are going to be aligned, some are not. For the patients who are aligned, they look at their historical 3-year spending and say, this is what we anticipate you should spend on average for your pool of beneficiaries. And if you spend below that benchmark, then you get to participate, you get the savings. And if you spend above it, then you don't. Now, that benchmark design has changed over time, and how that benchmark set matters a lot. And that's, I think, where, when you talk about where the fight comes in terms of prices and how you're going to achieve those savings, it really is thinking about what is that benchmark that's being set, and can ACO spend less than that while under the still framework of fee-for-service and the prices that have been set for fee-for-service across the Medicare board.
So, and I remember they were talking about earlier the Blue Rock sample. Okay, so that was 2 doctors apparently got together and did this. So I guess what I'm asking now is, did Blue Rock get a fee, an extra fee for doing this for everybody else that was under them? Is that how that works?
Blue Rock is the private equity company?
No. There are 2 doctors that got together.
I don't know how that was set up.
I don't know the Blue Rock example either, but I would be surprised if the 2 providers were the only ones in the ACO. You can't manage
No, but I think they started it, is what they were explaining. Yeah, what I'm trying to figure out, is there so the ACO or the DCE, whatever you want to call it, whoever it is, whether it's the hospital or whether it's a private equity firm that owns a hospital, whatever, do they get an extra fee for being the ACO? Is there a profit out of this?
Their profit is in keeping the overall spending below the benchmark. So just to be concrete about it, the benchmark might be $12,000 a year for a typical Medicare population. So, and then it's adjusted by the history of those individuals. But let's say $12,000 a year. Then they actually will spend in fee for service. If it was the same care, they might spend only $11,000 because the rates went down. But what if they, through whatever mechanisms, they decrease care and it now goes from down to $10,000. So now they've spent below the benchmark. They keep some of that $2,000 and some of it they'll share with the providers. So those people who started that ACO.
So we don't know this, though, because that's what she said. We don't know how this is distributed.
We don't know. We don't know the exact rules. We do know that it's required that the providers take a lower fee-for-service amount, and that they share in the savings, or they can share in the savings. So we know that this is the mechanism. What we don't know is the precise rules, which will vary from one DC to the next, considered proprietary. But that's how they make their money, by keeping below the benchmark.
Okay. So,
President Taylor.
Yeah, we got to move on.
I can also follow up regarding the Blue Rock example that Dr. Fowler gave. I can follow up by, email otherwise with more details about
yeah,
how they set that up.
I'm just feeling like I'm not getting a straight answer here. I feel like are these entities making a profit, right? If they beat the benchmark, but that has to be, so this proprietary piece is where you're leaving our retirees kind of unknown what's going on, I think, is where it really comes down to, is that piece right there.
Sure, though I think the one thing is providers have to want to participate in an ACO. If it is not lucrative for them to participate in ACO, we know that everyone's profit driven. Why do it? So they have, if they continue to participate, presumably the entity or the contracting body or the ACO is sharing some of that money to make it profitable for providers to stay in.
Which would make sense if they were also a provider of some kind, but it wouldn't make sense if they were just some, company doing it for the providers. So
sure, and I think that's why the ACO REACH model has now enforced for 75% of the ACO board, whoever runs that entity, to be providers.
Okay.
Yeah.
Ms. Middleton, I'm sorry, we should move on. Ms. Middleton?
Yes, this is going to be fairly quick, I hope, and it's for staff. Specific, what is the decision the board has before it to make today?
None.
Information.
This is all informational.
Educational discussion, sorry. I always do this. This in itself is an educational discussion to inform you more about the program. It's something that you could take up later on if you so choose.
All right, thank you.
And Mr. Rublikava.
I think the question's been asked, so.
Oh, okay. All right. So I want to thank both of you. We do have our public comment coming up. Great conversation. I appreciate it. Thank you very much for helping us out with this today.
Thank you. Thank you.
So I'm going to, I think we're in public comment at this point. So I'm going to call three folks up. First up is Keith Umamoto, Larry Woodson, and Rosemary Knox, in that order. I have to have you guys go because I need this part over here. Sorry. But they could be a provider.
The providers can be paid directly for coordinating all that.
So Keith, I have you as first on here. So if you'll set us up for.
Thank you very much, and Happy New Year to everybody. Also, congratulations to the new members of the board, and welcome aboard. ACO REACH is a extremely critical issue before, oh, by the way, my name's Keith Imamoto. I am representing California Alliance for Retired Americans with this testimony. We have serious concerns about it, and we jointly signed a letter about not quite a year ago with 350 other organizations with our concerns about it. And one of the fundamental issues that we have about ACO REACH, and I think you got a lot of that dialogue just recently, or immediately preceding my comment, is that it is an entity that establishes a system where private equity firms and even the HMOs, et cetera, are looking at as an avenue for, and especially the private equity firms, for a profit. Now, when you look at that as a element, private equity firms gets money for people that want to make money. They're not necessarily soliciting money for people because they are concerned about a particular issue. And so that's one of the fundamental points. Second is there are other avenues to achieve a lot of what we've been hearing that doesn't necessarily have to be under the auspices of ACO REACH, because you fix a certain system to enable the dialogue. Wraparound services is an example. It's done within, well, Santa Clara County was the one that initiated it many moons ago. And then also another issue is the contracting out. It is really contracting out. And two of you are really concerned about contracting out, or was, with the state of California, and that's what this is actually doing. And the ultimate goal ends up being shifting on priorities, where in reality they're looking to save quote-unquote costs, but not with a structure that achieves that goal. So anyway, of those many organizations that signed on board, the more recent one that signs recently is Alameda County Central Labor Council, that I thought you should be aware of as well.
Okay. Good morning, Larry Woodson, California State Retirees, and thank you for allowing me 5 minutes. I speak on behalf of our president, Stephanie Hugh, and our 43,000 members, many of whom chose traditional Medicare as their preferred plan. I hope the report I sent you last week and the staff detailed information about the shortcomings and dangers of ACO REACH was helpful. First, I want to address the presentations by Dr. Fowler and Dr. Chen. The traditional ACO models that Professor Chen describes, like the MSSSP ACOs that have been operating for 10 years or more, should not be conflated with the REACH ACO. There are significant differences, and I think you've heard that. Center for Innovation erroneously states in their material, and I've heard it today, that REACH ACOs are a group of doctors who come together voluntarily to provide better coordinated care. Most REACH ACOs doctors did not volunteer. The 1,140 PCPs that were at Sutter, they didn't volunteer to come together in a DCE. Their corporate entity that they work for, Sutter Health Inc., made that decision, and they were captured along with all their patients and tens of thousands of patients, and they're automatically brought in without prior notice, without their consent, and are informed after the fact in most cases. I attended a webinar in which a keynote speaker, who was a physician in Indiana, whose corporate board overseeing the practice, informed him he was now a DCE doctor. He knew enough about it. He didn't want to comply. He was told he didn't want to be a DCE doctor. He was told he must. Those are terms of his employment. and if he wanted to continue with them, he had to be a DCE doctor. He was also told that he didn't really need to do anything differently in REACH, which is surprising. So, secondly, research by independent academics show pre-REACH ACO's impacts on Medicare spending over the last 10 years has been negligible. 0.4% lower cost in some years, 0.3% higher in some. And a lot of the failures of the ACOs are based in part on the false assumption that fee-for-service incentivized doctors to order unnecessary tests and over-refer to specialists. And I know people here believe that, but the Commonwealth Fund and other researchers have demonstrated that higher utilization of services is not the driver of higher costs, but higher prices for drugs and services are. Additionally, PE's acquisition of healthcare providers from hospitals to physician, PE private equity, from hospitals to physician practices and nursing homes has driven costs higher, but compromised patient safety. And yet CMS has approved scores of PE companies as DCEs and now more as ACOs who maximize profits by stretching their doctors thin and not paying for needed staff. 15 of the newly approved ACOs, I just went through this and found them, have limited experience in managing Medicare. They're called new entrants. That's scary. Dr. Fowler said they're carefully screened, but it doesn't sound like it. REACH proponents state that ACO REACH beneficiaries can still choose any hospital or doctor that accepts traditional Medicare. In practice, that is difficult. First, they assume that TM beneficiaries captured by REACH know that they have that option. We have some evidence that members never received the CMS mandated letter, which informs them of that right. And many may not have read the letter, since at the very top it says in bold, required annual notice, no action necessary. How many read further? The letter nowhere tells the beneficiary that they can opt out of REACH by finding another PCP, which, by the way, is not easily done with 80% of PCP practices closed. ACO REACH beneficiary may, I'm going to skip this. I'm just going to, because I'm running out of time. In conclusion, we believe REACH will be harmful to our CalPERS retirees. It incentivizes denial of care, will deplete Medicare Trust Fund more rapidly than TM, and have the resources, and they don't have the resources or capability to effectively monitor the program, as demonstrated by their inability to stop Medicare Advantage companies from extensive and sometimes fraudulent upcoding. So we ask you to join 250 local, state, and national organizations and 54 congressional reps asking President Biden and Secretary Becerra for termination of REACH. As the largest pension fund in the country, your opposition could have considerable impact. We ask you for your support in saving traditional Medicare. Hope you will vote on this soon.
Good afternoon.
You have to turn yours on.
Oh, it's on now.
There it is. It's on now.
Okay, thank you. First time here.
I don't have that control. Apparently they do.
My name is Rosemary Knox. I'm president of the Retired Public Employees Association, known as RPEA. I am a retired registered nurse, so I'm very well aware of the issues that are before us. I would like to read that the Medicare Advantage program has become an enormous cash cow for insurers, in large part because the way they have rigged the risk scoring system to maximize profits. The Center for Medicare and Medicaid Services estimate a net overpayment to Medicare Advantage plans by unconfirmed Medi-Cal diagnoses at $11.4 billion for 2022. And that's just 1 year. Can you imagine what happened? Despite the recent changes and goals for better care, critics remain skeptical of the new model. The Congressional Progressive Caucus claims that it enables third-party middlemen to manage care without seniors' full understanding or their consent, and often through for-profit businesses with incentives to restrict care. The group recommends ending the new REACH model, purporting that the model just puts money in the hands of investors at the expense of American seniors. Thank you.
Thank you, Ms. Knox. I appreciate it. I'm going to excuse the three of you and call three more up. I've got Mark Hynum, John Gilman, and Kathy Jepson, if you want to come up here. So I have Mark as our first speaker.
On here.
There you go.
You know, I've been coming here many times, and this is my first time to speak before the board, so thank you for the opportunity. Good morning, good afternoon. My name is Mark Hynum, and I'm a retired physician and also a California state retiree. I am a med-peds specialist trained in both internal medicine and in pediatrics. In my career, I've managed healthcare in a variety of settings in both private and in government organizations. I'm here today as a volunteer on the Health and Safety Committee for California State Retirees. I wish to share with you in 3 minutes just some of my concerns about ACO REACH program and how it will directly affect California state retirees. Number one, unlike other yearly insurance CalPERS plans, California state retirees do not choose to join the ACO REACH program. They are told that they now belong to this plan. They can opt out, and only if they receive a letter from the ACO REACH entity. I wonder how this can happen in America, to be very frank with everyone here. Number two, in the ACO REACH program, for-profit companies, and to my amazement, even private equity firms, are allowed to manage California retiree health care. Many of these entities have no prior health care experience or Medicare experience. Do we really want private equity to manage our health care? I would say no. Three, coordination of care through a primary care provider is promoted as a benefit of belonging to an ACO REACH entity. This is a wonderful thing. No physician would object to this. No person involved in healthcare everyone would support this. However, there's a problem here. There's already a very significant shortage of primary care providers in California. By one estimate, 4,700 primary care providers additionally are needed in California by 2025. And another 4,100 primary care providers will be needed in 2030. And these providers will not come from other states. A 2021 study estimates that there will be a shortage of up to 124,000 physicians in the U.S. by 2034. So there's not only a very substantial profit motive to delay or deny health care in this program, but actual attempts at coordination of care will itself likely lead to significant delays. This is because there aren't enough primary care providers already. And the ACO entities will have primary care providers that are overwhelmed with very large panel size and can't even communicate with their patients on a regular basis. I would recommend that the Medicare Center for Innovation should instead start working on developing innovative programs that will increase the number of primary care providers in California and in the United States. For many years, CalPERS has been a national leader in providing quality and affordable health care insurance to retiring state employees. I'm proud of that. I'm a beneficiary. The board and the program should be proud of that as well. I am urging the CalPERS board to join with many other retiree organizations and oppose the ACO REACH program. Thank you very much.
Thank you. John Gilman, please.
I'm on. Okay. Madam Chair and members of the board, thanks so much for the opportunity to speak today, and I've enjoyed the discussion that's gone on today. My name is John Gilman. I'm a retired ophthalmologist and an attorney and a health policy consultant. I retired from state service as a principal consultant with the Assembly Health Committee, where I served for over 8 years, and before that, I was a health policy advisor in the U.S. Senate in Washington, D.C. I'm speaking today as a member of the Health Benefits Committee of the California State Retirees, and I'm urging the board to take a position opposing the ACO REACH program. Let me just make 3 points. First, Medicare beneficiaries and CalPERS members already have the option of choosing managed care by choosing a Medicare Advantage plan, but seniors on original Medicare have chosen not to enroll in managed care, and they shouldn't be forced into it through ACO REACH. Second, the incentive for direct contracting entities that participate in ACO REACH is to maximize profits, and they're going to do that by reducing care or gaming the system by upcoding risk. The participation of private equity makes it clear that private equity's stake in healthcare is financial. I mean, it's not care. That's what people invest in private equity plans, investments. Private equity's goal is maximizing profit in as short a period of time as possible, and that's no way to improve care. Finally, just let me read some headlines that maybe you've seen that have been in the news in the past few months. Now, these headlines today pertain to Medicare Advantage plans, but tomorrow these same headlines, I'm quite sure, will be there for ACO REACH unless it is stopped now. One of those headlines from a few months ago, government watchdog attack Medicare Advantage for denying care and overcharging. Another, beat cancer. Your Medicare Advantage plan might still be billing for it. Firms mined patient records for outdated, irrelevant conditions to increase profits. The cash monster was insatiable, how insurers exploited Medicare for billions. Most large insurers in the program have been accused in court of fraud. That was the headline. Hidden audits reveal millions in overcharges by Medicare Advantage plans. And this from Kaiser Health News just last week. Big health insurers plan legal battle over Medicare Advantage audits. So basically, the government's trying to come in now, finally, maybe, and do a decent audit of these Medicare Advantage plans, but the big insurers are trying to protect the money that they've overcharged and obviously trying to keep it. So don't forget that Medicare Advantage was promoted as a privatization scheme that would reduce costs while improving care. Isn't that how ACO REACH is being promoted today? So like I said, the headlines I've just recited there are the same headlines that we're going to read about ACO REACH in a few years. Just as Medicare Advantage plans have been able to game the system, so will these ACO REACH entities. The one way we can avoid those headlines is by stopping the ACO REACH program now. On a theoretical basis, on some theoretical basis, it does sound like it's a good way to go, but we have the experience already. Through Medicare Advantage plans, and these entities are going to have the same incentives, unfortunately. So I urge you to oppose ACO REACH. Thank you very much.
Thank you, Mr. Gilman. Ms. Jepson.
It's on.
Yes.
Thank you. Happy New Year. It's
Happy
great
New
to
Year.
see all of you. I'd like to thank you all, the panel, especially for an absolutely robust discussion. Great questions by the board, good panel discussions. I just have a couple of comments. I really can't make a decision in my own mind whether you should go with affordable care or not. I probably will go and agree with a lot of the public comments that maybe we should hold off a little bit. But anyway, what my concerns are is that I have a problem with having private equity investments in ACO REACH. If this were an investment committee, my answer would be very different. It would be pro the private equity. But as Frank said, the primary purpose is to make money for investors, and that's really not what we should be considering when we are talking about quality medical care for CalPERS beneficiaries. I did get a very quick answer, and thank you, Marcy, for that, for so quickly. Before lunch was over, she had an answer for me. As we have heard, the letters that come, if you get a letter that comes to the participant that you have been changed to an ACO, really do not list the opportunities that you have to opt out. And as they were mentioned, my question was, well, if you can opt out, the open enrollment at CalPERS is only once a year, and what do you have to do? Wait. And Marcy got me an answer that said that you didn't, if you decided to opt out, you do not have to wait till the open enrollment period, which was very nice. I am concerned because what they have stated is that if you join ACO, you will have more patients. And with the doctor shortage that we have in California, I think that's going to be a real problem. I know it's hard enough to get an appointment with your doctor now, and it's going to, I think, become even worse if you have more patients, as they admitted that you have in the ACO. I'm running out of time, so I know that there's a lot of people, so I'm going to say thank you for allowing me to speak.
Thank you, Ms. Jepson. I think we're over to the phones now, so Mr. Behrens and one more person is waiting on the phones. Oh, Elnora, I'm sorry. I totally went by you. I know, right? Oops.
I wasn't going to say anything, but thank you. Okay. Eleanor Hunter Fretwell, state retirees. I'm going to make it short. I'm not going to repeat what everybody said. I would just want to make a comment on when Frank asked the young lady that's gone to the airport already about how can you tell if they're charging more money, helping us less and stuff like that. And the example that she gave, I didn't really understand it because she was saying that the lady was 90 years old. She went to the emergency room about 6 times and couldn't get help. So then all of a sudden she joined ACO, and all of a sudden her daughter was able to reschedule appointments so she can come and not miss work. But on those things, you can already do that. You can already schedule your own appointments. You can go online and look at those and get those and not go. Her daughter can get her care. She also said people come out to the house now because she's on ACO. We already have nurses that come out to the house already with the health care that we have. She also said they was training her how to help herself with different things. If you're a diabetic or something like that now, you can take classes already, and they'll teach you how to do those things. So the things that she gave an example about to Frank exist already. So I was kind of confused about how is that a good example. What I came up with was that her daughter probably needs to know the mother's benefits and get more training on how to help her mother versus having her mother change over to ACO, because every example she gave exists already in the health care that we have. So if that's the case, I don't see why we would need ACO to change over. So that's all I really wanted to say, because everybody else kind of said everything else. Thank you so much, and congratulations for all the new board members too. All right, thank you.
Thank you, Eldora. I'm sorry, now we're off to the phones. So that's Tim first, and I don't know the name of the last person. Is it Kelly that's doing the phones? It's David. David, do we have anybody on the phones? Hello?
Tap dance music.
I know, right? I forget where that's from. Wheel of Fortune. I don't know. Are they not there, maybe? Did they fall off? I think Kelly's going to go check right now.
Okay, Madam President, can you hear me now?
I can. There you are.
Oh, all right. So, the 7th time's a charm on unmuting this thing. Tim Behrens, go ahead.
Hello, good afternoon, President Taylor, members of the board, Tim Behrens from California State Retirees. I urge the board to take a position opposing ACO REACH. I agree that one of the previous speakers made a point that actually ACO REACH is a form of contracting out. I wonder whether or not CalPERS and the board has thought this out and how it will impact the union members currently working at CalPERS. How can the stakeholders expect to receive the same level of services from Medicare when independent companies are being promised a 25% plus profit, and the only way they can do that is to either delay or restrict special needs for their medical health? I urge the board to take an opposition to ACO REACH on behalf of the CalPERS stakeholders. And I'd like to finally say, what's the expected savings for CalPERS if all stakeholders fall under the ACO REACH proposal in the state of California? Thank you and have a good day.
Thank you, Mr. Behrens. Next, Mr. Takert.
Madam President, we have Honey Kelly next. Go ahead.
Hello? Can you hear me? Yes, we can. Hello? Okay. My name is Henny Kelly, and I am a retired teacher. And I will tell you that I have been called this year 116 times asking me to switch to different Medicare programs, many of them the ACO REACH. Right now, I am enjoying having Medicare, but I really do believe that when you listen to those people earlier, the two women who are trying to check on ACO REACH, they said at least 50% of the people in the second year were not the right companies for it. Well, I think that there are an awful lot of companies that are going to come in just to get those profits from that and take away the help that seniors need to age in place and to get good medical care. I am one of the legislative committee of the California Alliance for Retired Americans. And our organization, as you heard before, wants you to vote no. I personally want you to vote no because I really believe that if we go to this OCO REACH program, basically there won't be any Medicare for my children or your grandchildren. And that's what I worry about. Profit will be taken by big companies, and the money will not go to help people who are seniors or people with disabilities who need Medicare. Thank you.
Thank you. Is there anybody else, Mr. Takert?
No, Madam President, that's all.
All right, thank you. Is there anybody else in our room? It doesn't look like it. I just want to reiterate that we don't have say over CMS. Just everybody be aware of that. I still, encourage you guys to engage with our health director and our health office. And Dawn, if there's additional questions that you're finding out from the members, then just bring it forward to us. I'd appreciate it. So with that, I'm going to move forward to our next item on our agenda, which is current trends in investing and sustainability.
We've had to delay that session until the March.
The whole thing?
The whole thing.
The
has to be
whole
delayed.
thing.
Yes, our speaker is in Davos, which is 9 hours ahead, and so with the delayed start.
Oh yeah, now it's midnight, isn't it?
We needed to reschedule that for March. So we can move on to the next.
Okay. So then we are in fiduciary training. So the most exciting part of our day. I know. What'd you say?
Better now than another night.
Yeah. I know. So how about this, you guys? Why don't we get set up? Let's take 2:25. Let's come back at 3:35 or 2:35. An hour and 5 minutes? No, 2:35. So we'll be right back. Calling the meeting back to order. And we are in fiduciary training, and I'm going to throw this over to Matt.
Very well. Well, good afternoon, Madam President and board members. I'm pleased to introduce the annual fiduciary training, which, as you know, is a requirement of the board governance policy as well as the education policy. And I'm pleased to introduce two of our outside fiduciary counsel, Ashley Dunning to my immediate right, and then Lance Olson 2 seats down. These are really two of the best attorneys in the state in their respective areas of expertise. They've been relied upon for many, many years by pension boards, trustees, elected officials, and candidates. And Ashley will start by giving you the ABCs on your fiduciary responsibilities. Then Lance will provide a primer on the law of conflicts of interest, the Political Reform Act, and Government Code 1090. I'll be standing by as well for any questions you have you may have for me, as well as my colleague and expert, in-house expert, Robert Carlin, who is sitting directly behind me and supports the board throughout any kind of questions that they have on these types of issues. So with that, I will kick it over to Ashley to get started.
Thank you, Mr. Jacobs. Good afternoon, members of the board. Very nice to see you all in person. It's been a number of years. And that's the presentation that I hope is this one in front of me, because it doesn't have the same graphics, but we will get started with that one.
I think you have.
I think that's the one we have.
Okay.
Oh, maybe not.
It has the same text, so that's
Yeah, it
good.
is.
That's
Yeah, it
a good
is.
start. All right, so as Mr. Jacobs said, I'm giving you a primer on fiduciary duty, but I do hope to provide you with some of the complexities of it, because many of you have been trained on fiduciary duty. I have been in this role for quite a long time, and I hope that this is helpful for all of you, as well as those of you who are newer to this position. I will start with a discussion of what makes you a fiduciary. All of you on this board are fiduciaries, that's a given, but I'm going to talk about what it is about the aspects of your responsibilities that make you fiduciaries. And then I'll talk about some of the 5, what I think of as the 5 key fiduciary duties that apply to you as public retirement system trustees. So that's different from me as a fiduciary. I'm a fiduciary to my clients. I have different responsibilities than you as fiduciaries have. And then finally, I'll talk a bit about delegating a fiduciary duty, obviously with a system as enormous as CalPERS, as well as smaller public plans. It is not to you to manage the ins and outs day-to-day of the payment of benefits, for example. And therefore, there's a lot of delegation involved by you as a board. And fiduciary law says a number of things about that, too, what your responsibilities are in the context of delegation. So starting with that first question, which is, what is a fiduciary? In California and in the law that we turn to when we're analyzing these issues, we often look to the Restatement Third of Trust. We look to some degree to tax law, but you're a tax-exempt organization. You're not subject to ERISA. And so there are some limits to that. Nevertheless, the definition of fiduciary in both of the sources quoted here is very useful. And that is that a fiduciary is a person who exercises discretionary authority or control over the management or disposition of plan assets, renders investment advice for a fee or other compensation, or has discretionary authority or responsibility for plan administration. Discretionary is a really key word in that clause. So key concept, as I pulled that language out for the second bullet point, is that if you exercise discretion over the administration of, in this case, CalPERS, or the investments of CalPERS assets, you are likely a fiduciary. And fiduciaries, to state it very bluntly, must act with a very high standard of care and loyalty. Fiduciaries, the definition is often described as a functional one. If you do things that make you a fiduciary, you may be deemed to be a fiduciary. And when I say you, I'm not speaking to you as trustees, because you all are already fiduciaries, as I said that, but others at CalPERS may be deemed fiduciaries, even if they did not intend to be, or even if there are contractual provisions that say they are not. And so that sometimes worries those with whom you do business. If they are assuming a discretionary role on your behalf, they may well be deemed to be fiduciaries. So the message here to a general audience is beware of the inadvertent fiduciary, such as an employee whose efforts may are aimed to be helpful, but they're straying into the area of fiduciary. People and entities are fiduciaries as a result of their relationships with one another. So it's usually somebody, or generally applies to somebody who occupies a position of particular confidence with respect to another. So I mentioned the example earlier. I, as an attorney, have a fiduciary responsibility to my clients. But that relationship and that responsibility applies only with respect to that particular engagement. It's not a general proposition that for every single purpose I act as a fiduciary for that person. Similarly, you have fiduciary responsibilities to the members and beneficiaries of CalPERS with respect to your responsibilities on the CalPERS board. Appointing a fiduciary, so in the context of delegation that we're going to talk about, appointing a fiduciary makes you a fiduciary with respect to that appointment. And there are ongoing monitoring responsibilities that come with that delegation. We'll talk about that as well. So here are some examples of fiduciaries. The first one is what we're talking about primarily today, and that is the CalPERS board and its committees are fiduciaries. Critically, I put in the caveat, with respect to their responsibility to administer CalPERS in the overall best interest of the members and beneficiaries of the plan with respect to their CalPERS benefits. It's important to think about all aspects of that plan. You're not fiduciaries to your members and beneficiaries with respect to something that doesn't pertain to CalPERS, something that pertains to their day job, perhaps, or some other thing that they do in their lives. You're responsible to them with respect to the security of their retirement benefits received to be received in the future from CalPERS. And individual members of the board and in-house staff, each of you individually, as well as the entity, the organization, and the board, have fiduciary responsibilities with respect to whatever their responsibilities are with respect to CalPERS. What are non-fiduciaries that we're familiar with? So an employer or a settler, in this case, the state of California, or your participating employers, your contracting employers, they do not have fiduciary responsibilities. They have other responsibilities, but they're not fiduciary responsibilities. Record keepers are not fiduciaries. Auditors are typically not fiduciaries. All right, I think I've exhausted the topic of who is a fiduciary, and I'll move on to the 5 basic duties of public retirement board fiduciaries. I list them here. I'll talk first about the duty of loyalty, moving to the duty of care. In my other presentations I've given to you, I've often talked about those as the 2 prongs, and they are the 2 main prongs. But then I focus on 3 more that are set out specifically in the California Constitution and really pertain so directly to what you do as the board of CalPERS that I focus on them here. The first is diversifying the investments of the fund. That is a fiduciary responsibility set forth in the Constitution. You also have the duty to assure the competency of the retirement assets to pay the promised benefits. That's a lot of words, but what does it mean? It means you have to have enough money on hand to pay the promised benefits when they're due. You don't need to have it all today for purposes of paying benefits that are due in 10 years, but you have to have a plan to get there that's a reasonable one. And you have a duty to administer the plan in accordance with the plan terms and applicable law. You're not making things up here. It's a statutory plan. You're applying the benefits that are afforded by statute as sometimes further refined through your regulations. Duty of loyalty. That is primarily characterized by the exclusive benefit and fiduciary duty rule within fiduciary law. The California Constitution, Article 16, Section 17 is where you find this recitation of fiduciary responsibilities, and stated very simply, you are to act solely in the interest of and for the exclusive purpose of providing benefits to participants and beneficiaries of CalPERS. Under both constitutional and statutory law, that exclusive benefit and primary duty rule takes precedence over any other duty. And as I said, it's referred to as the primary duty law. In the California Constitution, there's a reference to the duty to minimize employer contributions. I get a lot of questions about what that means. That does not mean that you minimize employer contributions to the detriment of your ability to pay promised benefits. What it means is that you do not overcharge the employer. It means that you manage the fund in a prudent way so that you are being cost sensitive. You are not overfunding the plan simply to do so. But it is, as I said, secondary to the primary duty to members and beneficiaries, and it's not actually a fiduciary duty. Sometimes people will say, oh, well, that's a fiduciary duty too. It's not, because the fiduciary duty flows in one direction. It flows from the trustee to the beneficiaries, and the employer is the settlor or the trustor in trust law. And to that point, when if a fiduciary puts a third party's interest ahead of that of the overall best interest of members and beneficiaries, that can constitute a breach of fiduciary duty. Whether you're putting the plan sponsor's interest ahead of the members and beneficiaries, or you're putting a union's interest ahead of the overall best interest of the members and beneficiaries, or some other third party. That is not the way the duty of loyalty, that is not permitted under fiduciary duty. It's basically a conflict of interest rule in a sense, that you have this duty of loyalty, and Mr. Olson will talk with you about the two primary conflict of interest statutory and common law-based rules in California. But the premise in fiduciary law of that conflict of interest principle is that you cannot have conflicting loyalties. You can't use your role as a fiduciary to benefit someone other than the members and beneficiaries in sort of a broad sense. All of that said, it is recognized in trust law that the duty of loyalty, particularly when you have different types of beneficiaries as you do in a public pension plan. You have retirees, you have actives, you have deferred members, you have safety members, you have miscellaneous members, you have people who are in PEPRA tiers, you have people who are classic members. All of those members may have quite different interests with respect to the decision-making that you are engaged in. And you are engaged in a prudent process and complex decision-making when deciding on the best course of action. But the framework should be, as to all of that important decision-making, what is in the overall best interest of all of our members and beneficiaries in the long run? And the appropriate balance may not be obvious when their interests are different. If you have retirees who are no longer paying contributions into CalPERS, their interests may be different from those of your active members. As I mentioned, your PEPR and your classic members, they may have somewhat different interests from one another. People who joined yesterday are going to have different interests from people who have 30 years of service. But dissimilar interests among beneficiaries are built into most trusts, and as I said, trust law has evolved to grant you a fair measure of discretion to balance those interests and think about them. But you need to be deliberate about it as you exercise your judgment in decision-making on those topics. Very importantly, trustees are not permitted to administer the retirement system as an agent for how you got here, for the one who appointed you, or the entity that appointed you, for the group of members who elected you, or in the case of ex officio members, because of that ex officio position. Once you're here, you're all fiduciaries, you wear the same hat, you're co-fiduciaries to one another. You take off that hat when you leave and you do your other day jobs, but when you're here, you have that fiduciary hat on, and you're not sitting on behalf of another. Of course, if you're a designee for somebody else, you're sitting for that person in your role, but all as co-fiduciaries. The topic of collateral interests comes up not infrequently, and the restatements is pretty straightforward in the way that it discusses this, and it discusses it in the context of managing investments of a trust, that ordinarily a trustee's decisions are not to be motivated by a purpose of advancing or expressing a trustee's personal views concerning social or political issues or causes. That does not mean that as an organization you can't make judgment calls about prudent investing, for example, in a way that incorporates environmental or social or governance considerations. You do, and you may, assuming that that is the appropriate consideration with respect to whatever decision you're making on that topic. But the restatements make it clear that collateral interests are not permitted if that is what's motivating, that personal view is what's motivating the decision. I have a hypothetical here that I'll say, without having forewarned Mr. Olson, also implicates potentially some California conflict of interest rules, possibly 1090. But I'm not here to talk with you about that. I'm talking with you about the fiduciary context of this hypothetical, which is you have a hypothetical member of the Board of Administration. That member is an active member of PERS and works in the IT department of PERS. The board is considering replacing its IT department, its pension administration system, and it's deciding whether or not to do an RFP for an outside consultant or to pay for the state's IT department personnel to advise on the matter. Assuming for purposes of this discussion that we haven't asked Mr. Olson for his advice on whether that's appropriate from a 1090 perspective when you're acting for your departmental employer, hint, hint, to all of you. Think about it from a loyalty perspective too, just setting aside the potential recusal requirement here. The person is employed by the department that is going to be greatly benefited by this potential decision to forego an RFP and instead use the state's IT department. Is it appropriate from a duty of loyalty perspective for the person to take that into consideration or not? Or what should be discussed? What should be done? How should you document? They have to be very careful, if they are permitted to participate in that decision making, to document the rationale for why they think it should be done by the state if that's their conclusion. Or they may prefer to avoid any of the conflict of interest risk and say, let's consider all of them. Let's do an RFP, but let's also allow the state to be considered as an option, and then you can consider the cost, you can consider the service to be provided, et cetera. But it raises a fiduciary duty of loyalty question. And I'm not providing answers here, I'm just posing the questions for thought. The second hypothetical is an actuarial one. So the board is consulting with its actuary on the appropriate assumed rate of return for CalPERS. The CalPERS actuary recommends reducing the the assumed rate by 50 basis points, which would raise employee contribution rates and employer rates quite a bit. Devon objects to, this is the same Devon who is an active member, objects to the recommendation on the ground that the employee contribution rate increase shouldn't occur because he is an employee and other employees can't afford that increase. And a fellow board member, Marie, who sits on a city council of a city that's a contracting employer with PERS, objects to the same recommendation on the grounds that the city can't afford it. So query the record that's being made here, query the considerations that are being expressed. Because in each of those instances, the board member who's an active member is talking about their personal interest in not paying more contributions, and the board member who is a member of the city council of a contracting employer is expressing the financial interests of the employer. When the proper fiduciary consideration is why is your actuary recommending that the return rate of return assumption be discounted, to be reduced? Is it because under the current framework, you're not collecting sufficient assets to pay the promised benefits? Well, if that's the case, your duty is to make sure that you as fiduciaries are collecting sufficient assets to pay the promised benefits on time. To repeat what I said earlier, that's the hat you're wearing on this board, and those are the considerations that should be expressed. It is not to say that it's not appropriate to talk about or think about, to consider among yourselves the impact on your members, on their contribution rates, or on your employers. That it's not that that is some sort of a breach. It's that that can't be the motivating factor that ultimately results in how you reach your final decision. Turning to the second large topic, which is second prong of the fiduciary framework, which is the duty of care. The Constitution describes the fiduciary duty of care as I've quoted it here: you're to act with care, skill, prudence, diligence, then prevailing, that a prudent person acting in a like capacity and familiar with these matters would use in the conduct of an enterprise of a like character and like aims. I quote that because all of the words in that statute or in that constitutional provision have meaning. Very importantly, you are not acting as a layperson on this board. You're considered to be a prudent fiduciary with experience, which means you need to get that experience. You need to keep yourself up to date in the areas of knowledge that are required for somebody to act as a prudent fiduciary. And it also means you may well need to consult with experts and with others in order to be a prudent fiduciary with experience and comply with the legal standard that applies to you. Good faith is not enough. And I've quoted here from a relatively recent California Court of Appeal decision, which noted that, quoting the Restatement of Trusts, that an abuse of discretion occurs when a trustee acts from an improper, even though not dishonest, motive, such as when the act is undertaken in good faith, but for a purpose other than to further the purposes of the trust, or more specifically, the purpose for which the power was granted. So an example that I provide here is if the board, sympathetic to an ailing member, whom the competent medical evidence demonstrates is not eligible for a disability retirement allowance, instructs staff to grant it nonetheless, or to provide it nonetheless. So the member might say, you owe me a fiduciary duty. Why are you not granting me my disability retirement that I've applied for? And the response is, if the person's not eligible, they're not eligible, and it should not be granted. That is in compliance with your fiduciary responsibility. It's not a violation of your fiduciary responsibility. As I mentioned, the prudent standard is not that of a prudent layperson, and I've quoted a case on that because that comes up quite a bit. Also, note that courts do probe the thoroughness of the review that you do as fiduciaries on matters to see if you've complied with your fiduciary duty, and they will analyze the bases for your decisions. Importantly, fiduciaries don't need to be experts themselves. They need to inform themselves in a way that you exercise your fiduciary prudence with experience or meet that standard. But there are most certainly many times where you will need to consult an expert. When using experts, the fiduciary may take into consideration the advice of the experts, but ultimately, you as a board are responsible. Duty of prudence doesn't require a fiduciary to guarantee specific outcomes, but it does require a prudent process. And I've divided these slides into procedural prudence and substantive prudence, because sometimes I've heard fiduciary trainings that focus a lot on procedural prudence, which is really important, but don't mention substantive prudence, and I'd say they're equally important. The duty of prudence, as I said, is referred to, the one I'm talking about now is procedural prudence. It's the ability to demonstrate that the fiduciary followed a prudent process in making a fiduciary decision. It highlights the importance of documenting the fiduciary considerations that you are engaging in or that you have taken into account with respect to your decision making. The standard that's used to assess whether you have complied with the law or not typically will be whether your decision is arbitrary or capricious, or fails to follow procedures required by law, or doesn't follow the evidence that's presented to you. So it's really important in terms of your procedural process to make clear the connections between the information that staff has provided to you, that your consultants have provided to you, and the decision making that you're engaging in. What does it look like? Certainly acting consistently with the laws and the plan governance documents. So, for example, your regulations, and your council will walk you through those on matters as they come to you. What is the rule that applies to this case, to this circumstance, and it is for you to follow those. It also means that those will need to be updated from time to time as circumstances change. Not necessarily the statutes, those aren't within your purview, but your regulations and perhaps other policies that you have. To the extent that you've delegated certain of your fiduciary duties, systematic reporting by those to whom you've delegated the responsibilities and your continuing monitoring of them is important. Documenting your decision making. So making sure that your documents show the factors that were considered, the information that was provided, who provided the information, and what you concluded. The comprehensive agenda packet material that you get on your topics are exactly why you have that, in order to be able to give you the information that you need to make prudent decision making, and also that it's showing your prudent process, hopefully. Turning to substantive prudence, even if you've gone through the most prudent process, courts will look to what you decided to decide whether or not they agree, frankly. They will afford you deference because you as the CalPERS board and your staff are deemed to have, and do have, a type of expertise that the courts don't have. But that deference will not be provided if they think that you haven't followed, for example, CalPERS law. So it is really important to remember that. And one example of that, which is not in a CalPERS context, but it was an ERISA case, which, as I noted, does not apply to you, but sometimes because it applies fiduciary principles, we look to those cases for guidance. And in the Tibble case, which was a U.S. Supreme Court case, the Supreme Court said that a particular investment that an ERISA plan had maintained and not disposed of constituted a violation, or could well have constituted a violation of their fiduciary duty of care, because they were paying more for it than they could have if they simply purchased an institutional class of the exact same investment. They had purchased a retail class of that investment. So courts do look behind the prudence, do look behind the documentation, because there the board had been advised by various different audit firms that not audit firms, advisors, consultants, experts, that it was a fine investment. And notwithstanding that advice from the experts, the courts found it to be a breach. Final topic on duty of care relates to the confidentiality of information you necessarily receive as CalPERS board members. You will receive people's medical information. You will receive investment managers' proprietary trade secret information. You'll receive attorney-client privileged information. Assuming all of that information is properly provided to you as privileged, you have a fiduciary responsibility to maintain it as privileged. Okay, so it's imperative that you as board members respect that and do that. Just as you're not considered a layperson with respect to your fiduciary duty, there's also an absolute understanding that you're not an expert in necessarily the law that applies to you, the actuarial responsibilities, the investments, et cetera, and a prudent fiduciary will consult with experts as to those matters. The implicit corollary of that, though, is that if your expert is advising you to take a particular action and you don't care to, the advice that you should be getting to assist you with that determination also needs to be provided by other experts. So it shouldn't be simply a I don't want to response. Some of the common pitfalls for fiduciaries that have occurred include not doing what the law and the governance documents say, having no record of what was consulted, having no record of what decision was made. I can't imagine that happening here, but I just note it for purposes of comprehensiveness. And having a record of the decision itself, but having the decision be deemed to be unreasonable by a court. So again, they'll look behind the decision sometimes. Here's a hypothetical on the fiduciary duty of care. This involves a board member becoming fascinated with cryptocurrency and asking the board's investment consultant to speak with the board about the potential investment opportunities for CalPERS. These are truly hypotheticals. I'm not alluding to anything specific. The investment consultant presented on the topic and discouraged the board from allocating any material portion of the trust fund to cryptocurrency because of valuation and accessibility concerns. The board didn't like that answer, hired another investment advisor to opine on the same topic. The advisor urged the board to commit 10% of the assets of the fund to cryptocurrency, and the board did so. The following year, cryptocurrency lost 25% on average in a year when all the other investments in the asset classes from which CalPERS had moved funds grew by an average of 10% in the same time period. So, continuing with that hypothetical and looking to how that might be analyzed, I note that from a procedural process standpoint, the documentation to support that final decision to invest is going to be really important because it needs to answer the questions of why did the second investment advisor recommend investing in cryptocurrency? It may have been perfectly legitimate, it may not, but you really need to have that documentation to support the prudence of the board's decision making. And did the second investment advisor's experience and skills warrant following its advice? The person may well have been perfectly qualified to provide that advice, or they may not have. And that's going to be examined very carefully in this particular context if you were challenged. And then also being able to explain the substantive rationale for the action. So was the second investment advisor's advice reasonable when given? Under the circumstances presented at that time, was it reasonable, notwithstanding the results? Turning quickly to the duty to invest, to diversify investments, that is a specific provision of the California Constitution. Article 16, Section 17 says that fiduciaries on public retirement boards shall diversify the investments of the system so as to minimize the risk of loss and maximize the rate of return, unless under the circumstances it's clearly prudent not to do so. So if it's clearly prudent not to diversify in a particular way, you don't need to. Otherwise, it's a diversification mandate. So I note here, because it's a preface to the next slide, that ERISA, again, doesn't apply to you, but it's looked to for some guidance at times, and there can be some analogies drawn, particularly when you're looking at ERISA plans that are defined benefit plans as opposed to defined contributions, except to the extent that you're looking at this in the context of a defined contribution plan, in which case ERISA may be, some of these cases might be applicable. So diversification is generally considered based on the plan's entire portfolio. And I cite here some of the factors that are considered in some of the ERISA cases about when looking at diversification and looking at investments and their prudence. And I won't read those to you because they're on this slide. Diversification mandates, question mark. So, excuse me, divestment mandates, question mark. I have that question mark because when you have a diversification mandate, you would think that that was the exact opposite of a divestment mandate, because it's an anti-diversifying move to divest from something. However, divestment is permitted under California law so long as it is fiduciarily compliant. And that is why in the various statutes that that the legislature has adopted requiring CalPERS to divest from various different types of parts of the world or types of assets subject to your fiduciary responsibilities, you have that fiduciary savings clause. And that's why you go through the analysis on a periodic basis to assess whether that divestment remains prudent and consistent with your fiduciary responsibilities otherwise. It's care and loyalty. Next major responsibility as a fiduciary of a public pension fund in California, and as to CalPERS, is to assure the competency of the assets of the fund to pay the promised benefits. I cite the language here. In O'Neill, which was a case I mentioned earlier, it was a case that was brought against one of the county retirement systems. The petitioners had challenged the board on various of its retirement board decisions relating to actuarial methodologies. They challenged having an amortization period of in excess of 17 years. It challenged transfers of funds among reserves, claiming that they were in violation of their duty of loyalty to the members. Ultimately, well, actually, initially, the Court of Appeal who considered that case decided that it was not a breach of the fiduciary duty of care because the decisions were sufficiently prudent based on the record. But the court did make the case go back to trial to assess the duty of loyalty question and whether the trustees had considered the proper factors when making those decisions. Again, illustrating the importance of each of you having your duty of loyalty hat on, your duty to members and beneficiaries, and the security of their retirement benefits, on, that hat on when you're making your decisions. Finally, the duty to act in accordance with plan documents and other applicable law. I cite a couple of cases there. It's just a continuing important mantra that that is forefront, that your duty is to apply CalPERS based, or laws that apply to CalPERS to your members with respect to their benefits. Delegation of fiduciary duty. The restatement says you're supposed to do all of this yourself personally unless a prudent fiduciary would delegate. And thankfully, a prudent fiduciary as to CalPERS most certainly would delegate. And what do you do? How do you do that delegation? The board delegates to its own committees, and it also delegates to staff. When the board, committees, or staff themselves delegate fiduciary duties, those delegees generally become fiduciaries to the extent of the duties to which they were delegated responsibility. Effective delegation is a key component to managing fiduciary risk, and appointing a fiduciary is itself a fiduciary function, so long as you're doing it for the proper reasons, and I've recited those again here. Prudence is the key to delegation. First of all, whether you do it. Second, how. Third, to whom. And fourth, how you supervise once you've delegated. Fiduciary responsibility doesn't end with the selection of that delegee, though, because your responsibility continues to monitor and provide the type of oversight necessary to comply with your own fiduciary duty that you've retained. Recognize that although courts in California tend to afford boards, including CalPERS boards, certainly broad discretion and decision-making and exclusive authority over the administration of the plan and the investment of your assets, it is subject to your fiduciary responsibilities, and it is important to avoid an abuse of discretion. And so I've articulated through this presentation and in this final set of bullet points the main factors that you should consider, I believe. That process is important. Make sure your record reflects the process that you're engaging in, the prudent process, and the fact that, and your exercise of your duty of loyalty with respect to that process. It reflects the education that you've had, your inquiry into matters brought to you, that you have active independent actuarial oversight, active independent investment oversight, and legal consultation and compliance with applicable law. I will not read to you this final fiduciary goal, but it's on the end of all of my fiduciary presentations because I think it sort of encapsulates what I've said to you throughout this entire presentation. And with that, I'm happy to take any questions if board members would like, or pass it on to Mr. Olson.
Okay, I think first we have Director Middleton, and if I can get this to work here.
The only thing I might add to that is that, and I think Ms. Dunning covered it in her presentation, but we are here, staff is here to help you. It's not like you have to figure this all out by yourself. It can seem pretty daunting, but we are here to help ensure that the presentations to you create a sufficient record for you to make those kinds of decisions and to answer questions about do we have enough procedure here? Do we have enough information? Do we need more expertise on this? And we can help you make those decisions.
Okay, I do have a question from Ms. Middleton.
All right, thank you. An outstanding presentation, as always. I want to go back to the issues of divestment. And you spoke that divestment is permitted to the extent that it's fiduciarily prudent. What type of findings would need to be made to demonstrate that divestment was fiduciarily prudent, and what kind of cautions would you give us in terms of conversation or deliberations that would demonstrate that we're not acting in a fiduciarily prudent fashion?
I mentioned the sort of point-counterpoint between diversification and divestment that's in the California Constitution. Diversification states the goal of investing, which is to maximize your risk-adjusted return. And so in the context of divestment, your analysis should be investment-oriented. Are you still able to maximize your risk-adjusted return in a reasonably prudent way, even if you are divesting, as the legislature has said you need to? So you need advice from your in-house and outside investment advisors on that topic, and you need to reassess. And so I think It's an investment analysis.
And is it solely an investment analysis?
I mean, without more specifics, I'd say the general answer is yes, it's an investment analysis. When looking at certain types of investments, you will likely get responses about what your long-term trajectory is as a plan, and therefore some types of decision-making you'll engage in would be prudent for a plan that has the long-term trajectory of a CalPERS, whereas it would be less prudent for, say, an administrator of a 401k plan or an administrator even, or another type of fiduciary who had a shorter term duration.
Thank you.
We had a good example of that several years ago on the tobacco, whether to stay divested from the tobacco industry. Ms. Dunning assisted us on that. We had an extensive record before the board on the investment decision about whether to continue the divestment. We had Ms. Dunning's fiduciary advice on that, and so I think we provided the basis for a fiduciarily sound decision in that case. So that was an example.
Right, and you had a very thorough record of that particular decision in terms of on the investment side.
Okay, thank you.
You're welcome.
Thank you, Ms. Middleton. Mr. Pacheco?
Yes, thank you very much for your presentation, and thank you, Madam President. I'd like to ask you a question about the prudent fiduciary with experience. I think it's page 18. You had mentioned that it's not the standard is not of a prudent layperson, but rather of a prudent fiduciary with experience dealing with similar enterprises. Are you elaborating on the educational component of that? I mean, do we need to, can you just elaborate a little bit more about that and how where that case law is and how, so that it can help us understand, is it the education or is it other experience?
Oh, that's a really good question. The case law, well, they're both very good questions. The case law is the Howard Shea case, I believe I cited in the decision. Mm-hmm. There are prior presentations that I've given, even to this board, where I use the shorthand prudent expert. And I've refined that a bit since then, because the language in that Shea case is prudent fiduciary with expert, and I actually think there is a difference, and it goes to your question and the answer to it. And that is that we all recognize that somebody who's not a lawyer who does public pension law, somebody who's not an actuary who does public retirement actuarial work, somebody who sits on the board and has just been presented with education over time and been immersed in it, is not truly an expert in the way that somebody would be qualified as an expert in court. But you are expected to gain, when you come on the board, you either have some experience or you gain it while you're on the board in the various areas where you have plenary authority. So whether it's investments, disability retirement, actuarial services, pension law, all of those different areas, you have a responsibility to be educated, to get educated so that you begin to have that experience. And some of you come to the board with some of that experience. And which leads to the other part of your question, which I think is a particularly important one to note here, and that is there are those of you who come to this board with a lot of experience in certain areas. And you are put on the board for that reason. You're either appointed because you have certain types of expertise that's recognized by the appointing authority, or you're elected by members because they recognize that you have a lot of deep understanding, say, of benefits. You are to share that with your fellow board members. As sitting on this board, you're to share that with one another. You don't become the expert for the board to whom everyone defers, but you are supposed to share that with one another as a multi-member board. That's why you're here. So it's both that experience that you come with and the experience that you gain through educating yourself that gets you to the point of being a prudent fiduciary with experience.
Thank you very much for that question. Just a correlate to that question is, if you have this experience and you're sharing it, but, and suppose another board member doesn't have that experience, maybe has the minimal amount necessary, is there a timeline in order for that person, board member, to get the experience? Or does it just develop over time? Is there something in case law that says you have to have it within a year or 2 years or 3 years?
I know of nothing in case law that puts a particular timeline on it. However, when you're acting on decisions, you're making decisions, you're participating in the making of a decision that implicates the particular area where knowledge is needed,
yes,
it behooves any trustee to be sufficiently educated to make a prudent decision. And so that's why some boards in their, say, their trustee education policies or elsewhere will say, we'll put in timelines. Within the first year, we expect you to have done X, Y, and Z. There are these conferences or these trainings that we expect you to go through. You need to have 2 hours of fiduciary training annually. You need to have your conflicts of interest training on a regular basis. Those are put into law, actually, because, or at least the ethics for public officials is required for that very reason, to make sure that you're informed of certain things. But as an organization, as a self-governing board, you can impose your own expectations of one another, and personally, as to what should be done. But I would draw a line in the sand before you're making a decision on a particular topic that requires some level of understanding and knowledge. You need to educate yourself, and that means calling the general counsel and getting some additional information before the board meeting. By all means, you should be doing that, or calling your CEO to discuss, or your CIO. That is a really important function that your chief executives have to provide you with, as your chief counsel told you, with that information so that you can engage in prudent decision making.
Thank you very much for that explanation.
Thank you, Ashley. I was actually going to say, so if we're calling our investment consultants or our chief executive officer or CIO, that also to get knowledge about whatever it is we're going to be voting on, right?
Almost certainly. Yeah, that actually I think is your first call,
right?
Okay. To your staff.
You were worrying me a minute there. I was like,
no,
my gosh,
no.
do we
I
need,
wasn't.
like...
No. I didn't mean to suggest you have to go out and to go to all sorts of classes, but. And there's a lot of internal training that can happen, and I'm sure does happen at PERS.
Absolutely.
So that is most certainly compliant in the sense of getting the education you need.
Okay, thank you. Yeah. Frank.
Thank you, Madam President. And I have just a quick question. Actually, it's a follow-up to Ms. Militan's question with respect to divestment. And I'm not sure, I'm not looking at yes or no, I'm just thinking out loud, and I want to ask your opinion. That you said you have an abundance of investment analysis, and you have to seek that, and it will be provided to the board. But is it also possible, it is possible that you got 13 people in this particular board, for example, and out of 13, someone, after they review all the analysis, they have a different conclusion, and that is as prudent fiduciary as could be others. So I guess I'm answering my own question. I just want to hear from you, because it's a very complex issue, and because he still does not really say statutorily, yes, the legislature can mandate, but ultimately the board could have a difference of opinion, and we've seen cases, and I don't want to necessarily go back where we had that situation. Thank you.
Your question implicates a couple of points. One is that you're a multi-member board, and you each may exercise may have different judgments about the prudence of a particular course of action, and that is expected. I don't know that I used the word abundance, but I might have said robust. But in any event, whatever the word was, you need to have enough information to make a prudent decision as a collective, but it need not be a unanimous decision. And the majority will ultimately decide whether to proceed with the divestment mandate that has been required by statute, subject to a fiduciary determination. So what I'd say is, if you go through a prudent process and you have reasonable documentation to support whatever the conclusion is that the board reaches, to establish that you were acting prudently and in the best overall best interest of your members and beneficiaries and the security of their benefits, given all of the different contexts you'll consider with respect to CalPERS, then that should comply.
Okay, thank you.
You're welcome.
Thank you, Ashley. I don't think I'm seeing any more questions. So thank you very much for your portion of the training. It was excellent. And I'm going to, unless you want to introduce Mr. Olson, go ahead.
I have no further introduction, so I will turn it over to Mr. Olson.
Good afternoon. Is this the?
Oh, yes.
Okay.
The clicker.
And that's the one on the right? Okay. I have a PowerPoint. I don't know if it's, she's frantically trying to get it up on the screen. While she's doing that, I will say, unlike Ashley, this is actually my first presentation or appearance before your board. Although I'm not a stranger to CalPERS by any means. I've been under contract for a number of years and have been providing advice to your legal office primarily, although the executive office generally, with respect to some of the topics we're going to talk about today, including conflicts of interest. But I'm happy to be here, and congratulations to the new members. I read that a number of you were new, so that's exciting for you and for sure for CalPERS. So let me talk a little bit, just very briefly, about the objective I want to do here today. Despite the title of conflict of interest, I actually going to talk about a few things beyond just conflicts of interest. We're going to talk a little bit about the Form 700. We'll get to that in a moment. And then I want to talk a little bit about honorarium and the ban on honorarium. Then we'll talk about gifts and some of the rules that relate to gifts. Then we'll get to conflicts of interest, and as Ashley alluded to, we've got two various laws, or I guess maybe Matt did, about conflicts of interest, and I'll touch on both of those. And then a little bit on post-employment. I know some of you just arrived, but maybe some of you are thinking of leaving or whatever, and at that point you'll be concerned about post-employment law, so we'll talk a little bit about that. So it'll be a basic overview. My objective here is not to teach you everything there might possibly be to know about these areas of law, but instead maybe give you enough information that if you're confronted with a particular set of facts and you think back to this presentation, you might say, I better call Mr. Jacobs or Mr. Carlin or somebody in the legal office to see whether or not I can vote on this or participate in it or contact the staff about it or whatever. So that's hopefully my objective. I don't think that's a low bar. I think that's actually a pretty high bar if we can accomplish that much. And I'm happy to take questions, although it appears that your protocol is to wait to the end. I'm equally happy to wait for that. So whatever the chair wants to do, I'm open to that. Let's talk a little bit about the Form 700. So most of you, I'm no doubt, are familiar with it. I suppose those who just got appointed or elected to the board and weren't otherwise public officials in a prior life, this may be something new and different. But obviously, if you're not familiar with it, you're going to become very familiar with it shortly. You are, well, we commonly refer to as Article 2 filers, which basically means that you're in the broadest category of disclosure. Your employees, by contrast, some of them at least, are what we call code filers, and they may have more narrow categories in terms of what they might have to disclose on their Form 700. But for the purposes of each of you, you are in the broadest possible category. So as long as the financial interest that we might be talking about is either located or doing business in California, then you're going to have an obligation to disclose that information. The purpose of the Form 700, other than probably to aggravate you quite a bit, because it's not easy to do sometimes, is to actually avoid conflicts of interest. That's really the objective. And if not for you to avoid them, then maybe for somebody on the staff, or possibly, worst case, I suppose, the public, noting a conflict of interest. And the Form 700 serves that purpose. And it does a pretty good job, although there are at least some circumstances where a conflict can arise even though you're not disclosing it on a Form 700. That's a little beyond our scope today, but it is important that you spend some time working with that. And you're pretty, well, I want to talk a little bit about the things that you have to disclose briefly on the Form 700. So your business interests or investments, as the forms refer to them, are number one on the Form 700. And there you're required to identify things such as stocks, partnerships, memberships in LLCs, sole proprietors, and the like. So any basic business interest that you have, you're required to disclose it. There is a monetary threshold of $2,000, but I suspect that's a pretty low bar to meet, and for most people it's met, and the disclosure is required. You're also required to disclose your interests in real property. There are some major exceptions. Probably the single biggest one is your personal residence, although there's some limitations on that, and I'll try and remember to talk about that in a minute. But otherwise, your real property interest, income that you receive, $500 or more, is required to be disclosed on a separate schedule. And I want to emphasize that income, and for that matter, investments and so forth, can include interests of your spouse and dependent children. So to the extent that they may have income, it's possible that you will have a disclosure requirement. Not on income, I should say, on dependent children, but just on your spouse, but investment interests, certainly. And then finally, gifts. And we'll spend some time talking about gifts, but gifts are reportable if they equal $50 or more. There's a variety of rules that apply to gifts, primarily aimed at restricting the amount of gifts you may receive, and we'll go over those in some detail. The filing of the Form 700 is done on three basic occasions. One is when you assume office. For those of you who just were sworn in or just assumed office, you have 30 days in which to file your assuming office statement. For those of you who are veterans, you of course don't have to now file an assuming office statement. There's an annual statement that is required, as the term suggests, once a year. And then there is, once upon you leaving your position, you're required to file, within 30 days of departing from the board, you're required to file a leaving office statement. It's very important, and I don't take this lightly, but it's very important that you take completion of the form seriously. One of the things I've done throughout my career is represent people in enforcement actions, primarily with the Fair Political Practices Commission, who unfortunately did not take the form seriously. They simply checked the nothing to report box on each of the categories: income, investments, real property, and so forth, and didn't think about it because in their mind that really wasn't either important, or they had concluded that they didn't have anything to disclose when in fact maybe they did. And the reason for, of course, doing that is that a possible enforcement action that could result not just negative publicity but actual monetary penalties, and of course in the worst case scenario even criminal prosecution, although that's probably highly unlikely, but it is theoretically possible, as well as what we call headhunter litigation. So private parties can actually sue you for not properly disclosing something on a Form 700. So needless to say, it's important you take the time and energy and devote the resources necessary to get it right. You are very fortunate, and I've worked with a lot of public agencies that can't say this, but you're very fortunate here at CalPERS to have some really top-notch people in the legal office, particularly, I think, Mr. Carlin, sitting right here behind Mr. Jacobs, as well as your enterprise compliance unit. They have some top-notch people there that can assist you, and I suspect many of you know that because you probably worked with them. But I commend that to you, particularly for the new people or those who've not taken advantage of it in the past. So I want to, yes.
I have to ask a question because you made me think about something.
Okay.
You said assuming office, although if you're a veteran. Well, I'm elected, and I sort of just assumed office, right?
Yeah, so you're a new?
Not really, no. I've been here 8 years, so I'm starting my 3rd term. So no? I got very confused when you said that.
I don't think so. I was talking about the new people.
Okay, only the new people.
Yeah. If I'm wrong on that, I will let you know, but
No, you assumed your office 8 years ago.
Yeah.
So, because...
You don't have to file an assuming office.
Okay.
Form 700.
Just checking.
Yeah.
So I want to talk a little bit about the honoraria ban.
Never have.
I don't know. This can come up in some unusual circumstances, but basically the law as it stands now prohibits a public official, and you, of course, all public officials, from being compensated for giving a speech or publishing an article or making any attendance at a conference or meeting or a like gathering. So that's a pretty broad prohibition. And speech includes really any form of oral presentation, including most common would be seminars or panel discussions that you might attend. Articles, primarily they're thinking of articles that you're paid to publish a particular article. They're not intended to include things like creative works like books, plays, and screenplays. The ban on honoraria was actually imposed in the late 1980s as a result of some pretty serious abuses by elected officials, primarily in the legislature, who were taking advantage of this loophole of basically, in theory, giving a speech and being paid money for that, it becoming income not subject to any limitation at all, even though gifts are otherwise, at that time, certainly were limited, and campaign contributions were becoming limited. So it was a way around these limitations. And the most egregious one was the state senator who met with somebody in the Hyatt Hotel downtown Sacramento and talked about bear hunting in Alaska, and then received $5,000 in an envelope from the person who gave it. Unfortunately for the senator, that person was an undercover FBI agent, but that was the indicative of the way things worked at that particular time, and so the ban came into effect. There are some important exceptions. Bona fide professions, things like teaching, for example, are exempt. So if you do teaching and get paid for that, I used to be an adjunct professor at McGeorge School of Law here. I got some minimal amount of money, but I got paid for that. That would have been exempt if I were a public official because it was a bona fide activity. Travel payments, this is an important one that could affect you. Are exempt, so you can't be paid to give the speech, but folks can pay to get you there. They can feed you, and they can put you at a hotel for your speech or for your participation in a panel or seminar. And I'll get into whether that's reportable or not, but that's something that does not violate the honoraria ban. And then finally, it is possible for someone to pay you to speak and have them donate to a charity. But there are some serious limitations on that. One, you can't make it a condition of speaking, so you can't say, well, I'll come to your conference and I'll speak, but you have to donate money to whatever, the YMCA. And if you do it and they donate, you can't claim a tax deduction personally. And then finally, and I think most importantly, the donor or the person making the donation and paying for you to come can't advise the charity that it's in your name or it's in your honor or it's connected to your speech in any particular way. They can just do it. So, but it is an exception, and I know some people have taken advantage of that. I want to switch to the gift rules. The state law prohibits gifts from a single source. They just adjusted the limits. So those of you who are familiar with the limits, they used to be $520. They're adjusted for inflation. So apparently we've been in an inflationary period, and they went up as you can see, $70 to $590. This is the Political Reform Act, or what is commonly referred to as the FPPC law. So the FPPC administers and enforces this particular limitation. Common types of gifts include meals and beverages, free airfare or other travel payments that you might receive, and there are some exceptions, which I already covered one, but I'll come back to those. Free admission to sporting events, theater, live entertainment, all of those sorts of things constitute gifts, and then rebates and discounts not otherwise received in the regular course of business. So that's sort of the general overall big picture rule on gifts. There is a separate limitation, which is self-imposed by CalPERS under your policies, which says that the Board of Administration cannot accept gifts in excess of $50 from entities doing business or who are likely to do business or seeking to do business with CalPERS. So if that sort of entity exists and they come to you and they offer a gift, you're under your own policies, even though you could, in theory, take it under state law because it's below the 590. You can't if it's over 50 under your own Board of Administration rules. And by the way, this rule, your rule, includes consultants and brokers and intermediaries of such entities. So it's not just the entity itself, but if somebody is an intermediary for that entity and they offer to pay for it, you can't do it. And then finally, there's an even lower limit with respect to placement agents who are registered to lobby CalPERS, and they're, just like all lobbyists, subject to a $10 per month limitation, and so you have to be aware of that particular limit as well. In addition to the gifts, there are a number of exceptions, and I want to go through some of them. I think I counted up today, I think there are close to 25 exceptions to the gift rule, but a lot of them are pretty obscure and maybe don't come into play. Some of them are just common sense, quite frankly. But there's a number of them that I'd like to highlight for you, and I've done that here, and I'll talk about them briefly. So home hospitality. So this is a rule that basically says that you can go into somebody's home, and that would include a vacation home, and as long as they're present, you can have a meal in their house, drink their wine, enjoy the ambiance of their house, and that's not a gift to you. There is one kind of important exception, and that has to do with lobbyists. And you basically can't have it is limited to people who have a relationship to you that is unrelated to your relationship or your connection to CalPERS. So if somebody's inviting you over because they want to do business with CalPERS, the home hospitality rule does not come into play. Otherwise, it's designed basically to not, so you don't have to worry about, gosh, am I getting a gift here because I'm eating a meal? It's a pretty nice meal. Boy, they brought out a nice bottle of wine. You don't have to be concerned about that under the home hospitality rule. There's something called invitation-only events. These are events where you attend, you're invited to come. They're pretty common here in Sacramento, particularly for legislators. I don't know whether you folks get invited to them. They're sort of generally referred to as third house events where people sponsor, they have some wine and cheese and you come in and stop by and you drink something or you have a bite to eat. There's two ways to deal with that. One is it's a pro rata share, which can actually run up pretty quickly. And the other is what you actually consume and drink or eat while you're there. And you have to be, the burden is on you to keep track of that and demonstrate that you did in fact just consume one hors d'oeuvre or have one glass of wine, or maybe you had nothing. A lot of people come in and don't have anything. Wedding gifts, if you are getting married, wedding gifts are not subject to the limit, assuming it's not a lobbyist. So for you folks, that would be a placement agent. If they are a placement agent, they can't give you a wedding gift in excess of the limit, their $10 limit. If you attend a wedding and receive the same cake and meal that everybody else got at the wedding, that's also exempt from the limits. So it kind of works two ways. You're the one getting married, it's reportable, but it's not subject to limit. But you go to the wedding as a guest, you eat some food, you drink some wine, it's not a gift. Nonprofit political fundraisers, this is, I've found it, at least in my practice, to be a pretty common exemption. You are allowed to receive 2 tickets directly from either if it's a political fundraiser, from the campaign that's sponsoring the fundraiser, or if it's a nonprofit fundraiser, from the nonprofit. You can receive those 2 tickets, and those are not gifts to you or the guest that you may bring along. If you get more than that, then you've got a gift, and the value of the gift is going to be the face value of the ticket. I mentioned travel payments a minute ago. They are reportable, but they are exempt from limits. So if you travel to give a speech, for example, you can do that. You can be put up at the hotel the day before, the day of, or the day after. You can be provided meals and free admission to the event.
Well, let me interject right here. We do have a CalPERS policy that CalPERS pays for all travel. And so notwithstanding what Mr. Olson correctly said about what the rules are under the Political Reform Act, here at CalPERS pays for travel.
Thank you, Matt. I thought Mr. Olson maybe was talking about whoever's requesting us to come travel to go to.
Yeah, there could be a circumstance where maybe you're not traveling on CalPERS business. I think Mr. Jacobs' point is that when you do travel on CalPERS business, CalPERS is paying for that travel.
Right, and that's not reportable, right?
Right.
Okay.
Yeah, this would be something you'd want to check with us on as to whether it is for business or isn't for business, whether it's CalPERS business or somebody else's business. Because if you're working in some other field, or you're on a nonprofit board or something like that, and you're being asked to travel for that, that might not be subject to the CalPERS rule.
Right,
So,
and you have ex officio members who are otherwise elected, and
they would have to bill it elsewhere.
Possible
Sure.
as well.
Sure,
In
right.
circumstances where
Gotcha.
that might happen. I want to talk about 2 more exceptions. I don't have them on the slide, but I think they're important. One is family gifts. I mean, that's, to me, is sort of intuitive, if you will, or common sense, that if family members are giving you gifts, those are not subject to limitation, and they're not considered gifts. But there is one thing you have to be a little concerned about, and that would be gifts to a spouse. And those are actually presumed to be gifts to you unless the person has an independent relationship to the spouse. So obviously with a family member, you would have that independent relationship, but there could be other circumstances where somebody gives a spouse a gift and they don't have an independent relationship, in which case the law says it's your gift as the public official. And then the other one is, it is possible to receive a gift, certain gifts, obviously, and donate it to a charity within 30 days, and then it is not a gift to you. And that's such a circumstance where you can pick the charity. You can decide, I want this to go to, to whatever and organization. I want this charity to have this particular gift. And it's not a gift to you. And I've had public officials where that has occurred. And it happens, not maybe that frequently, but it is an exception you can take advantage of. All right, now what we came here to hear about, I guess, is conflicts of interest. So let's roll into that. So there are two laws, as we now know, because we've told you that a couple of times this afternoon. One is the Political Reform Act, or the FPPC law, and the other is Government Code Section 1090, and I'm going to talk about the PRA, or the FPPC law, first. And the general rule, it's just stated up here, but basically, as a public official, you can't make, participate in, or attempt to influence a governmental decision in which you have a financial interest. And those financial interests include those things you reported on your Form 700, right? The investment interests that you had, and whether it's stock ownership or whether it's a LLC
Mr.
membership.
Olson, can you hold on just a second? I missed, did you want to ask a question from, go ahead, Frank.
If it's okay, Madam President, real quick, I just want to make sure that I understand clearly, because this one over here is sort of not new, but the invitation-only events, the third house type of parties. So if you go and you're not eating nothing, then you don't have to report it. If you do take a glass of wine and some cheese and some grapes, how do you itemize? I mean, how do you know whether you?
Well, it's
your limit.
Oh,
is there a 3 glass
wine,
limit?
$6.
Well, that's good because I have to drive, so I can't exceed those 3. So that's
it's referred to as, I think, sometimes referred to as the. Was it drop-in? I almost said drive-by. That's a different rule.
Okay.
There is a drive-by rule. It just happens to do with lobbyists, but the drop-in rule. So if you just drop in and drop out, and by drop in, the FPP seems to view that as just a few minutes, not a long time. You don't stay all night. You don't schmooze for 2 hours or whatever. Then it's not a gift. But you have my point is you have the burden of demonstrating that that's what you did. So some people I know send letters and say, hey, I stopped by your event and I didn't eat or drink anything, and I didn't stay long, and I said hello to people, and then I left. So it's kind of the drop-in rule is the idea.
So an email to the organizer, is that what you're suggesting?
Yes.
Some kind of letter, an email that says, hey, I was there, but I only got 2.5. Just
exactly.
To be clear.
And the reason for that is because the sponsor of the event is usually a lobbyist employer. Not always, but it can be a lobbyist employer. And they're actually required to send notices to people telling them what the pro rata share of the event could be. And that could be a reportable, it could be $150 per person because maybe they had a band there or they had a lot of hors d'oeuvres or whatever, and you had 1 glass of wine and a couple of hors d'oeuvres. And so you were in a position to say, no, but you have the burden and you should write a letter to them.
So real quick, one other one, please.
Sure.
So the lobbyist one, it's common sense, or an elected official. What about if it's a former elected official who's seeking out your office in a future date, non-declared? Yeah. Or declared? Does it make a difference?
Yeah.
You're making it complicated.
Well, I'm sorry, but
if candidates, once they file their statement of intent with the FPPC or Secretary of State, are subject to the gift limits and the gift rules. A lot of people don't understand that because they're not a public official yet. So the fact that you're a former public official and now you're running for elective office, once you file that what's called a Form 501, you've now become sort of a candidate, formally a candidate, and you're subject to the gift limit rules.
Is the 501 the same as the FPPC number?
Yeah, it's an FPPC Form 501. It's a statement. I think it's called the Statement of Intent. I believe
that allows you to start raising
exactly.
funds.
It's the one that says you can now go out and raise money.
So once you file that form, then you're an official.
You can't.
Well, you're subject to you're not an official.
Yeah. No, but you're subject to the limits.
You're subject to the gift limits.
So I just want to remind everybody, we just had our AG training. I think most everybody did. So this is all in there, just FYI. Jose, hold on 1 second.
Sure.
There you go.
This is very enlightening. Thank you very much. I want to go back to the gift rule because I think Mr. Ruffetto talked about it. I want to know about the nonprofit political fundraiser experience events. You know, some of us attend some of these political fundraisers. Like actually in November, October, November, we went to political fundraisers. Can you explain to me how that works then? I mean,
well, the campaign says, Mr. Pacheco, here's 2 tickets to our fundraiser, or maybe it's just an email and says, you're invited to come and bring a guest to my political fundraiser in the case of a candidate, and you can attend it. It's not,
but you can't eat.
You know, partake of whatever's provided there at those events, and it's not a gift. So it's just limited to 2, and the same applies to a charity. So a charity can invite, and let me tell you, the thinking behind it, or the theory is that there's an exchange of consideration, if you will.
Yes.
That your attendance is equal to the value of those 2 tickets that they provide to you. And that's true of a lot of political fundraisers and public officials. They want the public officials to come because it maybe makes them look more credible or whatever it might be. But that's the theory behind it.
And that's with respect to also like a nonprofit as well. Let's say you were asked to go to, I don't know, the United Way, let's say United Way event or something like that.
Right.
It would be the same kind of thing. 2 tickets were offered. You come. You can't partake in the meals or any of the wine, but you can come.
No, you can.
Oh, you
can.
Report it.
You can go to the dinner. You can sit at the head of the table. But they just have to give it to you. What can't happen is somebody buys a table at the United Way and says, Mr. Pacheco, here, or, well, they'd like to say Jose, but here are 2 tickets, right? And I want you to sit at my table. And now you've gotten a gift from the person who paid United Way.
Yeah,
that would be true also of the political fundraiser. It has to come from the charity or from the campaign.
From the overall organization, not the specific.
You got a question there?
Yeah, thank you. Yeah, which is very distinctive. I wanted to be clear on that. Thank you so much.
You're welcome.
We have so many hats. Go ahead, Melissa.
Thank you.
Oh.
Actually, I appreciate the conversation, and sorry, it gets my wheels going too. But I think that's the key of it too, is that a lot of us probably wear different hats. And so, are you talking about when we're invited as a CalPERS board member, or like if I'm, in a different role, invited to attend?
It doesn't matter why you're invited. You're a public official. It's kind of like the fiduciary rule, right? When you're here, you're a public official and you're subject to these rules. So when you're...
but we're a public official in our roles as union people too. So if we go to an event for the union...
But you're still a public official.
Really? Uh-oh.
I don't want to get into fiduciary.
Yours is broader than the fiduciary.
Yeah.
So from the fiduciary perspective, you're fiduciary with respect to your actions for CalPERS related to CalPERS matters.
Yeah.
What Mr.
He's
Olson is
talking about the
saying is you're a
gifts.
public official at all times for all purposes, regardless of whether...
That's correct.
Yeah.
I used
That's
a bad
different.
analogy, which is fiduciary duty.
Yeah.
You're just a public official 24/7. You're subject to these rules, regardless of why you get invited or go, unless
So
an
labor
exception
dinner
applies.
is the whole bit. And I'm going as a DLC president for my union.
Well, there is an exception for activities where it's part of your job, and I believe that would apply here. I need to double check that, but I think
would be
that
nice
would-
because
let me
we're
do
both in
let
that
me do that
situation.
and see if I can double check that. But
All right, I
won't
appreciate
take
it.
the time right now. but
Sorry,
I will
so
get it.
to simplify it and give maybe a different example that not all of us may have, though. Just as an example, like, what if, like, a family member's, like, my son, right? He's in school. And so what if, like, parents and families are allowed, we're giving out tickets to attend the whatever game, you know what I mean? Or something like that, right? You can come and attend the game because the kids are going, or it's like nothing to do with me or something.
You mean like a
right?
Kings game?
Yeah, sure, a Kings game.
They give you Kings tickets unless
Okay.
they're a charity or it's connected to a political fundraiser. You're getting a gift, and the gift
Okay.
is the face value.
Even if
Okay.
all parents are going?
Actually, there is with respect to the, say, the union president situation, it just occurred to me, there is an exception that would apply, and that is you could treat it as income. In other words, your services are being provided as the union president, and in exchange for that, they're paying you just like your income, the salary you may receive as union president. It's part of your duties, and you have to go to this dinner.
So we don't.
I've used that exception quite frequently with a number of public officials who attend events, and they maybe are on panel discussions or whatever for their own organization, and we treat it as income. So and it's not subject to limit. It may be reportable.
So it's reportable on Form 700 is what you're saying?
Yeah,
okay.
but
I get, okay.
Right.
That I get, okay.
Okay. So.
Wait, I got one more question.
Oh, I'm sorry.
I got the state official over here.
Just so now that we've gone down this rabbit hole of gift ideas.
Sorry, Irina.
No. Just a clarification on the CalPERS $50 limit versus the FPPC limit. For those of us who have very distinct roles, so if I'm involved in an activity that has to do with my day job, and receive a gift that I report, is it still subject to the $50 limit because I sit on the CalPERS board? If the entity has nothing to do with CalPERS?
No.
Robert's saying maybe, go ahead.
Did you want to?
Because it sounds like if we have to, then.
Robert wrote the rules, so he can.
I'm really confused.
So I think the linchpin for your question, Mr. Ortega, is whether or not the entity falls under our gift policy, because our gift policy is not as broad for you as the FPPC rules. For the FPPC rules, it's the entire universe of the world unless an exception applies.
Right.
So if the entity you received a gift from didn't fall under our policy, in a nutshell, you could think of it as they're not doing business with us, or they're not the type of entity that could do business with us, then that likely would not be subject to the $50 limit that we have. Okay. And we'd be happy to take a look at it.
Yeah.
I would just add one other thing I think that would be helpful for the board as a practice to think about is if you're planning on doing travel that's not related to the board or that you're not going to be having CalPERS pay for, it might behoove you to reach out to us just to see whether or not how the rules might apply in that particular situation. Our goal is to keep all of you fully compliant, and that's part of the reason why we have the policy that we pay for all CalPERS travel, because the rules get very complicated and it's easy to trip up and make a mistake without any bad intent. I would just also add that for the fundraisers and for nonprofits, for it to be no gift, I think it's only for 501c3s. So there's a variety of nonprofit entities, 501c4s, 501c6s. There is a value attached to those tickets if you get them.
Yeah, it has to be a charity.
Right.
That's
well, and labor is not
a C3.
Right. It's like a 4 or 6.
We're aware of that.
Yeah.
So.
Yeah. So that I wanted to just raise that. So it's always behooves you to reach out to the legal office or Marcy Matter.
So, and you're saying in our official rules with the union, then we would just report it as additional income.
Right. For a service that you provided to the union.
Whatever it costs to pay for that dinner.
You're emceeing the program or whatever it might be at that particular event, or maybe it's a conference that you're at and you're doing it. So in that regard.
I think it highlights something a really helpful thing to think about as well, which is that if you're getting something and you didn't pay for it and CalPERS didn't pay for it, you're going to want to be sure that you understand exactly what exception is allowing you to get that without providing some kind of a payment.
I just thought we had different hats, but.
Yeah, I suppose the default should be, am I getting a gift? And then call the legal office to find out if there might be an exception that would apply.
Okay. You may move forward. I think we're done. Oh, one more question. Sorry.
Again, sorry, a clarification. The focus on exception isn't necessarily, as long as it's reported, right? Like, I mean, you're saying you look for the exception. Sometimes you are accepting a gift, you're going to report it. It's under the limit. And if it's not violating the CalPERS rule. I mean, I thought, my sense of this is about transparency. So if I receive a gift that I'm not concerned is inappropriate in any way, then I'm going to report it, and I don't necessarily need an exception.
That's a perfectly good point.
Yeah.
No, exactly. The only thing I would just add is that while the gift limit is $590 and it's higher now, certain trips and other things, for example, could easily go over that. Even some invitation-only events, depending upon the venue. So that's why it's just always important. Yeah. I figured that's what you have in mind. I agree 100% with. Yeah.
I lost my.
I think you were on 495.
Well, I was going to talk about conflicts of interest, but I don't know what happened to the.
You're done.
I'm happy to talk about it without a PowerPoint.
Oh, it's signed off and everything.
Oh.
I guess you are done.
I don't know what to make of that, so maybe I better speed things up. So the general rule is that you can't participate. We started to talk about the things that report on your Form 700, so the income, the investments, the gifts, and the real property. Those are things that would create a potential conflict of interest. For your purposes, make, as a general rule, would be voting on something. Participate would be comparable, probably, in your case, although maybe it would be in a committee hearing or something like that. Attempt to influence is the one I would be more concerned about, in the sense of calling up the staff, for example, even though your governance policies seem to discourage that sort of activity, but to calling up the staff and suggesting a certain course of action can be participating, because even though the staff may ultimately make that decision, you're attempting to influence that decision by suggesting that they go in a particular direction. As I read your board governance policies, you're supposed to, it's not that you can't suggest things to the staff, it's just that they're supposed to occur in meetings like this or in committee meetings where you do it. But whether you do it there or somewhere else, the question is, are you influencing a particular decision? And if you are, then the question is, do you have a financial interest in that decision? And I want to kind of go into that next, what that might look like. So the financial interest has to both be, or the effect on the financial interest, so your decision or your influencing has to be both foreseeable and material. And so foreseeable seems like a logical, easy to understand word. The FPPC has, by definition, made it really easy to understand, because essentially they've said everything's foreseeable. I mean, as a practical matter, they think everything is foreseeable. So they think that if you call up the staff and suggest they go with a particular vendor, for example, and you might have a financial interest in it, that it's foreseeable that your influence or attempt to influence it's foreseeable that might occur. Materiality is slightly different, and materiality has sort of two prongs. One we traditionally refer to as direct and indirect. There's different ways of looking at it or terminology, but essentially, if the source of the financial interest is involved in the decision directly. In other words, they're seeking to do business. And the next slide, I have a couple examples of how this might work. But if they're participating directly in the decision, they're the applicant or whatever, they're getting the entitlement, they're getting the contract, then the presumption is that it's material. That's the presumption. So it defaults to, you've got a conflict because they're directly involved. If they're not directly involved, then there's a more complex rule that applies that looks at the effect of the decision on the asset, the income, and the assets and the liabilities of the particular source. So that's the dividing line, whether they're directly involved or whether they're indirectly involved. So I've given you a couple of hypotheticals here. These are, the first one is, assume you own stock. And by the way, it could be your spouse that owns the stock, but you have a stock ownership interest in a bank or a vendor, and that particular bank or vendor is seeking to do business with CalPERS. If the decision to retain the bank should come before the board, or let's say before a committee, or possibly you make a phone call to the staff to suggest that this would be a good idea if we invest in this particular, not invest, but we retain this particular vendor, or bank, then there's a presumption that the effect is going to be material. It's also foreseeable, in which case you have a problem because you've just participated in the making of a governmental decision, or you've attempted to influence the making of a governmental decision. Now let's assume that the interest is in an investment firm, and the board decides to increase the type of investments with firms that might benefit from that, but they're not named. So I think an example, a recent example, might be your decision to invest more in private equity. Well, you have a lot of vendors or investment managers who work in private equity sector. It's possible that they're going to get business, and there you have to. They're not directly involved because they're not being named. You're not awarding them the contract or anything like that. They're just potentially involved. In which case, you then have to go down this other analysis to figure out, could it possibly impact that particular investment firm. And on foreseeability, you would, particularly if they were somebody already doing business with CalPERS, I think they would meet the foreseeability test. So then the question would be, well, if they got the business, would it have an effect on their assets and liabilities and resources? And it's a high standard. The test varies, but we don't need to get into the details of the test, but it does vary. But it could be that you have what we call an indirect material effect on that source of income. The bottom line, I think, is that if you have investments, and particularly investments, but income could also do it, and you are aware that that source is doing business or involved here at CalPERS in providing services, then you should really take it up with the legal office before you get very, very far down the road to make sure that you don't have a conflict of interest and don't inadvertently violate the law. So I'm going to switch over now to Government Code Section 1090. So 1090 is different from the Political Reform Act, the FPPC law, even though the FPPC now has the ability to enforce that one. But it's different in a couple of very key respects. One, it's limited only to contracts. So there has to be a contract involved, meaning like you're going to hire a particular vendor, or you're going to enter into an agreement with an investment manager, or you're going to invest money with a certain fund or whatever, but it has to be a contract in order for the conflict to arise. And I would say the other significant difference is that violations of Government Code Section 1090 are felonies, whereas violations of the Political Reform Act are misdemeanor, are rarely prosecuted, but there are a number of instances where Government Code Section 1090 has been prosecuted, primarily by local district attorneys who have jurisdiction over it, usually involving local public officials. So it's different in that regard, and therefore more serious. There's a kind of a third distinction, which is in the Political Reform Act, the FPPC law, you can abstain as a general rule, and you're fine. The board can proceed and do whatever it wants to do with the particular vendor. With 1090, unless there's an exception, and I'll talk about those in a moment, the general rule is that your conflict is extended to the entire board, and so the CalPERS can't actually enter into the particular conflict or into the contract because of your conflict. It's presumed to exist throughout the board, and the idea being that, yeah, you abstain this time and somebody else abstains next time, and I'll scratch your back, you scratch my back. The 1090 doesn't operate that way. It says you cannot, as a board, act because of one particular board member's conflict of interest. Now, there are lots of exceptions to what I just described. I don't know, last count, I think there's well over 30, maybe 40 exceptions. They fall into two categories. There's non-interests and remote interests. Non-interests are kind of like the name implies, they actually aren't conflicts. So if you, for example, a good example would be you own less than 3% of the stock of a company. That's a non-interest. So you could actually have a conflict under the Political Reform Act, but not create a conflict under Government Code Section 1090. Remote interests are a little different. They allow you to abstain, just like the Political Reform Act, and so the board can act, and there's a certain limited number of remote exceptions. But if 1090 is a difficult area, and if you sense that you're anywhere close to that, you absolutely need to get involved with the legal office before you go down a 1090. And with respect to your hypotheticals, did you want me to answer them now, or?
Sure.
No.
If you'd like to, you're welcome.
I didn't think to give you one, so.
Oh. You don't need to.
So I think we're on, there we go, final slide. So I want to talk quickly about post-employment. There's a number of rules that apply to you if you're leaving CalPERS board. First of all, if you're still here, you're prohibited under the Political Reform Act, the FPPC law, from attempting to influence a decision in which you have a prospective employer on the line. So you may not own any stock, you may not have any income from them, but it operates the same basic way. You're negotiating with them, actively negotiating a job with them once you leave here, and you can do that, but you just can't make a governmental decision that would impact that particular prospective employer. Then there are 3 specific FPPC rules that apply to you folks in particular and other agencies such as CalPERS. One is there's a 2-year ban on being paid to give advice or consult with somebody. So somebody comes to you and says, hey, I'm not asking you to go talk to the board, I'm not asking you to go talk to the staff, but I need, you're been on the inside, you know the people, you know how it works over there. Let us pay you and get advice from you on the best way to approach them and how we ought to do it. You got a 2-year ban, you can't do that for 2 years. After 2 years, you could do it. Then there's a 4-year ban for representing someone. So here, it's not aiding or consulting with them or advising them. Now you're going to come down and meet with the chief investment officer about this deal. Well, that's a 4-year ban. You're prohibited for 4 years from doing that. And then finally, there's a 10-year ban on you becoming a placement agent for CalPERS. So that's the other ban. Those are the bans. I'm happy to answer questions, although it's late in the day.
I do have one more.
We do. Okay.
So hold on a second, Lisa. Ms. Middleton?
All right, thank you. I want to go back to the 1090 applying to the full board. If I'm understanding what you're saying, board member A has a conflict, recuses him or herself, but that's not good enough.
Yeah, unless it's a remote interest. And there are lots of remote interests that might come into play. So we'd have to know what the facts were relative to that individual's conflict of interest. But if the remote interest did not apply, then you're stuck.
Define for me a little bit what a remote interest is.
Oh, gosh, I did not. There are so many of them. Robert, do you think of one off the top of your head? There's.
I'm trying to think of a good salient example, Ms. Middleton. But what maybe rather than give an example of one of the remote interests, what I would say is that the situation essentially is if a non-interest doesn't apply, so it's not a de minimis interest, and a remote interest doesn't apply, then the full board is potentially stuck and is not able to move forward with the contract. And the rest of the agency is as well, the staff as well, which is one of the reasons why it's difficult, for example, for the board to have currently employed financial people who are working for the big firms, because we have contracts with almost all of them, and that forecloses a lot of those from coming up.
Right. Second question in this is post-employment. This applies to organizations that are attempting to do business with CalPERS or would it apply to any organization that CalPERS might have an investment in?
You're talking about the post-employment rules? Well, it bans you from accepting compensation to advise somebody, a business entity which is attempting to get a contract or business with CalPERS. So I'm not sure, maybe I don't understand your question, but that's the rule. So if the entity that wants to pay you for advice is going to be seeking business with CalPERS, then these various rules would come into play.
So would that apply to a firm that CalPERS has invested in and has long-standing investment relationships in?
I would say yes, it would. So, yeah.
The one thing I would add, that Lance, tell me if you disagree, is these rules are primarily designed to protect CalPERS from the former board member, if you will. If it was work that was unrelated to CalPERS, other clients other than us, these rules would generally not be triggered.
That's right. I mean, you could be hired by somebody who's doing business with CalPERS to advise them on something completely unrelated to CalPERS. That's not prohibited.
Is that it? Well, I want to thank you, Mr. Olson, for breaking this all down for us at the same time as kind of confusing us.
Well, as I said at the outset, the goal here wasn't to give you to learn everything. The goal was to just think, oh, maybe there's a problem here and I better call Matt.
For sure, and we appreciate that. So we'll either be calling you or Robert, I'm sure. Thank you both very much, Ashley.
Thank you.
We really appreciate it as usual.
Thank you.
And Lance, it was good to see you here. I see your name all over the place. I worked with Yvonne for a long time, so I've never actually seen you or met you.
I was thinking when I read your bios, I was going, oh, have we met?
No, actually we hadn't, but. All right, so I'm going to go ahead. Wow, 4:30. I'm going to call for a 10-minute break, not a 15-minute break, so we can get moving. And then we're going to go into closed session. So right now we are currently recessed and going into closed session at 4:40. So it's a 12-minute break. Woo.
And at that point, we're going to handle the items that are listed on the closed session agenda.
We actually have to get approval to meet in closed session. My bad.
Okay.
So everybody sit down. We have to get approval. So before we adjourn into the closed session, the board needs to approve meeting in closed session for our information security roadmap. The Bagley-Keene Open Meeting Act requires at least 2/3 of board members present, and we have a quorum to vote in approval to hold a closed session to consider matters posing a potential threat of criminal activity against CalPERS property or equipment, including electronic data, and where disclosure would compromise CalPERS activity. Based on consultation with our legal office, discussion concerning CalPERS information security roadmap qualifies for this closed session exemption. And after the closed session, the board will briefly report out in open session that we met under this exception, and if any action had been taken. What's the pleasure of the board?
Approval.
Okay, it's been moved by Mr. Miller, seconded by Ms. Ortega. All those in favor, and we're going to have to do a roll call because we need a 2/3 vote, so.
Teresa Taylor.
You can go past me, go ahead.
David Miller.
Aye.
Lynn Paquin for Malia Cohen.
Aye.
Frank Rufino for Fiona Ma.
Aye.
Lisa Middleton.
Aye.
Arena Ortega. Jose Luis Pacheco.
Aye.
Kevin Palke.
Aye.
Ramon Rubalcaba. Yvonne Walker. Melissa Willette. Gail Willis.
Is not present. All right, so the ayes have it at 100%, so we're good. We will adjourn, recess for now and come back at 4:40 for closed session. Thank you. Session. We met in closed session. Hold on a second. Let me move my page here. Today, pursuant to Government Code Section 1126, Subdivision C 18A, during the closed session, the board received an update from management on CalPERS Information Security Roadmap. The board took no action. This adjourns the board educational day. Thank you for joining us. And we'll see everybody at 10 a.m. tomorrow. And hopefully be done on time.